Bug Day is truly unique. A full day of education for anyone interested in infection prevention control, communicable diseases, and infectious diseases in our community and healthcare settings. For the past 25 years, I've tremendously enjoyed being involved with Bug Day as a presenter, host, and organizer. Our presenters are world-class thinkers. If you're interested in the prevention and control of communicable diseases, Bug Day is for you. Bug Day will be live streamed on October 19th, 2021. Visit our website for the complete agenda and to register. It is an opportunity to update your knowledge and skills, and it is accredited for all healthcare professionals. In addition, the 25th Annual Bug Day is free. Did I say accredited? And the topics are all timely. Together with the Bug Day Committee, I'd like to invite you to the 25th Annual Bug Day. See you there.
Good morning, everybody. My name is Adam Topp. I'm the CEO of Shared Health. I'd like to begin today by acknowledging that the health services across Manitoba are provided in facilities located on the original lands of the First Nation, Inuit, and the homeland of the Métis Nation. Manitoba's health authorities respect that First Nations treaties were made on these territories and acknowledge harms and mistakes. We dedicate ourselves to collaborate in partnership with the First Nations, Inuit, and Métis peoples in the spirit of reconciliation. It's a pleasure to be with you today, albeit virtually, for this, which is the 25th anniversary of the this amazing Bug Day that actually started as a nursing education day at the Health Sciences Center some 25 years ago. It was the original concept of two educators, Joan Porteous and Joyce Mora. It is now an interdisciplinary accredited program, and we have almost, or more than, I'm told, 2,000 participants today. So really happy to have you all here today on this 25th anniversary. I did want to say thank you very much for the efforts of all the healthcare professionals throughout the pandemic. It's been a difficult 19 months for many, many people, but I want to especially thank the dedicated professionals who work in the field of infection and prevention control very much for the work over the last 19 months. I also want to introduce you to John Emble, Dr. John Emble. John says he requires no introduction at all, but thought I'd better give you one, just so you know how much his expertise is nearly limitless and his energy has benefited Bug Day over the last many, many years. John's a specialist in internal medicine and infectious diseases. He's the medical lead for infection and prevention control at the Winnipeg Regional Health Authority. And he served as the medical infection control lead for our provincial integrated COVID-19 response. He's a professor of medicine at the University of Manitoba and also very active in teaching and research and clinical practice. He's recognized for his scholarly activity, for his mentorship, and he's established student awards to support advanced studies in infectious diseases. I actually know John as the driving force behind Bug Day, and of course I first met him as Soapy and in spandex, and that's how I met Dr. Emble. He was clearly in spandex and on calendars and really promoting Bug Day. I think, John, that was the first time I ever saw you was in spandex, so there you go. And you're not wearing it today, so I'm a little disappointed. Your Soapy costume is not on. But I want to thank you for all your energy in this Bug Day, and I'm going to turn it over to you now. And thanks very much, John.
Well, thank you very much, Adam. I'd like to welcome everyone to the 25th Annual Bug Day. And just for clarification, at this moment, there are approximately 2,593 participants. The program would have never occurred without the involvement and support of the Planning Committee, And it's a collection of very dedicated people who go through the hundreds of suggestions every year for different topics. The Health Sciences Center leadership who have tolerated and over time supported Bug Day, the staff of Shared Health, and of course the University of Manitoba, specifically the Department of Continuing Professional Development, who have helped with every aspect of this program. I'd like to remind you that to receive your continuing professional development credits, you must register for the program. Remember, it's completely free, so there's no cost to you, just overwhelming benefit, knowledge, and continuing development, continuing professional development credits. I want to say a very big thank you to the staff of the audiovisual department who have helped with every aspect of this. And last year, Bug Day was the first time it was excuse me, virtual, and we somehow managed to pull a rabbit out of a hat, and it went flawlessly. We're hoping for a similar performance this year. With the exception of the Grand Rounds presentation given by Dr. Karen Doucette, we'll introduce in a moment, all of the presentations for Bug Day are 15 minutes in length. And the reason for that is that we're all adult learners, and most of us live and think in 15-minute blocks, not dissimilar to what happens with situation comedies, 15-minute blocks between commercial breaks. So our attention spans are limited, and this way, a 15-minute presentation just gives you the meat, none of the extra filler that people add to fill an hour. You're just focusing on the meat. As you know, the topics are selected 1 year in advance. So I would ask all of the participants today to fill out the evaluations and give us ideas for topics. I'm running out of ideas, so I need ideas. We try to avoid controversy for Bug Day. We just want to focus on knowledge, the sharing of knowledge, and fun. I once again thank everyone who made this program possible, and I wish everyone a wonderful day. I'm going to switch gears and introduce Dr. Karen Doucette. Karen is someone that we know very well at the University of Manitoba. Karen is a professor of medicine and divisional director of infectious diseases at the University of Alberta. With regards to Karen's education, she undertook her Bachelor of Science in undergraduate medical training at Dalhousie University in Halifax, Nova Scotia. Subsequently, Karen undertook internal medicine training at Queen's University and subspecialty training in infectious diseases at the University of Manitoba, and therefore Karen's connection to Manitoba. Additional subspecialty training in viral hepatitis and liver diseases was undertaken at the University of Manitoba. And the pièce de résistance is that Karen undertook a clinical and research fellowship in transplant infectious diseases at the Massachusetts General Hospital in Boston. Dr. Doucette joined the University of Alberta in 2004, and in 2015 was appointed the divisional director at the University of Alberta Infectious Diseases and Edmonton Zone Clinical Section Chief for Infectious Diseases. Dr. Doucette's clinical and research interests are in infections in immunocompromised hosts, particularly solid organ transplant recipients, and persons who have viral hepatitis. Karen's published over 60 peer-reviewed manuscripts, and as well as authored or co-authored numerous book chapters, and is a well-respected national and international authority in transplant infectious diseases. Dr. Doucette has delivered many international and national scientific symposia, and has given at least 200 continuing professional development sessions. And of course, the crowning moment in Dr. Doucette's career will be presenting at Bug Day. In 2016, Dr. Doucette was inducted as a fellow of the American Society of Transplantation. And in 2021, Dr. Doucette was awarded the Canadian Society of Transplantation's Clinical Recognition Award for contributions to program development, innovation, and education, notably in the area of viral hepatitis and organ donation and transplantation. Dr. Doucette will now present the medical grand rounds portion of Bug Day with her presentation entitled Known or Increased Infection Risk in Organ Donors, Precision of Language in Medicine Matters. And just for clarification, Dr. Doucette's presentation will be an hour long. Dr. Doucette will have a brief period of questions and answers at the end. And Dr. Doucette, we thank you for joining us today virtually from Edmonton.
Thank you very much, John. So I'm going to share my screen here and hope that it appears correctly with my new setup this morning. Yes?
Yes, that looks great.
Okay. Okay, so thank you very much. I'm very pleased to be virtually here, as I said, and as John said, I previously lived in Manitoba and Winnipeg for a number of years, and it would have been nice to be back with you all this morning, but happy to be here virtually. I am going to talk for I'm going to target about 45 minutes or so. So hopefully, despite the indication about adult learners and attention span, I can keep people engaged, talking about increased risk infection donors and a few different topics, hopefully to keep people on their toes. So these are my disclosures, mostly related to clinical trials that I am involved in, and the objectives, which are, I'm going to talk a lot about the current standards of organ donor screening, and a little bit of comparison between recent changes in the US system and how we screen organ donors and utilize those results in Canada, and how that may be holding us back a little bit, and the potential for some change and improvement in the Canadian system. I'm going to talk specifically really about bloodborne pathogens and some paradigm shifts that have occurred over the last number of years related to hepatitis C, HIV, as well as hepatitis B infected donors, and really to talk about how we communicate risk to potential transplant recipients. I think many of us are very attuned to the public's perception of risk, and challenges in communicating risk and relative risk in relation to the COVID pandemic. And this is another example about how important it is to try to communicate risks clearly and objectively. So overall, when we think about organ donor screening, so a lot of the paradigms and thoughts around organ donor screening have translated from the blood donor screening, but it really is quite a different level of risk and risk benefit compared to blood. So organ donation is a very limited resource, and there are very tight time constraints around making decisions about utilizing particularly deceased organ donors. So the goals of screening really are threefold. A lot of the screening we do is really intended to stratify risk of infection and develop optimal preventative strategies. And I'll talk more about this later on today. So CMV, cytomegalovirus, is one good example there, where we know this is a risk of transplantation and we can optimize preventative strategies. Some screening is done to identify and initiate treatment prior to donation and transplantation. So here a good example would be bacterial infection. So a donor that has passed away from, for example, pneumococcal meningitis and may have pneumococcal bacteremia. Here we can decrease the risk by treating the donor, treating the recipient, and essentially eliminate that risk. And then finally, to identify conditions which may disqualify the donor as a potential donor for transplantation. And these are increasingly rare. So the little picture up here is rabies. So we don't want to transplant organs from a donor that has been infected with rabies or has an otherwise unidentified central nervous system condition. This is associated with extremely high risk to the recipient. But bloodborne pathogens, when I started in practice, and as John said, it's 2004 when I started at the University of Alberta in transplant infectious diseases, HIV, hepatitis C, and to a large degree, hepatitis B were essentially contraindications to organ donation. And much has changed over that time that allows us to utilize donors with these infections very safely. And increase the donor pool. And so that's what I'm going to focus on today. So just to put a little bit of perspective around this, when we think about the scope of donor-derived infections under the current screening paradigms, which again, I'll show you a little bit about sort of the standard screening in organ donation in Canada. But overall, donor-derived infections are fairly uncommon, range in the literature between about 0.2 and up to about 1.7% of organ transplants. When they occur, however, they are associated with a high risk of mortality up to about 40%. With increased standardized approaches to screening and increased review of transmissions when they occur, we're learning more about how to lower these risks. So the Disease Transmission Advisory Committee in the United States was set up in 2008. This is a passive reporting system, although increasingly, again, over time, we know that reports have increased to this agency in the United States, where organ donation is all centralized. And this was described in July 2020, reports from 2008 to 2017. And here you can see that unexpected donor-derived disease was very rare. So as I mentioned, there are a number of times when we transmit infections to organ recipients, knowing full well that this is going to occur, but we have strategies to reduce this, most notably cytomegalovirus being very common. But when unexpected transmissions occur, they're overall rare, so about 0.2% in this report. And this was actually a mix of infections and malignancy. Most of these are infectious diseases. But again, when they occur, they are still associated with high mortality. So I think it's important to keep in mind when we're talking about donor-derived infections that they're overall rare, and we need to keep that in our conversations with patients who are awaiting transplantations, where they are facing many, many, many other risks, including, of course, death from their underlying disease while they wait for an organ transplant, and need to very clearly balance these risks. So in Canada, so this is the infectious disease screening of organ or islet cell donors in Canada. And you can see that there are a number of mandatory screening tests. So these include screening for HIV, hepatitis B, and hepatitis C, as well as a number of other infectious diseases like toxoplasmosis in heart donors, syphilis, the cytomegalovirus, Epstein-Barr virus. And then there are other tests that are considered recommended, so they're not necessarily required. And these, as I say, I'll talk a little bit more about when we talk about HIV and hepatitis C and using nucleic acid testing to enhance our ability to detect early infections in organ donors. So if we go through, I'm going to talk about sort of from least common to most common scenarios in bloodborne pathogens in organ donation. So first of all, I'll talk a little bit about HIV positive organ donors, where these are now being considered for HIV positive transplant recipients. This is really very uncommon. So the HIV Organ Policy Equity Act, or the HOPE Act, which was passed in the United States in 2013, actually, which was not that long ago, allowed transplantation of organs from HIV-infected deceased donors into HIV-positive recipients under research protocols, which prior to that date, it was actually illegal to transplant organs from HIV-infected organ donors. So this on the left-hand side shows you an early experience from South Africa, published in New England Journal of Medicine in 2015. There were 27 kidney transplants done from HIV-infected donors into HIV-infected recipients. And this was really the first demonstration of the safety of this approach, where graft and patient survival was very similar to those who are HIV negative. This, of course, is in South Africa, where the majority of donors, in fact, I think all of the donors, had not been on antiretroviral therapy, very low risk of resistant virus in the background. And so these are some of the questions, particularly in North America and Europe, when this is considered, and concerns about HIV superinfection being a concern due to resistance and secondary infection with another strain. So this was in Lancet HIV actually very recently at the end of 2020, a small publication, 14 recipients of HIV-infected donors into HIV-positive recipients, where they demonstrated that superinfection was really not a significant clinical concern, where the recipients were on antiretroviral therapy. They did not see evidence of breakthrough infection or concerns with resistance. But there is ongoing study of this in the United States. As they say, this is relatively uncommon, with only a small number of centers throughout the United States participating in ongoing research into the area of HIV positive to HIV positive organ transplantation. In Canada, we actually have very small numbers of HIV positive individuals listed for transplant. They are considered candidates for organ transplantation, meeting all of their criteria, but it's so uncommon that this isn't routinely a significant consideration in Canada. Hepatitis B, on the other hand, so hepatitis B is another bloodborne pathogen for which there has been a lot of change over time in how we think about safe utilization of organ donors. So there are really two classes of risk. So the anti-core positive, meaning this is somebody who's been exposed remotely to hepatitis B and has themselves managed to resolve the infection, but their hepatitis B does remain latent in that donor. This is, as I say, relatively common. About 5% of the population in Canada has been exposed to hepatitis B in the past. The hepatitis B surface antigen positive donor is much less common in North America and in Canada specifically, with less than 1% of the population being surface antigen positive. And when we look at sort of the demographic of donors, deceased donors in particular, it is even less common. These carry very different risks. So the anti-core positive donor, as I say, is a little bit more common. We utilize these organs routinely. This is not considered a contraindication at all to donation, but this is one where we can mitigate risk. So the risk is very different when you look at liver, utilizing livers from such an organ donor. This is the site of latency of the hepatitis B virus. And so the risk of transmission here is very high. Upwards of about 80% of liver donors who are anti-core positive will transmit, and the recipient may become hepatitis B surface antigen positive in the absence of prophylaxis. This is a consensus guideline that I worked with a multidisciplinary group in the American Society of Transplantation a number of years ago. And essentially, these livers can be utilized into any recipient, but most often they do require long-term antiviral therapy. This risk persists lifelong as the latency of hepatitis B remains within that donated liver. The non-liver, so kidney, lungs, heart, organs from a hepatitis B core antibody positive donor carry very, very low risk. So there is less than 5% chance that organs from such a donor could transmit hepatitis B to the recipient. And if that recipient is vaccinated for hepatitis B or has themselves been exposed to hepatitis B and is immune on the basis of prior natural infection, in fact, the risk is negligible and there is no intervention needed. Even if the recipient is completely non-immune, so never exposed to hepatitis B, and either not vaccinated or more often a non-responder to vaccine, there is an extremely low risk of transmission, which only occurs if that donor actually has detectable hepatitis B in the bloodstream, which is in less than 10% of donors who are carrying anti-core. So overall, this is a scenario where we need to examine the characteristics of the donor, the characteristics of the recipient, but can essentially eliminate the risk of hepatitis B transmission from anti-core donors. And given that this is quite common, this really opens up a significant proportion of donors when there remains an organ shortage. So this is a recent publication from 2020 also, again through this US Disease Transmission Ad Hoc Committee, which tracks transmissions in the United States. And over a period of 2009 to 2017, they identified only 25 cases of proven, probable, or possible transmission events. And so this is in over 300,000 transplants. So you can see that this is a rare event when these organs are routinely utilized. And in the majority of cases, in fact, the transmission occurred where there was likely some lapse in the follow-up. Either individuals did not receive antiviral prophylaxis where we know they should have in order to limit the risk, or it was stopped early for a variety of reasons. So very effectively prevented when we're following the appropriate interventions to lower the risk of transmission. The hepatitis B surface antigen positive donor is a bit of a different story. So as I say, these donors are much less common in North America, a little bit more common in parts of Europe, and the majority of the data, which is in case reports and small case series, is actually from Asia, where hepatitis B chronic infection is much more common. But it still remains limited to case series in heart and kidney recipients, where there have been demonstrated reasonable outcomes comparative to transplantation with surface antigen negative donors when antiviral prophylaxis is used with hepatitis B immunoglobulin and nucleoside analog antiviral therapy. But there is still a small risk of transmission. Particularly, a number of these studies use older nucleoside analogs such as lamivudine or short course therapy, which again, although the data are limited, generally in Europe and North America, we would use more potent nucleoside analogs and continue this therapy indefinitely to minimize the risk. Liver transplant, similarly, again, the liver is the site of chronic hepatitis B infection. And so the data here are largely, again, in Asia, where many patients who are undergoing liver transplant are actually undergoing a liver transplant for hepatitis B. And so most of the data are in surface antigen positive donors into surface antigen positive recipients. And again, outcomes here appear to be relatively good in small case series and with intermediate term follow-up, with the exception of those who are co-infected with hepatitis D virus in the donor, where hepatitis D virus can go on to be unchecked and result in poor outcomes. But in the surface antigen positive alone donor, pretty good outcomes overall. In lung transplant, so this is a case report that we reported from our center about a year and a half ago, we were offered actually from the United States a lung from a surface antigen positive donor. Up until this point, there were no reports of lung transplantation from surface antigen positive donors into negative recipients, but we did have a man who was 63 who had a new diagnosis of very rapidly progressive pulmonary fibrosis and was in our ICU with a very narrow window for transplantation. And so following a discussion with the family, who at the time he was intubated, and so it was his family who was making decisions for him, we did proceed with utilizing the lungs from this donor. We did not have all of the data, and so again, this is one of the challenges with organ donation and transplantation is you don't necessarily have all the information you might like in the short time frame you have to make the decision. We knew that the donor was surface antigen positive, and we knew that they were E antigen negative, but we did not have a hepatitis B viral load at the time. So this recipient received standard immunosuppression as well as initially received hepatitis B immunoglobulin, along with antiviral therapy with entecavir at the time of lung transplant. We subsequently, about a week after transplant, got the hepatitis B DNA back from the US Organ Procurement Organization, and it was very low at only 38 IU per ml. So in fact, at that time, we made a decision to stop the hepatitis B immunoglobulin and continue on with entecavir. And this recipient did quite well from a hepatitis B perspective. He did have some other complications along the way, but left hospital, and at a year post-transplant was doing very well with a fully suppressed hepatitis B DNA, negative surface antigen. He had converted, or at least had passive, it's difficult to say at this point, but was positive for anti-core, suggesting perhaps that he had an abortive infection with hepatitis B, but remained surface antigen negative and had a fully suppressed DNA. And so we'll continue, the plan is to continue indefinitely on entecavir. We looked in the US data set on lung transplantation, and overall, this has occurred very uncommonly. So only 23 cases in thoracic organs over this 10-year period. So it remains uncommon in North America, but certainly can be considered in certain circumstances, particularly as in this case with a very high risk recipient who otherwise would likely have passed away. Hepatitis C. So this has been a very hot topic over the last number of years, is utilizing hepatitis C viremic organ donors. And this has really come together with these three factors. So one is the ongoing gap in organ transplantation, which is not new. There are far more candidates for organ transplantation than there are donors available. But in addition, there has been in North America the opioid crisis and rising hepatitis C incidence, as well as deaths due to overdose, and specifically organ donors who have died from overdose, and the development of safe, effective, curative, all oral, simple therapies for hepatitis C. So really the coming together of all of these three circumstances have led to an increased utilization of hepatitis C viremic donors. So why would we consider this when, as I say, when I trained and when I started in practice, and for in fact the first 10 years or so of practice, this was an absolute contraindication to organ donation. But what we know is that, first of all, this is older data now, but in the US, if a recipient were to consider a hepatitis C viremic donor, their wait time goes way down. Now, this is quite variable depending on the area of the US, or in the US versus Canada that you live, and the number of donors that become available that have hepatitis C. But if these are donors that you are willing to consider that may not otherwise be utilized, and this can certainly shorten the wait time for transplantation and improve overall outcomes. And then, as I say, if you look at hepatitis C viremic donors, so the top line here is donors due to overdose, and you can see particularly around 2010, this very large uptick in organ donors who have died of overdose, and they have a obviously significant rate of hepatitis C viremia. So this is an increasing portion of the organ donor pool that's potentially available. In addition, these donors are now younger and overall have therefore less comorbidity, and organs tend to be of higher quality overall. So you can see again here around 2013 or so, there's a crossing of the curves. So these are hepatitis C viremic organ donors who historically were older when the epidemic was largely related to blood transfusion and remote injection drug use. But now currently, where it's more active recent injection drug use and overdose deaths, the average rate or average age of organ donors with hepatitis C is about 35 compared to 41 for the hepatitis C negative organ donors. So these tend to be very good quality organ donors otherwise. So this is the first case of a hepatitis C viremic organ donor that we transplanted. This was in 2016 into a negative recipient. So this was a young woman, 23 years old, with cystic fibrosis, who had been relatively stable, and as often happens in young CF females in particular. She had an acute deterioration and was hospitalized and was now BiPAP dependent on high flow oxygen. She was known to be colonized with a number of fairly typical pathogens, Pseudomonas, Stenotrophomonas, and Scutosporium. And this is here because this shows she's relatively short, small female, meaning that it's challenging to find lungs to fit her because donors are more often male and bigger. And so lungs, when you're looking at a size match as well, there's a challenge. And she's blood group O, which again, increases the challenges in trying to find an appropriate donor. And so this donor became available, also young 35-year-old woman who died following an opiate drug overdose. This donor had been first identified to be hepatitis C positive just 7 days prior to the overdose and was documented to be viremic. So again, we had a discussion with the recipient and family about the potential to utilize this donor and treat with hepatitis C direct-acting antivirals post-transplant, and went ahead with this transplant. You can see this is her original chest X-ray with extensive changes related to cystic fibrosis and quite severe scoliosis as well. And so we went on to report our series of hepatitis C viremic donors into negative lung transplant recipients in the American Journal of Respiratory and Critical Care Medicine in 2018. And this was the first series in lung transplantation in these 5 individuals. And you can see this patient I just presented is case 5 here. Notably, I would say, so there's a wide range of ages, 23, this youngest, up to 65. They all had double lung transplant. They all underwent what would be standard immunosuppression in our center. You can see the time to start therapy post-transplant was variable. So about 3 weeks or so for this young woman, but actually up to almost 3 months in this case. Due to a number of complications, lung transplant patients tend to be quite complicated, have long ICU stays. A number of these patients had issues with GI bleeding, et cetera, that delayed therapy. But ultimately, all were treated with standard courses of hepatitis C therapy, and all were cured. So hepatitis C viremic donors into negative recipients, there were 2 landmark trials in kidney transplant that were published, one that they're called the Thinker and the Expander trials in 2017 and 2018. So one looked at hepatitis C treatment initiated once the transplant was completed and viremia was detected in the recipient, and on average, that viremia is detectable by day 3 in virtually all of recipients with essentially universal transmission. And they were treated in this trial for 12 weeks. And then the Expander trial, which used sort of a prophylactic approach in that they initiated antiviral therapy prior to the OR, but they then did continue out for a total of 12 weeks, a standard course of antiviral therapy. Each of these had 10 patients, 10 kidney transplant recipients, and again, all were cured. There are now multiple case series that are published in thoracic and liver transplantation. And I've just listed some of them here, but really overall excellent outcomes with close to 100% cure rates across all organ groups. There have been a couple of trials that have looked at the possibility of shortening therapy if treatment is initiated very soon after or just prior to transplantation. So this is a trial done at the Brigham and Women's in Boston in thoracic transplant recipients, both heart and lung. And so here what they did was they initiated, not prior to the OR, but immediately post-transplantation, the first dose of sofosbuvir plus velpatasvir. And they completed here an abbreviated course of only 4 weeks of therapy. And so when this was published, They had transplanted a total of 44 individuals, but had follow-up data for 35, and 35 of the 35 were cured of hepatitis C and had a documented sustained response. So demonstrating really this proof of concept that you can shorten the course of therapy when you give it very early after transplant. This study is actually from Toronto, from Jordan Feld and colleagues. And so this enrolled patients undergoing lung, heart, or kidney transplant to receive glecaprevir and pibrentasvir for hepatitis C therapy, plus the addition of ezetimibe, which actually acts as a hepatitis C entry inhibitor. And this pilot study included 30 recipients from hepatitis C viremic donors. They gave the first dose just prior to the OR and then completed only 7 days following transplant, and all 30 of these individuals were cured. So again, demonstration that you can shorten antiviral therapy if given early. We're expecting to see a larger cohort actually presented at the upcoming American Liver meeting in the next few weeks. So this shortening of therapy appears to work in certainly a cohort of patients. It's currently not recommended outside of a clinical trial and not recommended at all in liver transplant, where the hepatitis C has already established chronic infection in that organ to be transplanted, but is continuing to be evaluated in non-liver transplantation. And I think a very promising potential way forward to shorten therapy, save money, and eliminate that early viremic phase when we look at if you follow a test and treat paradigm. That has been associated with some concern. So this is a single center study from Tennessee in kidney transplant looking at viremic donors into negative recipients. And they had 53 kidney transplants where they use this test and treat paradigm, which many centers do because of challenges of drug coverage. They did have a very long time to initiation of therapy, so 76 days post-transplant. All of them became viremic. And in fact, one patient developed fibrosing cholestatic hepatitis. This did resolve with therapy, but this is a condition that no one wants to see in 2021 particularly. This is associated with a very high risk of mortality. All ultimately did achieve cure and good renal graft outcome, but they also did note some other concerning trends, including higher rates than expected for acute rejection, development of donor-specific antibodies, as well as BK virus viremia in about a third, and cytomegalovirus viremia in actually 60%. There are other reports of higher rates of rejection, both in liver transplant as well as in non-liver transplant, even with short courses of hepatitis C viremia. To date, there hasn't been a clear association with poorer graft outcomes, but definitely a concern. And this is a report actually that was published just very recently in the American Journal of Transplantation, where hepatitis C viremic kidneys were associated with a higher risk, so 1.69 hazard ratio of high-grade BK virus viremia. So again, although this is a relatively small case series and they did not demonstrate impacts on graft function or graft loss due to BK nephropathy, a concerning trend that early, even short periods of hepatitis C viremia from a donor may be associated with other immunological and higher infectious risks, and that perhaps giving preemptive or prophylactic therapy may be preferred. But at the moment, this is broadly accepted in the transplant community that these donors increase the donor pool and can be safely used. There remain questions around the optimal approach in prophylaxis versus this test and treat strategy, and data are still lacking in terms of the optimal approach. And one of the biggest challenges is the practical considerations of who is going to pay, and can you get either hospital authorities or prescription drug plans to cover prophylactic hepatitis C therapy. And so thus we continue to see this difference from center to center. Recipient-informed consent is critical, and at our center, we do this initially when people are listed for transplant. They have a conversation with their transplant physician. They then come and see us in transplant infectious diseases when they're on the wait list to talk about the rationale for, the risks and potential benefits for considering a hepatitis C viremic transplant. And then again, of course, at the time of organ offer, they have another discussion about the individual circumstances of this donor and the other factors in terms of overall graft quality to form a final decision about whether they receive that donor. And there are a number of treatment guidelines out there, which, I haven't gone in depth into the treatment, but these follow a number of guidelines that are published throughout the heart-lung transplant community, the liver transplant, as well as transplant-specific guidelines in the American Society of Transplantation. There are a lot of really interesting ongoing studies on alternate ways to manage hepatitis C viremic donors or other infections. And so this is just a provocative study from the Toronto group, who is always provocative. So here, recovering lungs from hepatitis C viremic donors and placing them onto ex vivo lung perfusion. So the lungs are placed into this little chamber where they are ventilated and where they are normothermic perfused. And then you can manipulate and treat infections or other conditions in those lungs. So for example, this is done if their donor lungs have thromboembolism, you can treat that and improve the quality of the lungs that can then be utilized. And in this case, what they looked at is whether or not they could inactivate hepatitis C using UV light. And what you can see is that they actually were able to drop the hepatitis C viral load significantly over time on the ex vivo perfusion. Now, unfortunately, you don't need much hepatitis C to be infectious, and these lungs did still transmit, and the recipient still did require antiviral therapy. But it's a proof of concept that you can manipulate, and so there's ongoing studies to look at how we might be able to eliminate hepatitis C and other infections from organs through ex vivo perfusion, which is a technology that is increasingly utilized. The final point around this I just wanted to mention is this is a study out of Chicago that looked at people's acceptance. So one of the big questions is, do people who are offered organs from hepatitis C viremic donors accept them? And overall, on initial approach, this study showed about half, and this is very similar to what we see, about half are willing, about a quarter are unwilling, and then about 30% or so are sort of maybe not and need more conversation. But the reasons that people decline really are related to concerns about stigma, about ineffective therapies, about death, and again, I think highlight the importance of how we communicate these risks. Those who were willing to accept were significantly older, tended to be Caucasian, had shorter wait times, and had, importantly here, greater physician trust if they were willing to receive organs. Highlighting, again, I think the importance of our role in communicating to patients and the risk. In the last little bit here before questions, I'm going to talk about the unknown. So we've talked about the known risks. So HIV, hepatitis B, hepatitis C, we can quantitate these risks, we can communicate them, we can modify them to safely use organ donors. But what about the unknown? So this is probably the most common situation we're in, is that we're offered a donor, we don't exactly know what the risks may be. And there is this category of donors that are called increased risk donor. So what are increased risk donors? So when we screen organ donors, as I said at the beginning, the standard is serology. So for bloodborne pathogens, HIV, hepatitis B, hepatitis C. However, we know that there is potentially a long period of time when a person may be infected, particularly with hepatitis C, up to about 70 days before they may become hepatitis C seropositive. We can shorten that window by doing nucleic acid testing. And so this shortens the window for hepatitis C and HIV down to about 7 days. But in someone who is engaging in ongoing risk behavior, there is still this 7-day period. So if they've been engaged in high-risk activity right up the time of becoming a donor, they still may be acutely infected with HIV or hepatitis C, where you don't detect that infection even through nucleic acid testing, yet that donor may transmit infection to a recipient. So this is what's described in Canada and was in the US as an increased risk donor. And so this is from Health Canada, Canadian standards about what is the definition of an increased risk donor. And so these are the factors and behaviors associated with higher risk. And predominantly the biggest ones here are injection drug use, but you can see there's a very long time. So injection drug use in the preceding 5 years, men who have sex with men, people who engage in sex for money or drugs, being in correctional facility for more than 72 hours within the preceding 12 months. So a number of factors that are related to higher risk of bloodborne pathogens. So in Canada, we also have this term that's called exceptional distribution. So if an organ is identified as being from a donor who is at increased risk of bloodborne pathogen, those organs may be offered under this process called exceptional distribution. So if there's no other organ for that recipient, which is basically always the case, and if the physician deems that otherwise to be a good quality organ, and obviously there needs to be informed consent of the recipient, and there needs to be follow-up testing of that recipient for HIV, hepatitis C, and hepatitis B. But exceptional distribution is also a process whereby organs are distributed for a wide variety of other reasons. They may be labeled as exceptional distribution if there was incomplete, something unknown on the history, or if, for example, they received a lot of blood product or crystalloid at the time of resuscitation. So it's not a specific term that applies to increased risk donors for bloodborne pathogens. So it results in this very confusing story, I think, in Canada. And I just have some cases here to demonstrate to you some of the challenges. So there's a number of different donors here, and starting up in the left-hand corner. So this is the fairly classic and not uncommon donor offer that we may receive. So a 38-year-old man has a known history of injection drug use, found down in a public space, a syringe in the arm, becomes an organ donor. All the serology for HIV, hepatitis C, and hepatitis B are negative. And so this is very clearly a donor that would be considered an increased risk donor, and organs, once NAT is demonstrated to be negative, would be offered under exceptional distribution. However, if you compare that to the donor to the right here, a 36-year-old man, so this is the history. So again, remembering history is taken from the next of kin, from the mother in this case, indicates that this donor had no history of injection drug use, but did have a history of polysubstance abuse, including oral and intranasal drug use, and died of an overdose while en route to jail, was in the back of a police car, and died due to an overdose due to a ruptured condom that was filled with heroin that he had in the rectum. And so this donor, I would argue, I'm not sure has much of a different risk from the prior donor described. However, by following the Health Canada definitions and the standards, this in fact is not an increased risk donor because there was no history of injection drug use, and that was negative. And these organs also would not be offered under exceptional distribution. So does this really appropriately capture what we're looking to capture, which is potential risk? And how do we communicate these risks and do appropriate follow-up testing in a recipient? In the interest of time, I'll just go to this 59-year-old man just to compare. So this was a 59-year-old man who had a subarachnoid hemorrhage and was from a small town, lives alone in rural Alberta. And the history here came from the ex-wife. And there is a question on the medical social history that says within the last 5 years, has has this donor had any sexual relations? And the ex-wife said, I don't know, in the last 2 years, I haven't really had a lot of contact with him and I don't know. So answered very honestly, but there was nothing in the history to suggest that this donor engaged in high-risk activities. But because of the question of I don't know, this donor and organs get labeled as exceptional distribution, and depending on which center they were going to were felt to be variable risk in terms of being an IRD or increased risk donor. And I would say really this donor had far less risk in reality than this donor up here. So some of the challenges of our current system in Canada. The other problem is, what is the relative risk? So this is really looking at the estimated residual risk of HIV and hepatitis C in Canadian IRDs despite negative serology and NAT. And overall, so again, intravenous drug use is the most common risk behavior, and these risks are very, very small. So for HIV, about 1 in 3,700, and for hepatitis C, 1 in about 250. And particularly if you compare that to other risks that people accept regularly in their life. So your risk of dying in a motor vehicle accident in your lifetime, 1 in about 100. So I think most of us still continue to drive. And then if we think about annual risk of death on dialysis, so if you're a kidney, waiting for a kidney, your risk of death on dialysis is about 3 in 100. So far greater risks that we take in everyday life and that transplant candidates experience compared to considering donors with these increased risk behaviors. The other big challenge is, and this is a study that looked at it specifically, but I will just summarize by saying, questionnaire responses provided by donors next of kin regarding risk factors may be inaccurate. And so I think this, again, is not news to anyone, but has been clearly demonstrated that it can give us a little bit of sense of risk category, but it really is not that accurate in identifying donor risks. And risk perception is a big challenge in medical decision making. And there are many, many factors that impact risk perception and risk tolerance, cognitive, emotional experiences, and it impacts the decision making not only of patients, but also of physicians. And we need to be very careful of our own biases when we're speaking to patients and trying to communicate risks objectively. So in the US, so this is the CDC in 2013 had updated their guidelines in an attempt to improve safety and communicate risks around these class of increased risk donors. But what occurred is that there was a much greater labeling of increased risk donors, almost doubling across all categories and across all regions of the US. And there is a clear negative impact on utilization of these organs by the label of increased risk donors. So this demonstrates that the actual outcomes of graft function are similar to standard criteria donors that we use, and in fact superior to what are called extended criteria donors, which are donors that are older or may have hypertension or have other medical factors that are associated with overall poorer graft quality, but that we accept because of the overall benefit in transplantation. And so increased risk donors, in fact, overall perform better than those organs that we would routinely accept, yet are more frequently declined. And when they're declined, what happens to those organ transplant candidates? Well, a significant proportion who decline an IRD go on to die, so about 20% in this study, or continue to wait many months or years after, or are removed from the wait list. So about 20% removed from the wait list, which means they developed a medical condition or something else that made them ineligible. So overall, this is associated, decline of an IRD is actually associated with poorer overall outcomes. So if you accept an increased risk donor, and this is in kidney transplant, your risk of dying is far less than if you decline. So, you know, the impact of our words is very important. And this is a book by Fergus Shanahan, who's a gastroenterologist from Ireland. And it's a bit of a difficult book to read, but it's called The Language of Illness. And so his quote says, this book is about patients and carers and is for patients and carers and about how words shape the thoughts, decision, and judgments doctors make on behalf of their patients. And I think we really have to be cognizant about how we communicate with patients and how that impacts their decisions. And so the United States recently in 2020 revised their criteria for increased risk donors, recognizing that although the 2013 update had attempted to improve safety overall, that this really was resulting in underutilization of organs that are at very low risk of infection and overall improved survival in recipients. There also is updated modeling, which really looks at organ donation, with older models having relied very much on the blood donor paradigm, and with organ donation, essentially, so if we look at hepatitis C, where the donor injects drugs, so that the risk, even if using right up to the time of donation, the risk is still relatively low, 27 per 10,000. And again, a treatable, curable infection as long as we identify it and if there's transmission. And that the time to reach 1 in a million risk of infection across all of the bloodborne pathogens is very short. So at most about 30 days. And so I showed you in Canada, we're asking about risks in the last 5 years, which really, it really is only the risk in the last 30 days that is significant. So the US has changed their guidelines, has removed a number of criteria that no longer are really relevant or have been shown not to be associated with transmission, and have moved to universal testing, screening by nucleic acid for HIV, hepatitis B and C, recognizing that our ability to do risk-based screening is really quite poor. And so we'll just screen everybody, and has removed the label. So no longer are these organs referred to as increased risk donors or IRD organs, to try to remove that stigma and bias that occurs. And the consent has been removed as a separate consent into routine consent, simply expressing the risk. And the risk factor assessment has also been limited to 30 days. So I'm going to stop there. I'll come back. These are the objectives, which hopefully I have covered. And I will open up for any questions.
Well, thanks very much, Karen. That was very informative. And I really, I like that whole concept of using the correct language. Very, very important. Everybody, welcome back. Just a quick update for those that don't know. If you want to submit questions, you have to go to Slido, slido.com, and you can see we already have some people out of our 2,500 participants. So that's good. So let's move straight on to this, but you have to go to slido.com and go bug 2021. And so the top one, as you can see, is hepatitis D tested for our liver transplants. You had kind of touched on it during the talk.
Yeah, so for donors, as I say, you would only worry about hepatitis D if a donor had hepatitis B, was surface antigen positive. So those are rare, as they say. If you were considering using particularly a liver, yes, you would test for hepatitis B. The recipients, again, with chronic hepatitis B are screened for hepatitis D as well, because it influences the prophylactic regimen. Yeah.
Okay, good. Now, so is there any rule on TB screening, case finding? Like, that's definitely lots of that happening.
There is lots of that. So yeah, I could give you a whole nother hour-long talk on TB in transplantation. Tuberculosis is a huge challenge in transplantation. So again, predominantly on the donor side. So recipients are all screened for tuberculosis. Again, we can talk to them, we can assess risk much more accurately. We do either tuberculin skin testing or interferon gamma release assays on recipients to assess for latent TB, in addition to assessing their epidemiologic risk, et cetera, and give latent TB therapy to those who have evidence of latent TB. Donors are much, much more challenging, again, because of the inability to get accurate history. We don't have an integrated national system. So we've had incidents where we were unable to find any information about prior tuberculin skin testing. And then when we had donor-derived TB, found out that that donor had actually had a positive TST in a different province, but that information wasn't accessible to us at the time. And then screening of donors in real time also can't be done because tuberculin skin tests, you don't have the luxury of time. We don't know if it performs appropriately. And interferon gamma release assays, which when they first came out were looked at as a potential way to help with donor screening, also turns out they largely don't work. So about 40% of the time, you get an indeterminate result in deceased donors, which is related to the cytokine storm of brain death and how the tests operate. So it's not reliable. So it is a very big challenge. We rely largely on epidemiologic risk history. But we in our center over the last 5 years have had almost one case per year of donor transmission of tuberculosis. Big challenge.
Yeah. So we'll leave that in your hands to sort out for Canada. Although you have got some of the top TB people in the country anyway, so that's fantastic. Okay, so but this does kind of touch, the next question touches on what you've been talking about, which is donor screening universal, and so you've talked about TB tests and that sort of stuff. Just how much testing is, like where do you even draw the line?
Yeah, so there is universal screening. So that table I showed you lists sort of the universal serologic screening that is done. In addition, there are some standard questions that are required in terms of asking about travel history, country of birth. There is a lot of variability. So, and again, we have national sharing of organs. So the questions that are asked in Alberta by the Organ Procurement Organization, although they have all of the required themes through Health Canada, as do the ones in, for example, Ontario, there are nuances. So they're not identical. So there is some variability from province to province. And there is additional testing that's done, again, based on what one might find in the history. So if a donor has been born in or spent significant amount of time in areas where other infections are endemic, so things like endemic mycoses, coccidiomycosis, et cetera, or strongyloides, then we do additional screening that's targeted.
Okay. And brand new question there, which very much a hot topic. I mean, so syphilis, what are we doing with that?
Yeah, so interesting. Syphilis is a big problem as well. We have a very, very large, again, in most jurisdictions, in Alberta particularly, we have a very big syphilis epidemic. We're seeing a lot. So of our hepatitis C viremic donors, the last 5 of them have also had syphilis newly identified. So it's routinely screened for. It's, relatively easy to treat. And so we do give the recipients benzathine penicillin G, but it's an area where we don't actually have a lot of data, but it is part of routine screening. Increasingly, I think we're seeing it in our donors, and we're able to use, again, those organs with the screening and with treatment in the recipients.
Mm-hmm. Okay. So I know we're a little bit over time, so I'm actually going to push on John and just say, okay, John, we want one last question. So, and it does kind of link into what we've talked about. So how does the recipient need, so how long does the recipient need to take the antivirals when the donor has Hep B. And you definitely did touch on that, but just a quick reply.
Yeah, so if it's a liver recipient, including even just an anticorp positive donor into a liver, then they have to stay on antiviral indefinitely, so lifelong, essentially. In a non-liver recipient, because the risk of transmission actually is limited by, lymphocytes that have a half-life into the recipient, for example, in a kidney, then there we would only use it, first of all, in a small portion and only for 1 year.
Well, I know you are back later on in the day, so you can sit back, grab your tea and enjoy the rest of the day. And we look forward to hearing from you again a little later.
Thank you.
Thanks very much. So I'm just going to go straight on into our next speaker and continue with the whole day. Just briefly, my name's Richard Rusk. I'm the moderator for the day, and two things you would have seen it. I've mentioned it before, the slido.com. That's really important. You saw that people are putting questions in, you rank them up and you rank them down, and that's the way you can interact. And then Dr. John Emble, he did mention earlier on, you do get credits, but you do have to log in to Slido to be able to get those credits. So that's why I'm just letting everybody know. And you're supposed to have also registered if you wanted the credits, and that's at the cpdumanitoba.com webpage. But if you are online, you most likely have already done that. So, okay, well, Dr. John Emble, I definitely no one needs to introduce you, even if you are in your spandex. And so you're going to give us a little bit of an overview. What's been happening over the last year, kind of a follow on from our COVID bug day last year. And so this is also to all other speakers. I see Dr. Casper's around. I'm sure Dr. Roussen's around it. I'm going to time you and I'll give you a 3-minute warning. So off you go, John.
Well, thank you very much. The year 2020 to 2021 has been quite a year. And this is going to be a rapid fire fast forward from October 2020 to October 2021. 3 objectives for this program, specifically state the challenges that we've experienced over the past 19 months, state how you're going to protect yourself from COVID-19, and of course, have fun. The conclusions first, in case I don't get to the end or you fall asleep. So in terms of the challenges, adherence to public health orders has been a challenge for some. Serial waves of virus transmission in the community has been a challenge. Healthcare capacity has been a true challenge, both acute and in critical care, and the surgical wait lists. Vaccination has been fraught with confusion and availability of the vaccine. The indications and contraindications and exemptions have posed a challenge for some. And of course, there are the emotional and psychological challenges, and definitely the financial challenges experienced by some. Protecting oneself from COVID-19, follow the public health orders, masks, hand hygiene, physical distancing, testing of symptomatic and isolation of those that are positive, and of course, common sense. Have fun, that goes without saying. So let's rewind the mental videotape to October 2020. This is where we were. We were in the valley of COVID colliding with flu season. At this point, the hospitals were pushed to the brink, the ICUs were filled to capacity, schools and care homes had virus outbreaks, and Health Canada recalls counterfeit hand sanitizer. Halloween brought around some really scary costumes, and we saw some non-compliers. Kids got different kinds of treats, hand sanitizer and packets of wipes. And the Emble family chose not to participate in Halloween, and this is our ghost. And we had a sign that says, no tricks nor treats this year. See you next year. Stay safe, social distance, wear a mask, and clean your hands. And I think that sign's going up again this year. So here we have Brent Roussin ushering in November. We don't have time, says Brent Roussin. No, we don't have time. What lay ahead in November was frightening. A healthcare worker dies related to COVID acquisition. And the second wave of COVID is riding on a wave of complacency. Scary business. The premier vows to ticket non-compliers, and mask strategies change from March to December. The rink, everyone think back to last year, everybody built a rink in their backyard. And Remembrance Day falls victim to the virus. Physicians ask, who do we treat? Who don't we treat? Who do we turn away? And care homes take a massive beating from COVID. Canada's overwhelmed with the virus, and Movember becomes a bit of a bust. No one can see your luxurious bushy mustache. The healthcare system is ravaged by, let me correct that, the foundations of the healthcare system are ravaged by COVID. The Russian vaccine costs less than $10 per dose, and who really cares? And then we've got the seven-letter word from hope, which is vaccine. Steinbach, COVID rates go through the roof, and Brett Rusin, a bit of a Grinch, you know, that Rusin fellow, says, stay home for the holidays. Oh no. But we realize that COVID has wreaked havoc on surgical slates, and everybody asked Santa for a vaccine, including Mr. Trudeau. Reindeer games are done at a distance, and Lynette Saragoza tells us in December, November takes the province from bad to worse, and little did we know what lay ahead. Those who survived the spring lockdown found themselves in the fall lockdown, and the holiday season was really a season from home with online shopping. COVID became the word, sorry, not COVID, pandemic became the word of the year for 2020, and the deficit grows, and people realize that they want their freedom. The Salvation Army goes high-tech with tap-and-go technology, and our premier steals Christmas, and if you didn't behave, you'd end up not the elf on the shelf, you'd end up the elf on the ventilator. Healthcare workers are first in line to get the first doses of vaccine, and of course, we want 3 wise men, not just 2 wise men. Ryan Zarachansky and his research team lead some phenomenal research using anticoagulants for critically ill patients, and our chief medical officer warns, our chief public health officer warns us that there are grim COVID numbers coming. The world gets a shot in the arm from Santa, and so does Brian Penner, the first healthcare worker who gets the COVID vaccine in Manitoba. And our deficit is in the $2 billion range, less than expected. I guess that's a good thing. The French Prime Minister gets COVID, and the healthcare system is on the brink of collapse. Healthcare workers sacrifice their holidays for our patients, and the vaccine rollout is criticized for being slow. And of course, most of us want to forget 2020. But there's hope and optimism for 2021. There's a vaccine on the horizon. So people are told not to travel. And some of these people that traveled were our community leaders. And here we have this great cartoon that's Air Hypocrite, carrying some leaders and not others. Care home residents get vaccine, and the vaccine rollout continues to be criticized for being slow. The First Nations get vaccine, and delivering alone is hard. Visitors were not allowed for hospitalized patients. The provinces blame the federal government. The federal government blames the provinces for the slow vaccine rollout. Mr. Biden rolled out a massive financial stimulus program for the United States. And after 10 weeks, haircuts are allowed, visitors are allowed, but not too fast. Little do we know what's coming. Some churches use anti-mask rallies to attract more followers. And we know that the vaccine is the key step for bringing us back to society, back to reality, and back to normalcy. Ryan Zarachansky and his research group are doing groundbreaking work with the role of anticoagulants in the critically ill. And even our pets know, stay. The backyard rink becomes critical to our survival. And the veteran who walked and raised money for COVID perishes from COVID. Those who travel may have found themselves in quarantine hotels. And the vaccine is still a challenge. And poor Mr. Trudeau is taking a beating for the vaccine rollout. The armed forces visit First Nations communities to help with COVID. And we can't forget that there are other pathogens out there. So Canadian snowbirds are grounded, and Manitobans older than 95 are allowed to get the vaccine, and then rolls out quickly from there. For those of you on social media, you realize there is no breaking news other than there's a vaccine delays. There is a mutating monster in our midst, and Manitobans get proof of vaccination. That vaccine card will become invaluable. Hospital diagnostic tests have been restricted since October. And think about it, we can't have everything. And one of the things we realized in Manitoba, and particularly in Winnipeg, is our downtown core in Winnipeg implodes because there aren't any people there. Care home residents get vaccinated, and we have no idea what the spring holds. So Red River Community College recycles masks, and those going out for a shot on St. Patrick's Day aren't going to a pub, they're going to the vaccine clinic. And we commemorate those who perished from COVID-19. We're getting ready for a third lockdown, and Dr. Rusin looks very serious. Kiss me, I'm vaccinated. But then again, I think Dr. Rusin would be horrified if people were kissing random strangers. The supply chain distribution has been massive, and Florida declares the pandemic over and starts partying. Not very wise. The Goldies get vaccinated in training camp, and if you are sitting on the fence about whether you're going to get the COVID vaccine, maybe winning a new TV will send you in that direction. Middle schoolers, and in fact, all kids in school are struggling with the loss of routine and in-home schooling, which is terrifying. Supply chain distribution and disruption is massive. You may not get your bicycle or running shoes, and dating at a distance, better safe than sorry. Now, here's a great and provocative headline. Lab leak, unlikely COVID-19 source. You know what? I think the jury's out, and we'll find out why the jury's out in a second. The variants are knocking at our doors, and Quebec locks down multiple cities. The flu season never came, which is phenomenal, but maybe not this year. Dr. Rusin tells us to mask up outdoors, and this fellow got his vaccine, and he's ready to party. Not so fast. ICU sees record numbers of COVID patients. This is scary business, and the vaccine rollout is still a challenge. Dr. Kumar tells us that vaccine hesitancy is adding to risk, and Dr. Atwal tells us this is an all Manitobans, and it sure is. Mr. Trudeau gets his AstraZeneca vaccine, and a teacher suspended for attending an anti-mask rally. Some people hear immunity, but don't act on it, and our political leaders get their vaccines. In the old days, we just rolled up our arms and got our vaccines. And no mask, no worry, you might get a ventilator. Notice how I said you might get a ventilator? Intensive care units are bursting at the seams, and patients are transferred out of province. This is scary. New Zealand uses science to inspire people. Unbelievable. Manitoba is sending patients to Ontario and Saskatchewan. Eric Jacobson tells us health system near collapse. This is scary business. Vaccine passports around the corner. The mall's open, but the shoppers don't appear. And now kids are back at home with schooling. Hockey games are back in action, but only for the vaccinated. Weed, bicycles, cell phones, all incentives for getting your vaccine. Back in business, sort of. And Maxime Bernier tours the country, but his tour gets abruptly shut down in Manitoba because he didn't comply with public health rules. Way to go, Maxime. Low German stickers so we can all designate our vaccination status. Mr. Trudeau explains the new border rules that are murky at best. And reading, writing, and repeating. Some kids choose to repeat academic years. The Landmark Theatre in Winnipeg, the Landmark Theatre in Winkler does not reopen because of low vaccination rates. Dr. Rusin is taken to trial for public health laws that are not in agreement with some churches, and the end is near. Hopefully it's the end of the pandemic, and Mr. Biden wants to tackle the pandemic. Here we are heading for the Olympics. Faster, higher, stronger. That's the Delta variant, not the athletes. And Dr. Zarachensky's work shows that heparin is of great benefit in sick patients. Online dating becomes a boom, and COVID visits the Sturgis rally. Anti-vax sentiments have anti-science roots. And Mr. Trudeau rides his surfboard on the fourth wave into a re-election. Manitobans keep wearing their masks, and the Children's Hospital braces for a surge of COVID and other respiratory viruses. Politicians can't get their head around vaccination, and a mother is cross with her dentist for not divulging vaccination status. The fourth wave is here. And loud and not so proud. The NFL and NHL make vaccination necessary for attending their events. And I love this cartoon, Back to School 2021. One kid says to the other, who's the new kid? It's the Delta variant. Steinbach vaccine protests attract hundreds. And the back to normal is not that back to normal. Religious groups endorse the vaccine, and some choose to protest vaccination outside our healthcare facilities. Surgeries are on hold, and it's back to school and back to stress for students and teachers. Physicians are exhausted with the anti-vaxxers, and nursing vacancies stress all of us. Some parties draw the anti-vaccination crowd, and Mr. Trudeau will not bow to the anti-vaxxers. And back to school supplies, masks, sanitizers, and wipes. Who would have thought? BC has a vaccine passport, and ivermectin is for deworming, not as a prophylactic therapy for COVID. Anti-vax and anti-max protests at outside hospitals, not wise, not cool. Our politicians are still struggling with the vaccine, and some have to apologize for comments they've made. The vaccines are now given names, and the Winkler chief of police actually prefers to deal with drug dealers and career criminals than the anti-maskers. The former are far more polite, he says. A restaurant actively defies the public health orders and gets monster fines. And Pfizer has great data for kids 5 to 11, now under consideration by Health Canada. Our political leaders need to come clean and clearly state their positions on vaccination and, in fact, endorse public health policy. Anxiety over return to the workplace. I'm not surprised. Who knows what lies ahead in the workplace? Staffing shortages are significant, and Mr. Trudeau sticks to his guns with the vaccine mandate. Christmas might not be the Christmas Santa had planned for with supply chain disruption, and we've come full circle from early man to the Neanderthal. It should have been the other way around. And at the end of the day, credit cards seem to rule because nobody wants to touch dirty cash. There's going to be significant lockdowns for the unvaccinated, and if you plan to travel, not without a vaccine. Boosters are here, and the Mennonite Church won't give vaccine exemptions. People line up for their flu shots, and Maxime Bernier is hot to trot. Russians flock to Serbia for Western-made vaccines, and health resources have been crippled by COVID. And this writer to the Free Press basically says, make the unvaxxed pay for their tests. The American border opens. Our politicians are still struggling. And look at this. China blocks the hunt for the COVID origins. And to bring this potpourri of headlines to a near end, healthcare worker shortages are looming. New Zealand had a vaxathon. Our Jets captain is locked down because of COVID protocols. And we lost Colin Powell because of complications of COVID. That Thanksgiving turkey is using COVID to its advantage. I'm feeling a bit feverish, says the turkey, and he's holding the COVID symptoms. So let's conclude. The challenges that we experienced over the past 19 months, adherence to public health orders, serial waves of virus transmission, healthcare capacity was at a premium and was in a serious state. Vaccination, there were some problems with availability, then some confusion about who's eligible, and ultimately indications, contraindications, and exemptions. There are the emotional and psychological implications of COVID, and of course, the financial strains. In terms of protecting yourself, follow the public health orders. These are no-brainers. These include masking, hand hygiene, physical distancing, testing of the symptomatic, isolation of those that have COVID, and common sense. And of course, have fun. A couple of parting shots for you. Political leaders must support the public health policy, not make it. That's for Dr. Roussin and his group. Vaccination has its privileges. If you're vaccinated, society opens up. And all of us play a critical role in arresting the pandemic, and any deviation from the public health guidance will cause prolongation of this pandemic. And this headline hits the nail on the head. It seems the COVID-19 fight is now up to us. It's in our hands, and only we can bring this to a conclusion. Thank you.
Oof. Well, thanks, John. That was your typical high speed, which is probably a normal full hour worth of talking. But do you want to go into politics? That's probably the first question. I mean, anyway, so I would like to move on to Dr. Brent Rusin. So if anyone does not know Dr. Brent Rusin, where have you been? I've no idea. Clearly under a rock. He has been our intrepid leader. He's a Chief Public Health Medical Officer for Manitoba. And he's going to give, I think, a very different slant on the last 18 months. So over to you, Brent. Welcome.
Oh, thanks. Thanks, Richard, and thanks, John. I thought I might be able to get through that slideshow without a picture of my collar, but that got slipped in there anyway. So perfect. Okay. Well, thanks. And so yeah, so no conflicts for me to disclose. Today we're going to review some of the epidemiology that we've seen here in this pandemic. Discuss topics such as herd immunity, which we've definitely heard a lot of, and its relationship to the basic reproductive rate. And then, of course, discuss these public health ethics that have been, really to the forefront with the use of the Public Health Act, really in a manner it's never been used to this, certainly to this degree in the past. So you can see from our epi the toll that this virus has taken on Manitobans, the lives lost, the impact on the healthcare system. The overall goal for the pandemic response has always been and continues to be to reduce the mortality and morbidity of COVID, but at the same time minimizing the societal impact of the actions against COVID. And it's been a very difficult balance to achieve. And like I say, this virus has taken a toll directly and indirectly on many Manitobans. You can see here that this what we're dealing with now is largely the pandemic of the unvaccinated. If we look at simply just cases, most data across Canada is going to show that the unvaccinated have 10 times the risk of becoming a case. If you look at severe outcomes, that's much greater. So if we look at ICU admission, this is in the 30 times the chance of being admitted to ICU in the fully vaccinated compared to unvaccinated. So you can really see that the transmission is predominantly in the unvaccinated, and the severe outcomes is predominantly in unvaccinated, and that's really the issue where we are right now. Is that it's the strain on the healthcare system that we need to protect against. We need to ensure that Manitobans have that healthcare system there for all of us, not only to battle COVID. And it's very, very clear that the best way to protect that system and ourselves is through vaccination. We know that even those who are vaccinated that do become cases are much less likely to transmit that infection as well. So many benefits to vaccination. We look at our epi curve, and I look back at that first almost non-existent wave that we saw back in March of 2020. And I think back to a time there, if you told me that we'd be looking at a period of time where we have over 80%, 87% of Winnipeggers fully vaccinated, it would be hard to believe. And if you told me that we had a period of time where we had 87+% of Winnipeggers fully vaccinated and we were still at risk of a fourth wave, I do find that even harder to believe, but that's where we find ourselves. And so most are familiar with the trends that we've seen over time. That first wave really did not hit Manitoba. We saw that second wave starting in Prairie Mountain Health, very localized transmission which we were able to get under control. Then that large second wave, over the holidays, and a third wave driven by the Alpha variant, where we did overwhelm our healthcare system, needed to send ICU patients out of province, over 50 of them. And then a fourth wave that has not yet declared itself in Manitoba, and this is predominantly driven by that Delta wave. And so certainly we had faced many challenges here, especially during that third wave. If we look at that ICU admissions, we saw that Manitoba faced a lot of challenges, that we, as a proportion of cases admitted to ICU, we unfortunately had many more proportionally compared to other jurisdictions, almost double that of Alberta and the third wave, the proportion of cases. And so this puts even further strain on an already strained healthcare system. If we look in that third wave, we were well into vaccine, especially in the older population. So a lot of our healthcare system was strained by the younger populations, and you saw that in these younger age groups, 20 to 39, we're 4 to 7 times admitting of proportionately of other populations. So this took a huge toll on our healthcare system and healthcare providers, and we really saw the effects of this virus during our third wave. So, what were the causes of this? It's not clear necessarily. It's certainly not related to a distinction in the way we, who we admit to ICU. We're certainly admitting similar illnesses, similar condition to ICU. This has to do more with the underlying health conditions in the population. It may have to do with a denominator issue. Perhaps we had many more undiagnosed cases compared to other jurisdictions, and therefore our proportion seemed higher, but was really much the same. So we know from our seroprevalence data that only about 1 in 4 cases were diagnosed. And so certainly that could be playing a factor into this. And there's just another slide, and these slides are from the Public Health Agency of Canada, just showing how disproportionately Manitoba faces severe outcomes. So it's really challenging on our healthcare system when we have spikes of cases, and therefore we need to be very cautious, and being very cautious with this potentially pending resurgence here in the fourth wave. Again, part of the issues that we faced here was the disproportionate impacts of COVID-19 on BIPOC communities. Certainly, this is not unique to Manitoba, but very significant. And you can see the disproportionate effects here, where if we classify the white population, about 60% of our population made up only 35% of our cases. But you can see in that many other BIPOC settings, very overrepresented in our cases. And again, when we're discussing these sort of risk factors, there's always that challenge with stigma. And so there was a lot of work being done. Dr. Marcia Anderson connecting with community leaders in these communities on appropriate ways to disclose this information, because we didn't want to further stigmatize on these issues, because it should be clear that this disproportionate effect is not related to poor life choices. This is related to underlying factors that we normally see affect other health conditions: poverty, housing issues, even occupations. And this slide here shows that disproportionate effect was present through almost all of the age groups, and really notable in that 20 to 29, 20 to 39 age groups, where we could see this is likely that impact of the occupational setting. And so, most of you are aware of the story of John Snow and the Broad Street pump during the cholera outbreaks, and removing that handle of the Broad Street pump and the effects it has. And really this is the Broad Street pump of this pandemic. These inequities that we've seen, long-standing inequities, has really driven cases as well as severe outcomes. And like I say, not unique to Manitoba, but such a significant story of this pandemic. We talk about issues of herd immunity. As soon as that vaccine became available, discussion of herd immunity and what proportion of the population do we need protected to be able to get out of this pandemic. And certainly that the proportion has changed over time due to the variants of concern. And so the concept of herd immunity is just that the resistance of a population to the transmission of a pathogen when a large proportion of that population are immune. And you can see that interaction between herd immunity and the basic reproductive rate, and that's that R naught, and that's that average amount of people that a case will pass on the infection to. And so that interaction is there, and we saw that with wild type virus, that R naught was considered to be around 2.5, 2.8. And so we'll be looking largely at 60 to 70% uptake of the vaccine could lead us to decreasing that R value to below 1. But with Delta, we see 5.6% is now that R naught, which is considered. So we're now looking at 80 to 90%. So it's really thrown a wrench in those calculations. And of course, the concept of herd immunity is a theoretical one. When we have large pockets of unvaccinated, that concept of simply a percentage of the population protected doesn't hold true, but it is a rough estimate, and you can see that interaction between herd immunity and that basic reproductive rate. Of course, we've used the Public Health Act in manners that have never been used before. There's over 90 public health orders that I've signed during this last 18 months. Most of them under Section 67 of our Public Health Act, which are special measures under a public health emergency. They do require ministerial assent, and so a lot of work is done on those, the ethical requirements, the restraint that we have to show, that balance, and so these are the typical public health ethics that we consider. That harm principle. We don't use coercive measures unless there's a threat to harm to the population. Of course, we want to use the measures that are least restrictive to reach our goal. Reciprocity, things like paid sick leave, some of the money that was paid out to businesses that have had to shut down, and in transparency, all the public health orders are published. Everyone knows the obligations they have under those orders.
Brent, about 3 minutes.
Sure thing. Thanks, Rich.
Thanks.
So about we hear, and so this is a requirement in at least 3 different manners. One you heard under the Public Health Ethics. Our Public Health Act has it enumerated there, the requirement. And then the Charter of Rights and Freedoms, and you saw that there was a constitutional challenge in our jurisdiction and many jurisdictions. And really that Section 1 of the Charter of Rights and Freedoms is what's in question. And when we look at that Section 1, this falls down to what's called the Oakes test. And it really is showing that the issue is pressing and substantial, as COVID is, and then comes down to proportionality, whether the restrictions are rationally connected to stopping that transmission. Do the orders minimally impair? And then, of course, that proportionality effect is the significance of the restrictions greater than the threat that we face. And so those are all the things that are argued in our jurisdiction and others. And looking to the future, what is that post-pandemic going to look like? For many, we're living in essentially a post-pandemic world right now. Fully vaccinated people are doing most of things that they had done in the past, just differently. But that post-pandemic will, be something that we'll have to deal with over time. When this fourth wave presents itself to us. But the more vaccinated population we have, the quicker we'll get to that post-pandemic world. And we know variants have always been a threat. With the vaccine uptake we have now with the wild-type virus, we would be largely done. But Delta has thrown that wrench, and now the selection pressure is on a virus escape. And so that would significantly set us back if we have a variant that escapes protection from these vaccinations. There's emerging treatments, monoclonal antibodies, again, which are promising, but certainly still early. And then we have other public health issues. We've had a syndemic of sexually transmitted bloodborne infections, most notably syphilis, alongside growing issues with substance use and harms. That was growing before the pandemic. It continued to grow during the pandemic. And we really need to start facing these other public health issues. But COVID has taken so much of our time. So I think that's it for my presentation, and happy to answer questions later on in the session.
Oh, thanks. Thanks very much, Brent. Always love the ethical and legal arguments, and you definitely have lots of insight on that. So, okay, so let's move on to Dr. Ken Casper. And for those in Manitoba, he probably doesn't really need any introduction, but he is one of our top specialists in internal medicine and infectious diseases, and has a special interest in HIV. Is definitely our HIV guru for Manitoba. And so, but what happened during the pandemic was Ken was the driving force, but behind VCOP. So that's a virtual COVID outpatient unit. And so Dr. Casper is going to tell us about the creation and the implementation and the success of this unit. So over to you, Ken. There we go. All sorted out. You can see everything.
Okay. Awesome. Thanks very much. Thanks very much for allowing me to present on the VCOP team on behalf of my crew from Shared Health. It's not easy going after Embil and Rusin, but I'll take the spot. We were a program that's sort of been under the groundwork of what was happening, and I can tell you there are 329 patients who are very happy, and a healthcare system that has been very happy that we developed this program in a pandemic. And I want to take you through that journey, and as well look at some of the things we've achieved, and then the potential future of a virtual system, and really show you how we had a virtual hospital up and running at some points in wave 3. I have no disclosures, and I'll get right into the talk and really show you this journey of really developing a program in the middle of a pandemic, which has been challenging, but this took a team to do, and I have a big thanks to everybody. I'll do some specific thanks at the end for a moment. Early in wave 1, we knew that we were going to have increased hospital admissions. We knew the healthcare system had potential to be overwhelmed, especially what we saw in Italy. And there was a question of whether hospitalizing mild to moderate ill COVID patients, is there another way of doing this? And that's really what the virtual system was trying to develop, to try to reduce the burden on the healthcare system. So a number of us, physician specialists, began working on the concept that will eventually become the virtual COVID outpatient program, or VCOP. And really driven by Dr. Sean Young at Health Science Center, who gave us a hub and helped us develop our plan, and Dr. Rob Gerson, because this is not only a virtual system, but we partnered with the emergency paramedics and community with the alternate isolation arrangement sites to try to make this a program that would help all Manitobans. And I thank again my main 6 clinicians who helped us put this program together. So VCOP is a remote monitoring program, and this is Dr. Moffat there, one of our VCOPers. And we usually connect with patients at least twice per day on a virtual means, and Microsoft Teams was the one that we used for the most part. But we were more than that. We offered home oxygen through the provincial home program. We had our own contract with Carica and could get oxygen in the home within 4 hours in some situations. We partner with the emergency paramedics. This is a key partner because if there are any problems at home, the paramedics would go into the home and do some objective assessments for us. And finally, our connection with the alternate isolation accommodations, which could help service other Manitobans not living in Winnipeg, was crucial as well, especially the alternate isolation accommodations where the paramedics were attached. Obviously, to do a virtual system, you need to be able to participate in the virtual follow-up. These are going to be the challenges going forward with a virtual system. We need high-speed internet, we need access to email, we need webcam, and obviously we need a place for individuals who could safely isolate. And this is where the alternate isolation arrangements in some situations were key goals to get people to if they couldn't isolate at home. But obviously these are some of the safe home environment criteria that we needed. But also we developed criteria, and this is just a snapshot of what the kind of patients that we were looking for the VCOP program. These are the ones that we're taking from the hospital wards. We had some age criteria. Really, we tried to pick out the ones that were going to be at the highest risk. We didn't want to take those patients into the program, of course. We wanted to have good outcomes, and obviously patients with higher risk should probably be monitored in a setting in the hospital. So we had criteria that we all agreed on. We changed them over time as we got more confident with the program. We had oxygen criteria as the most we could put into a home is 4 liters of oxygen. And we had some inflammatory criteria that if it could be done in the hospital or the emergency rooms, which really helped kind of, again, doing a lot of the COVID ward gives us an idea of who might be on that higher risk potential. Again, the kind of clients we do not want to have in the COVID outpatient program. We had some disease entities as well we did not take, active cancers, solid or bone marrow transplant patients, again, very high risk individuals for bad outcomes with COVID. This was a team, and this is just a snapshot of some of the team of physicians, nurse managers, registered nurses, and ward clerks. There's Bobby Brennan, who was the manager, and that's Kim Bressler, our main nurse, a key cogs in our success. Obviously, we partnered with respiratory therapists to get some oxygen teaching done very quickly. We utilized physician assistants during the wave 3. And then, of course, our relationship with paramedics and the Carica home oxygen program were all key steps in developing this virtual program. How does VCOP work? Well, as you can see, it's going to start with a phone call, and it's going to be a phone call from a healthcare practitioner to one of our VCOP doctors on call during the day. If we accept the referral based on that safe home environment, we're a place to isolate, and they meet our clinical criteria, everything starts at the hub. If they need oxygen, we put oxygen in the home. We plan to put oxygen in the home for the patient, and then we give them their material. We give them a VCOP package. We have thermometers and oximeters in the package. These are in the emergency rooms and on the wards of the VCOP wards, the COVID wards, so they can hand to the patients. And we also have tablets available if necessary. I really want to thank the Health Science Center Foundation, who supplied a lot of this upfront material early on. Again, these patients could be coming from the AI sites as well, not just home, where we would do our assessments daily. And again, we had the partnership with Epic. So Epic could go into somebody's home within 1 hour if we thought objectively that there were some problems, or if we're having virtual problems, Epic could potentially go in and be that voice for us while we're communicating with the patient. And then obviously we come to a place where we discharge the patients, hopefully from the program successfully. But obviously we've had situations where we had to send patients back to hospital. We had a unique ability, though, to send them right to the COVID wards with good relationships with the bed doctors if possible. So we bypassed the emergency departments. And obviously the patients are in our program for a while, especially with a long oxygen tail. We then refer them on for long COVID programs, including the respiratory clinic. So that was sort of the flow of how VCOP works. So let's take you through the journey. The initial concept was actually identified early but because, as Brent has said, the wave was quite quiet in wave 1, there really wasn't any focus on our program until October, November. A lot of work was done behind the scenes trying to develop the program. And then we really launched in December, right at the height of wave 2. And obviously, it started off as a pilot project. So we started at the Health Science Center, where we started initially from the wards, and then we started taking patients from the emergency department working at the Health Science Center. We got a project team started right in the middle of November. We had 3 to 4 weeks to get this project up and running in a pandemic. And I really appreciate all the hard work that it took to achieve this. We then moved on to our second site as it was clear that we were able to have success, and both the Grace and St. Boniface came on just in time before wave 3 hit. So we had all 3 tertiary sites and all 3 tertiary COVID wards now under the COVID team, the VCOP team. And then as wave 3, as this was a tremendous wave for us, as I'll show you the amount of work we put in, eventually we were able to look for other partners, and Boundary Trails reached out. We were able to add them as a referral site. And then finally, the urgent care sites in Winnipeg also wanted to get involved in VCOP if possible. And we brought on Victoria, Seven Oaks, and the Concordia Hospital really at the end of wave 3, and are now all part of our program going forward with wave 4. So let's talk a little bit about the success as we see it for VCOP by the numbers. 330 patients have been put into the virtual COVID outpatient program. About 50% are being taken from the hospital wards. These are inpatients, majority of them requiring oxygen, who are taken out of the wards and put in their homes safely, I will add, for the most part. Another good chunk of patients were coming from the emergency rooms. The Grace Emerge was one of our biggest suppliers, and that really was because that's where a lot of the patients were directed during wave 3 with respiratory symptoms. You can also see the AIAs themselves. These are patients who've flown down from the north who are at high risk for developing severe COVID. And we would go into those rooms there at the AIA sites with the paramedics and watch the patients there with them and make decisions of whether they need to come to hospital or not. And that's really how the program has evolved over time. And you can see 282 patients have been successfully completed their VCOP performance. Why others had to go back to the hospital for a multitude of reasons. But we were plucking patients in wave 3, some of the sickest criteria that we were taking just to try to help the system. But again, knowing that Epic was there to help us. Again, you can just sort of see we've served a number of patients from a lot of different health regions, but this was a Winnipeg derived program. And in the future, obviously, we'd like to see this outside Winnipeg and the future. Hopefully, especially with wave 4, where the burden may be more on the southern health region. But we certainly wanted to see if we can help. By the numbers, 2,200 hospital days saved. As you can see, the tremendous amount of hospital days saved during waves 3. The program has delivered a cost avoidance estimate of 660 hospital dollars per day for a bed. It would give us 1.5 million in cost avoidance. But the CAHI data suggests that number is much higher for a COVID bed. So that number may double or triple as we look through the CAHI data to see the cost savings of a virtual program like this to the healthcare system. But this is more than just hospital days saved. Dr. Embel it's really an infection control dream. As we take 330 patients out of the system and put them in their homes and prevent cross and nosocomial transmissions, which were huge in wave 2 and wave 3. Increased availability of hospital beds for higher acuity patients, even though Brent has shown us we had a lot more the sicker patients coming into the hospital. We gave those sicker patients the option to have these higher acuity beds. We decreased the use of PPE, of course, because people were out of the hospital. And the most important thing for us, and of all the clinics I've done in my life, this has probably been the most gratifying I've ever done, is having people plucked out of the COVID wards and having them in their homes with their dogs and their loved ones, virtually chiming in with us, sitting there on oxygen and finally feeling that there's hope for them. May was a tremendous month for us. We were taking 5 new people into the virtual system every day. And just to give you an idea, on May 30th, we had a virtual hospital running. We had 49 patients in the virtual program, 36 of them on oxygen. If you would have done the math, that would be really 2 extra COVID wards that would have been needed at one of the tertiary care hospitals. The amount of money that would have saved, I don't think you could well, we'd love to be able to put that together, but it's a tremendous cost savings for a virtual system like this. And we're really proud of what we accomplished in May and June. This is just one of our patients. This is Lynn. And just to give you an idea of some of the patient testimonials, Lynn had some complications. Because she was on the virtual system, we were able to recognize those complications. We got her back into the hospital and diagnosed and dealt with. Again, just another one of our stories. And these are just other patient testimonials. I won't read them all, but I'll read this one for you. The COVID-19 nurses and the team are great on the ward, but I hate hospitals. Getting me out early, being followed daily by a team of nurses and doctors while sitting in my living room has been a game changer. I love this program. I think, again, this has been an amazing clinic to work in, and I know my 12 or 13 VCOP colleagues also feel the same, and I've never had a problem filling the schedule. We're going to continue to be there for the fourth wave. We are looking at expanding our pool outside of Winnipeg, and that's really going to be the goal as we try to look at how wave 4 is unraveling. We're going to expand the program to other influenza-like illnesses, like influenza, like RSV potentially. And really the success of these virtual systems and our success in Manitoba is really going to drive the remote home monitoring programs for shared health, which is going to include other disease entities like COPD, heart failure, and type 2 diabetes as we roll out in the future. I'm just going to stop there, Rich, and just say a real big thanks to the team. I remember at the first meeting in November on the crust of wave 2 saying, all right, people, we're now going to start a virtual program in a pandemic. And again, I just want to really thank the Shared Health team and the team of collaborators that put this together for me. Sean Young, who I've mentioned before, the Shared Health Project team, Liliana, Cheryl, and Diego specifically, a team of amazing VCOP physicians who, despite working in the ICU on the VCOP boards, were also the same ones working in my clinic or in our clinic here at the hub. I want to thank the surgical departments, both plastic surgery and neurosurgery, redeployed some physician assistants for us that we absolutely needed in the wave 3 to help us. An incredible nursing team. We had a redeployed crew of nurses. The most nurses we had at one point was 4 of them working 12 hours a day on the virtual system, and the incredible VCOP support staff. And I'm going to stop there, Richard, and hopefully you guys got a good overview of what the virtual COVID program has been like.
Oh, thanks so much, Ken. That's I didn't realize just how expansive that was. I'd heard how successful it's been, so it's great to see some of the numbers and all the work that's gone in. Okay, good. So we do have a time to stretch after this, so that's great. So I'm going to actually go into that a little bit. But we don't have much time. So I'm actually going to try and limit this to 3 questions. So it's really important that everybody goes and actually votes these questions up or down. Okay, so let's put Brent on the spot. I'm really sorry, but yep, this is definitely a really important question. So plan for taking care of other medical problems. Will there be more deaths that are non-COVID because of these delays and reassignments? And that's definitely a piece that's weighing on everyone's mind.
Yeah, and I think that when we're talking about the public health restrictions and the response to things, is why we talk about that balance, because certainly the restrictions themselves have an impact on health. The surge of COVID cases on the healthcare system has an effect on other healthcare issues. So, as far as the healthcare system goes and the response to that, public health is doing what it can to minimize the cases and severe outcomes from the public health response. How we're going to catch up on surgical backlogs and diagnostic backlogs is going to be largely from the government and healthcare system. But from public health, like I mentioned, we have a lot of issues that we need to catch up on. So certainly there's been a lot of transmission that's gone undetected with sexually transmitted bloodborne infections, as well as the growing syndemic related to substance use. So this post-pandemic is going to be with us for quite some time.
Yeah, that's right. Okay, well, thanks, Brent. So, okay, I did. Yes, here's a question for John. I'm actually gonna. So, what percentage of eligible population needs to be vaccinated to achieve that herd immunity? So, Brent had kind of touched on it. I would definitely appreciate that additional input from you, John.
I'm going to defer to Brent Roustan. The number that I thought was about 75%, but I think this is a real community-based question. Brent, your thoughts?
Yeah, so there's a couple of things with this. One is you can see the connection between the basic reproductive rate, right? And so the higher that number, the higher the proportion of the population you need protected. So with wild type, we're looking at maybe 2.5%. So that would be 70% of the entire population. Now being 5.6% with Delta, the R naught, we look at, closer to 80 to 90, and that's of the entire population. And so we have a huge proportion of our population right now that's not eligible for vaccine, so those under 11. And so the eligible population that we need to reach is, closer to 90 or greater with Delta. So as we get approval for the 5 to 11, we'll have more of that total population being protected. So, again, it's all related to the transmission. The transmissibility of that variant, and Delta is just
okay. So this is I think a question that's on everyone's mind. Probably also Brent, this will be yours. But so do you feel that the COVID booster will become the norm, just like the flu vaccine?
So I don't think we should plan on having this pathogen being eliminated. I think this is going to be with us. I think it's likely going to be circulating as a respiratory virus during respiratory virus season. Obviously, it's hard to know where exactly it'll go, but we know that there's some evidence of waning immunity for transmission. Thankfully, there's not a whole lot of waning immunity for severe outcomes right now, early on. But that third dose is likely going to be made more widely available with time, and whether we need that each year, whether we see a lot of significant changes to this virus over time that requires us to change the vaccine, time will tell. But we should be prepared to be dealing with this virus every year.
Okay. All right. It's interesting. This question has been tagged for Dr. Ken Casper. So let's hear your answer. But I have a sneaky suspicion you might defer this. But but how are we doing globally in advancing vaccines? And without this variant, so without this effort, we can only expect more variants to occur.
Yeah, I think that question is correct. I think we are going to expect more variants, and I think Brent has already alluded to that. But I've had a chance to see the Moderna presentation, their mRNA technology. The fact that they're able to redevelop a potential vaccine in 62 days is breathtaking, and I think it's given me personally a lot of confidence that even if another variant arrives, the mRNA technology is going to develop a solution. So I really think today I feel much different than I did 2 months ago, I can tell you. So if that helps, hopefully that helps answer your question.
Yeah, and it is. We're in a very different place for vaccines compared to even the H1 pandemic. Completely different place. So that's fantastic. So I'm going to throw this. Although I think Brent touched on this. Could you have a quick comment on the vaccine under 12 years of age? I know you had just mentioned that. Can you comment any further on that, Brent?
Yeah, so nothing too specific. That Pfizer has now submitted the application to Health Canada, And so we are hoping on that there's a relatively short turnaround on that. We already have plans in place for implementing this. So once it's approved, we'll be able to move on those. So I can't give a definite time frame because that really is in Health Canada's hands, but it is appearing to come a lot sooner than what we expected. We didn't really think that we would have needles in arms until the next calendar year. So so I do think it's going to be a lot sooner than what we expected.
Mm-hmm. Great, that's great news. So very last question, and this will actually go to Dr. Kasper. But super important because it's such an innovative program that you've done. But you had touched on expansion to northern units and rural regions. Can you just give us a 1-minute synopsis on that?
Yeah, sure. We're really in discussions with all the health regions, including the First Nation communities, of trying to see who we can partner with, what's the best next move, the logical move for us. That some of the challenges is email access, the kind of technology we're currently using, which is always going to be a challenge in some of our remote communities. And obviously that's a game changer for us. We need that to communicate. Again, as well, the challenge of having patients remotely is that if they are doing worse, what's the strategy for getting them into the system, the healthcare system? And again, that's why we've really stuck with the major centers right now. But at the same time, I think the future of remote monitoring has to include the remote communities. That's really the hope of that. And hopefully new technology will be able to solve that solution.
Yeah, there definitely are some silver linings with the pandemic, vaccines, virtual care. It's actually been amazing to watch, and really appreciate all the work you've put into this, in that it's actually a hospital as well. So, okay, so everybody, I fully understand there's lots of questions, but we've all been sitting potentially for 2 hours now. We definitely have to all get up and have a little stretch break. I want to really thank all the speakers that we've had so far. Excellent presentations. And so a reminder, everyone does need to go back to Slido. You go back to the speaker evaluation component. It's really important for the speakers that we fill this all in. And then please also do the evaluation so that we at the university, we can understand if there's new questions, and we will keep all these questions that were on there, and this will help us with development of Bug Day next year as well. So go back to Slido, and if you haven't registered and you still want credits, you need to go back to our CPD website, cpd/umanitoba.com, and register. And registration is open all the way till 4 o'clock, and then you get this free credits. And so very brief stretch break, and we will start again at 10:15. So we'll see you then. Thank you. Well, welcome back everybody to the 25th Bug Day. And so we will keep that 25th theme for the next 3 speakers. So our first speaker is Dr. John Connolly. And if any of you have any idea about infection control, you will know Dr. John Connolly's name. He's a professor of medicine, microbiology, immunology, infectious diseases, been at the University of Calgary for many years. He's a consultant in clinical infectious diseases to multiple parties, not just in the clinical realm, and very, very involved in antimicrobial resistance and stewardship, prevention of hospital-acquired infections, novel innovations in healthcare. Really, really looking forward to your presentation, John. Infection Prevention and Control's top 10 list, looking back for 25 years.
Thank you very much, Rich, for the kind introduction. It's a great pleasure to be here, to be able to present to you. This is my third Bug Day, and I'm very honored to have the opportunity to speak to you and also to listen in on some sessions to see what I can learn on the 25th anniversary, the silver anniversary of the Bug Day. So just a quick territorial acknowledgement. I am presenting from Calgary on the traditional territories of the Blackfoot and Treaty 7, and also Métis Nation of Alberta, Region 3. My disclosures, and the one of relevance is that there was work that I did as a local PI for the Staph aureus vaccine for prevention of surgical site infections and spinal surgery. Unfortunately, it didn't work, so back to the drawing board with Staph aureus vaccines. But none of the money came to me personally. It all went to the University of Calgary. And then the rest of the disclosures are mostly academic related activities. The objectives for today are to look at 10 major IPC issues over the last 25 years. A daunting task. I'm still wondering who dreamed this one up, but I see the rationale for it. Discuss these 10 major issues, and then to understand the importance of some fundamental IPC skills, which really haven't changed all that much, and we're still looking at some recurring themes. Choosing the top 10 list, not an easy task by any stretch of the imagination. I still wonder who dreamed this up. I'll be speaking to my friend, Dr. Emble, after this session. So in looking at this, I was looking at both disease entities and themes and decided to focus on a combination of some specific pathogens, illnesses, and some general themes that came from that. The choice was arbitrary, but I put some thought into it. So on the top 10, we'll start with the first 4, and then I'll discuss some of the items associated with it. The rise of the zoonotic viral infections. So here we've got things that are important, such as the zoonotic coronavirus infection, SARS-CoV-1, SARS-CoV-2. Hopefully there's not a 3 and a 4, MERS, Ebola, and then other viral hemorrhagic fevers. There's been a rise in Crimea, Congo, viral hemorrhagic fever, in some parts just around the Middle East. And the subtext of this is to look at applying the knowledge of human factors and ethnography to improve how we interact with the system, and this relates to PPE. Similarly, H1N1 influenza, avian influenza, that remains a concern over time. And subtext within this is the role of vaccines, and I'll touch on that a little bit later. Antibiotic resistance, which is a major issue as well. Looking at some of the biggies, MRSA, VRE, extended spectrum beta-lactamase producing organisms, and carbapenemase producing organisms. And then, of course, C. difficile, which now renamed to Clostridioides. So just to look at Ebola, SARS-2, avian influenza, one area that I think is very important to focus on is correct donning and doffing procedures. We all work in the hospital, in the healthcare setting, long-term care, I'll add into that list. And the procedures of donning and doffing are very important to minimize any risk of inoculation. And this term, precision of execution, in my mind, is key. Not so much what you're wearing, but the precision of execution in donning and doffing. And I'll touch on why that is important in a moment. They've used the buddy system for many years in Africa in dealing with Ebola. And after having some outbreaks and nosocomial infections with healthcare workers, this buddy system has worked well. We've got somebody observing you as you're donning and doffing to be able to facilitate making certain that you have no slip-ups, and also avoiding harms of too much or ill-fitting PPE. And then there is documented risk of transmission with inappropriate PPE, and particularly doffing. This is where human factors comes in. Human factors is applying that knowledge of human characteristics to improve the interactions with the system. And some of this takes us back to work that was done by Jan Davies and the Winnipeg model, actually, which goes back many years about patient safety and how important it is for everyone in that regard. So this is looking at how you operate in the system. So in this case, how do you don your PPE? Where is it situated? Is it easy to get to, easy to take off within the design of the hospital systems? And sometimes hospital wards weren't purpose-built for donning and doffing, and we have to jury-rig the system. We had done some work in our health system with human factors and extensive videography, almost a half a terabyte. We published this some years ago, and we made a huge number of systems factors changes in the system. And hopefully it prepared us well for SARS-CoV-2, but the lessons that we should have learned have come back yet again. One of the areas is in this issue of PPE, and I'll just touch on it, N95 versus surgical mask. It's an area of some controversy, depending on your background and where you're situated. Current data do not suggest there's any differences outside of the AGMPs. And we've just completed a scientific rapid review just published last month. Most of the studies found are observational studies, and they're of low quality of evidence, but none are showing any significant differences overall. And we are awaiting the final high quality RCT that's run, a Canadian study out of McMaster. Our center enrolled 175 healthcare workers, and hopefully it'll be completed by the end of this year. At the 50% mark, an independent safety monitoring board found no safety signal whatsoever in terms of the outcomes. Of course, it's blinded, so one doesn't know where they're occurring. We've got some interesting data in Alberta. The proportion of healthcare workers who are positive for SARS-CoV-2 is lower than the general population, despite 3 times increased testing. And they've just finished an analysis that they put into this review in September of 1,400, and it's a pretty large number of healthcare workers. If you look at the community acquired or indeterminate, meaning there could have been a community onset, but uncertain, almost 80% come out of the community. And then of the 23% that were considered to be workplace acquired after intense investigation, 2/3 relate to exposure to an infected patient, and 1/3 to coworkers in break rooms, which is very interesting. And of those situations with AGMPs, 2/3 reported a breach. And there's been a recent study just released last week from Boston with 2 different hospitals, one using only N95s as part of their PPE, one using surgical masks, and there was no difference. Just as many people using N95s developed SARS-CoV-2, which would suggest, and they tried to adjust for community exposure, suggesting that there are multiple modes of transmission of this virus. And we've started an audit system, both observer known and observer unknown, so healthcare worker unaware, and have over 1,000 observations in the healthcare worker unaware. And we have actually found that doffing is as low as 54%, even on a ward where there are known COVID patients. So we know that there are still errors occurring. When we looked at the comparison to coached and healthcare worker observed, where they knew there was someone watching them, of course, they're next to perfect. So it's very interesting to see what the real doffing error rate is when it's done anonymously. Turning now attention to carbapenemase resistance, and this has been a big problem going back almost to the 2011 now, with the rise of the carbapenemase producing organisms. And as an example, and this is for all AROs, we need comprehensive IPC measures, surveillance, isolation, appropriate PPE, good hand hygiene, cohorting of patients, and then a new item, microbiome manipulation. And people are looking at this actively, which I think will be looked at perhaps in another session. And interestingly, with respect to influenza or C. difficile, it's associated with antimicrobial use, and stewardship of antimicrobials is very important. We've uncovered some recent evidence in a study looking at seasonal variation, and our statistician looked at both a harmonic regression and a cross correlative analysis. And you can see here that there's a spike in the number of cases of influenza over the years. And then following that, you can see a rise in C. difficile. with one exception, which is very interesting because we showed this very tight association. We haven't looked, but we think it's because of increased antimicrobial use, and it makes sense when you think about it. On the top 10 bundles and checklists, just to cover them very quickly, in antibiotic stewardship, there are many bundles that have been used. We have central venous catheter bundles, surgical site, ventilator-associated pneumonia bundles, urinary catheter bundles. We're trying to get rid of urinary catheters in the hospital as much as possible, pressure sore bundles, and now shunt insertion and pacemaker insertion and cardiac device bundles. All of them important. We don't know which is the major driver, but if the bundle's done appropriately, we can actually see reductions in nosocomial infections. Here's the pacemaker insertion checklist. And it's a very simple, it's modeled after the WHO checklist, a yes and no if you've done this. I'm not going to go through all the details, but these checklists are very valuable. Antibiotic stewardship, from looking at antimicrobials as a panacea, and you can see the antibiotic head here, when we used to want to use it for everything and for prolonged periods. Short course therapy is the order of the day now. And this is a recent publication in the JAMA journal looking at recommendations for short course therapy. And I can recall my training days, original studies done in Winnipeg looking at short course therapy for uncomplicated cystitis in women. So we've come a long way since then. In the top 10, to finish off, looking at hand hygiene, physical plant design, and vaccinations. Sir William Osler, soap, water, and common sense, still the best antiseptic. We still have ways to go, but there's been general improvements, particularly with audits. And I'm a big fan of anonymous audits for hand hygiene, which I think are more telling than observed audits where the healthcare worker is known to be being observed. I know when I'm with a student and I see the hand hygiene monitor, we are meticulous and do a great job. But when we're in a hurry and no one's watching, that's another setting. Physical features to enhance physical plant design, widely spaced beds, good ventilation, ease of environmental cleaning. A nice systematic review from 2016 showing that multi-bedded rooms are associated with much less transmission of nosocomial events than or single-bedded rooms than multi-bedded rooms. So that's sort of the new moniker, is to try to design single-bedded rooms or at best double-bedded rooms. Finally, vaccines, to talk about COVID-19, and I'm just going to use this as an example. We know that these vaccines are very effective. We've heard from a couple of the other speakers, so I won't spend too much time on this, but very important to look at the vaccination and the fact that we've got a lot of industry power to be able to literally within a couple of months turn on a dime to create new vaccines that will protect us for future variants as they arise. And finally, in the top 10, this is a segue into the next discussion. Innovations in IPC, microbiome manipulation, which is gaining traction to try to ward off a more natural process to prevent MDRO colonization. Whole genome sequencing for outbreaks, been invaluable in COVID-19 to show multiple community influx where you thought an outbreak was due to a single type of strain. New materials, photo-activated antimicrobial surfaces, and notably methylene blue. Silver, copper impregnated devices. Ultraviolet light is coming back. Nature's disinfectant, we're now bringing into the hospital, both for small medical devices and also for room disinfection. And then harnessing big data and AI, and then the use of interaction design and human ethnography coming in as a new tool. Interaction design, a relatively new science, but I look at it as the merger of science and art. How do we take interaction of the technologies that we have and shape user experience? Work is being done on this in hand hygiene settings where you've got monitors next to your hand hygiene stations and hands fly out and that you get an audio, great job, nice job, good hand wash. And it's been shown to actually increase compliance, particularly in children's wards. And finally, this is what I want to see in all of our washrooms, hospitals, restaurants, the ringing bell, didn't wash hands as you exit the washroom. If we could master this, perhaps we would improve hand hygiene. Thank you for your attention.
Well, thanks very much, John. It's great to see that you finished with a Far Side comic. Okay. So I'll move straight on to our next speaker so that we can have more time for questions. So Dr. Chris Sikora studied here at University of Manitoba and then absconded off to Edmonton. That was terrible. But he has done excellent things out there. He's a specialist in community medicine, and he's the lead MOH for Alberta Health for the Edmonton zone, and he helps lead teams involved with primary care, communicable diseases, and obviously infection control, and works a lot with core population health areas. So he's going to be speaking about infection prevention and control, looking into the future.
Thank you very much, and thanks very much for the opportunity to be here today. So I am a former Winnipegger, completed part of my training in Winnipeg almost 20 years ago now, near the beginnings of the original days, the early days of Bug Day.
That's right. We were in class together.
We sure were. That seems like a long time ago. Just to clarify, it's Alberta Health Services, not Alberta Health. I'm not with the ministry. So I am just a simple medical officer of health here in Alberta Health Services, a large regional health authority, and really reflected on the last 2 years together. There's probably a lot of areas where we could improve or that are possible for the future. So, and again, these are things that I just dreamed up and then chatting with many of our colleagues here. The big question we often asked is, what's happening outside of our groups? So really, I think this is the future for infection prevention and control. And I'll walk through a few of these in the upcoming several minutes. Really, the basic principle being, can we focus on the outside? So really, our teams inside our hospitals do phenomenal work, but what can we do to monitor and manage risks outside? So I'll perhaps preempt the bulk of the presentation with the take-home points being practices within community and public spaces, emerging technology for PPE disinfection or tracking, focus on the importance of animal and wildlife health as it's related to human health, and then a strengthened need for city, regional, provincial, federal, and international coordination and collaboration. So what we've seen over the past couple of years is a huge amount of social and organizational upheavals, huge social impacts, economic impacts, population level mandates, emerging technology, new medical advances, and really heightened needs to work together. So if we really refresh on what our core targets have been over the past couple of years, it's been reduce transmission events, save and protect the healthcare infrastructure, and protect the most vulnerable from illness and death. And if we add and layer a couple extra on top of that, we can monitor our current state of health, both locally, provincially, nationally, internationally, and prepare for future events. So as a community, we do amazing things together. So here I was able to grab a couple screenshots from one of the more recent reports. So this is our apparently non-existent influenza season over 2020-2021. So our community-based IPC efforts, coupled with amazing activities within hospital and facility settings, resulted in exceptionally few cases of influenza across Canada. This is ultimately mirrored in numbers of GI cases as well as other respiratory pathogens. So community-based interventions, those things where everybody in the public does, is actually possible. So we have a role to play in stopping transmission of pathogens. So that's being in the workplace, in our individual settings, in our schools, in our homes, as well as in our healthcare facilities. So how did we do all that? Signs, and signs. So masking, distancing, staying home when you're sick, no touching the eyes, the mouth, or the nose. But most simply, social innovation. Changing our personal practices has helped in meeting those targets of reducing transmission. So it doesn't come without cost, or it doesn't come without upheaval. So change is always difficult. So certainly many of those interventions that have been put in place across many healthcare settings have caused issue or have caused concern. People are upset about masks. Well, we have to convince people that it's something appropriate to do. People are upset about not having large gatherings together. Well, that's part of the social change. But when we as a society decide to do this together, we can actually reduce transmission events significantly and ultimately protect our population from getting ill, as we've shown from COVID-19, also from influenza, also from gastrointestinal disease, as well as many other things that are transmitted at least through the contact and droplet means. Now, I know we're going to have a talk about syphilis next. Maybe different social innovation is needed for that environment. So these are just some core pictures from around Alberta, very similar across Canada, empty places, people staying in, people doing the physical distancing thing, staying home when you're sick. So we've done a really amazing job of being able to change the mind of the public. So being able to do all these activities together to be able to change the outbreak curves is something that I think is going to be our future. So infection prevention and control outside of our facilities and into more of the community settings. So one of the other hallmarks of our last 2 years has been resource limitation. So resource limitation often drives innovation, and definitely opportunities were explored in the early days of the pandemic. We had N95 disinfection and reuse exploration. So can IPC apply its tried and true and really battle-tested methodologies in assessing efficacy of disinfection and sterilization to reuse other equipment in a resource-limited environment? How can this fit into current RHA and provincial infrastructure? How do we share learnings across provinces? So certainly, events like this can actually drive innovation. And now we have disinfection robots fighting the coronavirus. You know, I don't know. This just looks like a Roomba that causes melanoma or squamous cell carcinomas. But really, is this something that we can apply technology on to help reduce risk and increase safety within our hospital environments? Can it actually be applied elsewhere as well? And certainly some industries are taking this on. So again, using technology in a community-based infection prevention and control realm, there are some airlines who are exploring use of UV light to be able to disinfect airplanes. What other technologies? And really emerging technologies around engineered nano water particles using really reactive oxygen species or peroxide to be able to keep your hands clean. And certainly these are things that are being looked at, but can we actually increase the efficacy, make hand washing 2.0, make it gooder, make it more effective, quicker, faster, safer, ultimately, to be able to create environments where within hospital environments, within physical environments, within other workplace settings, you can do things easily. And really on the opposite end, the technological fix, instead of singing happy birthday, this timer on the bottom half of the screen, that when it activated counts down the requisite 20 seconds, and for you to scrub and keep your paws clean. Now, other technologies have emerged as well. So we have all of our tracing apps, we have exploration of near-field technology, Bluetooth, to create really that mechanism of contact tracing, and really most recently that innovation on passport and vaccine passports. So certainly new technologies being applied in terms of tracking individuals, but ultimately keeping and monitoring our health status of our population. So, and really to bring us back to the beginnings of COVID-19, emerging need for all of us to be very aware of the tight connections between animal and human health. So we got a good experience from influenza around chickens, pigs, or other birds, but the emerging work in the areas of pangolins, camels, bats, so maybe SARS-CoV-3, SARS-CoV-4, and really we have to be able to monitor and improve animal health as critical importance to really improve our human health. You can't separate them. So I know we're all very much aware of this process, but things that could expand in the upcoming several years are emerging pathogens, for sure, antimicrobial resistance. So because really who knows where the next pandemic is going to be coming from? It might be 2 years from now, it might be 20 years from now. But together with environmental health specialists, we have a better chance of understanding the landscape to be better able to respond. So we all remember this from the last year. Simple blockage in major transportation artery has major effects globally. Billions of dollars lost globally daily and lives around the world impacted. So we're all interconnected. And that goes for also pandemic response as well. So the future in the IPC world is, well, we all have to work together. So what do we do around local health, provincial, national, international, to be able to work around standards, monitoring, surveillance, implementation of practices, as well as messaging. And just to expand upon the messaging, infodemics, oh my goodness, I remember this being coined, I think it was March 2020 by the World Health Organization, that really infodemics, the spreading of false health information, spreads faster than the illness itself. And certainly we've had all of the ivermectin stuff, we've had the vaccine difficulty things all out there, and there are so many pieces of misinformation during their course of learning together that this is going to be a major task for both public health but also infection prevention and control. So we need to be able to get vast improvements in sharing of trusted information amongst partners, really to improve social trust, have greater consistency of our interventions, and ultimately to improve our health overall. And just some other things that we've observed: social distancing, and can't forget our Prime Minister's daily news conferences under the white tent that were all very appropriately social distance. So exiting the pandemic and looking forward to the future. So just to recap, we need to be able to focus on community. We can do amazing things. We have emerging technology that has to be tested, but really embraced to be able to expand upon tracking, upon disinfection, to be able to respond to resource allocation or resource challenges. We have to not forget about animal and environmental health as it pertains to human health. So we need to all work together on that. And then that there's strength in partnerships. How do we collaborate and communicate to be able to get together, to be able to respond to this? And just as a closeout, well, social skills at the beginning of 2020, and then a year later, I think we're all still here coming into work and giving our best to be able to help improve the health of our population. And with that, I'll turn it back over to you, Richard.
Oh, thanks. Thanks very much, Chris. Very thought-provoking. Lots of worrisome things there about infodemics, I have to admit. And I think John actually has a great question for you about that, but we'll touch on that later. Let's move straight on to our last speaker for this section. Also following the whole 25-year review idea. So I'd like to introduce Dr. Michael Isaac. So Mike is the MOH for the Northern region here in Manitoba. He's been very instrumental in First Nations health, but also very instrumental in managing a lot of our STBBI outbreaks here in Manitoba. And actually he was also the Chief Public Health Officer for a brief time before Brent. So I think you have some really good insights to this. And so you're going to speak about syphilis in Manitoba and a 25-year review.
Thanks, Richard, very much for the introduction. Very happy to be here. I just wanted to do a check-in. Can you see my slides okay?
Yes, we can. You just have to go into presentation mode.
There we go.
Yep, there we go. Thanks.
So I wanted to start with a thank you. I had some help on this presentation from Lexi Anderson and Tammy Stewart-Chester, as well as several folks from the lab. So thank you very much. Thanks so much, John and team. I couldn't resist putting a picture of Soapy here. What other infectious disease doc in Canada would put on a spandex and pose with a Siamese cat and put that in public? There isn't one. So we're very lucky to have you, John and team. Thanks so much for Bug Day. It's been an awesome 25 years, and I'm really honored to be a part of the 25th celebration here today. I also wanted to do an acknowledgement. I'm in Winnipeg, Manitoba. Manitoba's Treaty 1 through 5 territory, home of the Dene, Cree, Oji Cree, Ojibwe, Dakota, Anishinaabe, and homeland of the Métis Nation. And we're going to talk a little bit later about intergenerational trauma in residential schools and how that fits into what we're seeing in Manitoba. The objectives for today: review historical rates of syphilis in Manitoba and talk about some public health efforts over time. Secondly, we're going to look at some of the changing dynamics of syphilis risk factors and some of the underlying determinants of syphilis in Manitoba. and then just briefly get into a few clinical tidbits right at the end around diagnosing and managing syphilis. I couldn't help but start with a joke from Stephen Colbert. And Chris and John, I really apologize. This is throwing Alberta under the bus, but this could easily be Manitoba as well. So Stephen Colbert highlighted the rising syphilis cases by saying there are a horrifying number of syphilis infections in Alberta. What is up, Alberta? And watch out, Saskatchewan. If you keep rubbing up against that, you might get an infection in your vagina. So syphilis, we know, has been on the radar, even down into the US and making waves down there in terms of our rates in Canada and on the prairies. Briefly, so syphilis is a re-emerging disease. It was an infection that was quite common in the past and has really come back with a bang in many different populations globally, including in Manitoba. The bug is Treponema pallidum. It's a bacteria. And as you can see from the photo here from the CDC, it has kind of a spiral shape to it. So we call it a spirochete. Direct sexual contact is the main way that syphilis spreads. It can spread through oral genital contact, through other sexual contact. And we've also seen vertical transmission, so mother-to-child transmission in Manitoba, and we're going to get into that a little bit as well. Incubation period is 10 to 90 days, so that's the period from when you're infected until symptoms start. That can be quite long for some people. And syphilis has many stages, so it can be confusing to some individuals. The primary stage is the start of syphilis. You get a painless chancre or ulcer, usually on your genitalia, but it can also be on your lip. It might be in your pharynx or oropharynx, and from there it can spread throughout the body, which is a secondary stage. So during the secondary stage, you get a spirochetemia in your blood, lots of spirochetes, fever, chills, a rash on the palms, hands, and the soles of the feet is really classic for syphilis. Asymptomatic infection can occur if you've been infected within the past year. It's early latent, past a year is late latent. And even decades down the road, you can have symptoms from syphilis. And so tertiary syphilis includes infection of organ systems, including the cardiovascular system, liver, et cetera. All kinds of different organ systems can be affected. And congenital syphilis is syphilis in an infant that's acquired in utero. Neurosyphilis, just before we move on here, can happen at any stage. So that's an infection of your brain or meninges or spinal cord. So here's a look at syphilis over time. Thank you so much to Paul Van Kessel at Cadam Lab for this data going all the way back to 1942. And so you can see during the war, we had a lot of syphilis around. The blue line here is all syphilis, so that would be all the different stages of syphilis here that we're capturing. And the orange line picks up on infectious syphilis, so that excludes latent syphilis. Just something to keep in mind when looking at the data. The red arrow here, number one, is when penicillin was discovered by Fleming. That really helped to bring down rates in the late 40s. We were in the post-war era, learning lots more about syphilis, and rates came down quite nicely until around the 60s, 70s, where we had a bit of a bump. And then you can see over time, once we got to the late 90s, we had very little syphilis around at all. This is in Manitoba, and so number two here, the green arrow, was actually a little bump in cases that we had in the Winnipeg region over a number of years. And in conversation with Pierre Plurd, he's telling me this was really two distinct syphilis outbreaks. So one was in a population of gay and bisexual men who have sex with men that were attending bathhouses, and the other one was a heterosexual outbreak in local bars. Both of those outbreaks were brought under control in Winnipeg by the public health team. But another period of low cases around 2010 to 2012, and then we started seeing cases pick up again. So the third arrow here is an outbreak that started in gay, bisexual men who have sex with men in Canada. It was urban focused. So in Manitoba, that was Winnipeg, but other urban centers across Canada also saw cases. And that was really driven by a lot of anonymous sexual activity that was facilitated through things like mobile apps. So things like Grindr, for example, were driving that. And then you can see right at the end there, we had such a huge spike in our rates. And number 4 is a movement of syphilis into a young heterosexual population in Manitoba of people experiencing structural disadvantages. And that's what continues to drive our epidemiology at this point. Focusing in a little bit more on the last few years, the last 5 years, you can see in 2019, we had our highest case counts ever on record. Almost 2,000 infectious syphilis cases. So that would be primary, secondary, or early latent stage syphilis. And we've seen a shift in the male to female as well. Females are really catching up. This is not only new to Manitoba. When I was reviewing some of the reports around epidemiology globally, there was a great line from Public Health England that cases of syphilis in England have increased considerably. 2019 was the year of the highest number of diagnoses since the 1940s. So that mirrors our epidemiology in Manitoba to the year, which is fascinating. I think that we're seeing this global preponderance. US and Australia have also seen similar trends in their syphilis epidemiology. So Alberta and Manitoba are not alone. In Canada and other jurisdictions in Canada have seen that as well. A few points about the epidemiology. We talked about rates in women. Women are actually increasing faster than rates in men. And that plays into women of childbearing age who are at risk for syphilis and for passing that on to their infant. It's really a tale of 2 separate outbreaks, gay and bisexual men who have sex with men. And we've seen that outbreak seem to level off here in Manitoba, but heterosexual transmission really continues to drive our rates in Manitoba. Looking at our test positivity rates, they seem stable now in Manitoba, but our testing numbers are down. So we very much likely are missing cases of syphilis in Manitoba. And that certainly has been affected by COVID. So fewer people accessing care, fewer people getting tested in the context of the same test positivity rate means we're missing cases. Neurosyphilis cases are on the rise. Kadam provided some data to me around that. The number of tests for CSF specimens is going up for syphilis. The number of positives there is going up. And then congenital syphilis, and we're going to have a look at the epidemiology here in just the next slide. So this is congenital syphilis monthly case counts. This is both confirmed and probable, going back to 2015. So when we had our first case in 2015, we hadn't seen a congenital syphilis case in decades, and it was a real shock to our system. We knew that in public health we needed to do more. But despite our best efforts, we've really seen a rise in congenital cases, which is commensurate with a rise in cases in other jurisdictions. So Alberta has also seen a very significant congenital syphilis outbreak, as well as jurisdictions in the US, states in the US as well have seen this. So we're not alone. But certainly it's very concerning. Congenital syphilis can lead to all kinds of issues in the infant if not treated appropriately. And they can have long-term sequelae. Not to mention the costs of $10,000 to treat a case of congenital of confirmed or probable congenital syphilis. Some important factors that we're seeing in the literature and also here in Manitoba is that we've heard this term syndemic today already. It's the interaction between biological and social factors that increase susceptibility or harm to a certain health outcome. So in Manitoba, there's a real strong link between substance use and sexually transmitted bloodborne illnesses. And I think sometimes we focus on substance use a lot, or problematic substance use, but really what drives a lot of that substance use and the problematic nature of it is underlying social determinants, things like housing insecurity, intergenerational trauma with adverse childhood events and trauma leading to emotional pain and self-treating with substances. Intimate partner violence is involved as well in terms of a risk factor around syphilis. If you look in the literature, and incarceration certainly as well plays a part. We have very high rates of syphilis in corrections in our province. We can't discount the lack of access to care. So in Manitoba, with our congenital syphilis rates, we've seen many moms who just are not accessing prenatal care for various reasons. And we need to think about stigma and racism in certain healthcare environments. People have experienced racism and they don't want to access care anymore. And so we're not seeing them in clinic. We can't do the testing and the screening and the treatment that we need to do to prevent that congenital case. So it's been a very difficult factor in our congenital syphilis outbreak in Manitoba. Quickly wanted to go through some public health efforts. This certainly is not all of them, but case and contact management is the bread and butter for syphilis. Now we continue to do that in Manitoba. We've done some enhanced surveillance, trying to get a sense of what the real risk factors are around our syphilis outbreak, and do some network analysis there. Screening in pregnancy has been increased in Manitoba. So we used to screen just once for most moms in the first trimester. Now it's recommended that every mom have a test 3 times in pregnancy. And if you're infected during your pregnancy and treated, you should have it monthly. You should have syphilis serology monthly and at delivery as well. Harm reduction expansion. So again, getting back to that syndemic, we can't, just look at syphilis in and of itself and the biomedical interventions there. We need to think about harm reduction and how we can get the word out, education, testing through our harm reduction networks. We're very fortunate in Manitoba to have a wonderful harm reduction network with many community-based organizations that we've been able to partner with to do, for example, testing events where we'll have people come out that we wouldn't typically see in public health. And then working with emergency departments as well, because we know many people access their first point of contact with the healthcare system, or in some cases, their only point of contact is in the emergency department. So linking people with harm reduction, with addictions treatment, with STD/BI testing is important, and those are efforts that are ongoing. A few clinical considerations. So for those of you who are seeing patients who may have syphilis diagnosis, you can actually swab the lesion. So I think a lot of people know that you can do blood work. We do serology, and Catam Lab will do treponemal and non-treponemal testing on with the serology. But you can always swab the lesion if there is a lesion. Don't forget that, you might have a lip lesion or a lesion in the throat, and you can send that off to Catam for PCR-based testing. Treatment, we've seen a mix-up in the past between the long-acting and short-acting penicillin. So the treatment for infectious syphilis is bicillin or penicillin, benzathine penicillin G. It's 2.4 million units in single dose for infectious syphilis. Short-acting penicillin or Pen B won't work. So just something to keep in mind. I think in practice, we're going to start seeing more tertiary syphilis and neurosyphilis as well. We talked about neurosyphilis a little bit. But I do think that we are missing cases of syphilis, and in the coming years, we are going to see more cases of, for example, aortitis or other organ systems being involved. So something to keep on your differential diagnosis. Syphilis is the great imitator. So think syphilis, especially if you have a rash that is not responding to treatment. It could certainly be syphilis, so something to keep in mind. We're talking about 25 years of syphilis, but really I think taking a step back and thinking about communicable disease overall, if you're looking at Hep C, Hep B, TB, invasive meningococcal disease, the list goes on and on. Really what we're looking at here is populations that are experiencing structural inequities that are affected the most, and we're seeing a concentration of those communicable diseases in that population. including those who experience historic and ongoing systemic racism. So we really need to think about that in terms of our interventions and how we can decolonize some of our public health efforts around syphilis. I'm going to skip the questions here because I think I'm at time. I see Richard, and Richard's bearing down on me. A few references there as well for those who are curious to read more. So thank you very much. Real pleasure to be here.
Oh, thanks, Mike. Excellent presentation. It definitely has changed from the 40s. So, okay, it looks like I'm going to skip right over to our questions because it looks like we definitely have a few, and we've got a full 15 minutes. So I think this could become a great Q&A session. So just a reminder to everybody, you have to go to slido.com. It's bug 2021, and we've already got a few questions up there. All right, so and we'll rate them up and down, and then we'll get the best ones for the next 15 minutes. So do you foresee MRSA losing its contact precaution status like VRE has? A fascinating question. So, sorry, John, I'll put you on the spot.
Thank you. That's a great question, actually. And I would say no at this point. We are seeing, actually, interestingly, MRSA slightly on the rise. The recent Canadian CNIPS data suggested, and we're seeing that in our own institution, perhaps related to COVID and the fact that we've got a lot of, in our ICU, a lot of doubled up patients because we had very large ICU rooms and they were able to double up some of the patients. So I don't see MRSA going the way that VRE did. And one of the primary reasons is its pathogenicity. When you look at Enterococcus and Staph aureus, there's a world difference in terms of the invasiveness and severity of infections caused by those two pathogens.
Good. In some ways, you kind of touched on the next question, but I'll throw this out to whoever wants. So with our increased focus on hand hygiene related to COVID, have we seen less hospital-acquired C. diff or MRSA, hospital-acquired MRSA? Anyone with some data on that? You would kind of expect that we would, but maybe we didn't, maybe not.
It's John Connolly. You've got competing situations here because we have, with COVID, increased antimicrobial use. There's almost an auto population of orders for ceftriaxone and azithromycin for every patient that had been, even though we say don't bother. We have seen a fairly significant rise in our own jurisdiction at one of our sites that handled a lot of COVID patients, and correspondingly a little bit of an uptick in the C. difficile. So great to have good hand hygiene, but at the same time, antimicrobial usage drives the colonization with the C. diff. And so it's not just hand hygiene, because with C. diff spores, it can live for a long period in the environment. So then they pick it up, and then the antimicrobial receipts allows the overgrowth of the C. diff. So you've got competing demands going on in that regard. So I don't think we've seen the last of C. difficile or MRSA.
Yeah, such complex organisms, that's for sure. Complex diseases. Okay, so, I think, Chris, you would probably be able to touch on this. How can we combat misinformation and promote trust using the latest science in community when we don't have 100% buy-in from healthcare workers? Sorry, that's a toughie, eh?
Yeah, that's a tough question, Richard. I think it's really acknowledging that as part of the scientific process, we're almost never 100% certain about stuff. I mean, we have theorems that are 100% certain, but the vast majority of science has uncertainty associated with it. And I think our messaging that we use in most of our communications is always hedged. It's always saying this is the best evidence at this point in time. We know evidence is going to change over time, and certainly that trust when we are in an uncertain environment, is difficult to do. Many of our leaders and many of our public health folks, many of our best communicators actually communicate that uncertainty. They will fully acknowledge that there is difficulty in getting near certainty with any of our public health messaging. And certainly what we do want and hope for all of our healthcare workers is to be able to appreciate that the scientific process takes time. That takes trust. And within any of our populations, within any of our workforce, with any of our healthcare worker categories, we often don't have all that trust necessary or needed to be able to get to that ultimate end goal. Trust takes time. And so what we always do, and what we always should be doing, is helping work to develop that trust, that comfort, and that ability to be able to embrace uncertainty, embrace what we do know, and identify where we don't know.
Yeah, and would you like to comment on, or any of you comment on, the elephant in the room on then how do we manage the media, though? Because they are not aimed at moving trust forward necessarily. Sorry, I have to hit the elephant.
I'll perhaps ask Michael and John for their experiences as well. We work with media in a very transparent way. We acknowledge what we do know, where we don't, and developing that trust does take time and ability to identify what we know, what we don't, and it's always time limited. What we know at this point in time isn't what we'll know a year from now, a month from now, or even a day from now.
Any comment from the other two?
It's John Conley. I'll just comment that social media is in absolute overdrive during this pandemic, and even mainstream media has tended to be, in my opinion, more tabloidish and sensationalistic, which doesn't help when public health authorities are trying to manage the pandemic and many of the unknowns as best as possible, and trying to use scientific principles to be able to guide the response to it. But sensationalizing things can be detrimental, and I think we need to maybe ratchet it down a little bit from the media perspective. I know from their view, they have an obligation to present both the polarization on the left and on the right, but I think we need to have some nuancing in that, because I personally don't believe it's helping the cause when people are trying to do their best with the information that they have available. Presenting all those dramatic and polarized views, we're just reporting the news as it happens, is one thing, but they also have a responsibility in terms of the responsible reporting. That's my view.
Yeah, no, I agree. I think, though, it does, sorry, I'm going to throw in my little 2 cents in. I think, though, it does then come back to us as practitioners in this huge big room that we have right now. It's part of our responsibility to keep that balanced message. Sorry, that's just my 2 cents. Anyway, let's move on. There looks like there's a question for Mike there. Good question, Ian. So what do we do with those that have penicillin allergies?
Yeah, there's a few different options. So second-line therapy for infectious syphilis would include doxycycline, a 14-day course, or ceftriaxone is another option. For a pregnant woman, though, it's important to use penicillin or Bison. So we don't want to use a second-line option for pregnant women. In Manitoba, we're very lucky to have access to HSC Allergy Immunology, and Dr. Colin Barber can help with some of those assessments if you have, a mom that needs treatment and has a pen allergy. So that would be the one caveat. But for non-pregnant adults, ceftriaxone and doxycycline could be used.
Okay, let's go back to a PPE question. So also a little controversial, but how strict do we want to go? So should Canada and provinces take the stance that all new viruses / unknown illnesses be treated as aerosol driven, and we use this appropriate PPE until we find out. So going all the way across to the other side. Any comments on that from our ICP experts?
It's John Conley. I can address that. Chris may want to weigh in on it as well. I think the answer to this is it depends. If you had a gastrointestinal illness and we had a new strain of norovirus and we had epidemics of diarrhea, it wouldn't make sense to start looking at aerosol-driven. So I think it depends on the pathogen and what's occurring. And importantly, if you've got a respiratory pathogen, one needs to look at both the benefits and the risks and balance that. And again, to go back to your comment, Rich, we need to have a balanced look. There is an issue of immunity depth that's being looked at now in New Zealand, Australia, Hong Kong. Absolutely explosive outbreaks of RSV with deaths, I would add, in their ICUs. And we're now seeing that in Canada and Quebec and Ontario with a rise in RSV and quite severe infections and out of kilter. Is that being driven by too rigid and too strict a set of guidelines? So I think it's important, and particularly with children, we have to be very careful about untoward consequences. Are we going to prevent one thing only to have another that comes up in that setting? And are we impairing childhood immunologic development? There's been a lot of work now occurring. And then also with going full there are people who are raising concerns about the microplastic epidemic and the pollution in the environment, and also concerns now about microplastic lung, because many of the masks and things that are used, we're seeing when they get crumpled leaching of microplastics, and we're already aware of flock workers disease that's occurred as an interstitial lung disease. So just to give some examples, one needs to look very carefully before pressing the accelerator on any of these things in terms of that balanced view that I think you very nicely espoused.
Yeah, I'd agree with that, John. I mean, we really do have a great deal of information to build upon. So advent of new or emerging, I'm not sure is completely accurate. I mean, there certainly will be emerging pathogens, and certainly an approach to them is something that we should all be able to sit down together to be able to structure, well, what are our initial responses, with the acknowledgement that those initial responses will change over time. What is tried and true? What do we already know about a lot of these topics? And where are the information gaps? And being able to set up the infrastructure and systems across Canada and internationally and within our provinces, between our provinces, to be able to identify where are those information gaps and what are the risks and benefits of any one of our interventions, to be able to really have a balanced approach is something that we have to be able to do. And I feel that over the course of our past 2 years working together over COVID-19, we're probably set up now more than ever to be able to have those very fulsome, fruitful discussions, to be able to explore those risks that Dr. Conley explored, but also what are those social benefits that on the flip side. So being able to have that balanced approach is something that's absolutely critical.
Yeah, it's good to hear that there are some silver linings that are coming out of this pandemic from our first set of speakers and some of your comments now. Yeah, I agree. So we've got a little bit of time for questions still. So do you see IPC future where mask wearing and social distancing will be encouraged during the cold and flu season, especially if there's ongoing COVID?
No, I'll take a crack at that one. I think there's been a couple of major things that I think society and socially we've tried to learn together, and that's the no touching your eyes, your mouth, and your nose. Wash your hands frequently. For God's sake, if you're sick, stay home. And the daily symptom checks for either safe for work, safe for play, safe for learning. So those are things that that have been new, at least in our North American society, over the past couple years, and maybe internationally, other cultures have actually adopted those before us. I'm hopeful that those will actually continue to propagate and continue to have some stickiness within our overall societies, so that the days of old of medical students and residents coming to work with a bit of a sniffle is, no, that's not acceptable in any environment anymore. So that I think socially things will change. I guess time will tell to identify what will stick and what will have some longevity to it. But I'm hopeful that, at least from community-based prevention activities, that we're probably well set up, and probably set up for improvements into the future of reduced transmission within our community environments.
Mm-hmm. Yeah, no, I agree. So very, very quickly, because I'm actually personally interested in this, and I would actually throw this to John, because you may have national data. Are we seeing this syphilis surge? Is there a penicillin resistance component? Or Mike, do you guys know that? Because
yeah. I appreciate John's comments as well. We just haven't seen any penicillin resistance to syphilis. It's exquisitely sensitive, this bug. We're very fortunate to have that. We have seen certainly azithromycin resistance, so we can't use azithromycin for syphilis, but penicillin and bicillin in particular, obviously the treatment is very, very good, very little resistance. But John, did you want to add anything more on that?
No, just that I'm not aware of any penicillin resistance, and I just find it an interesting paradox that in a setting with COVID, where there's supposed to be less contact, individuals you don't know, and yet we're seeing an epidemic of syphilis. So obviously something happening in the background leading to these increased social contacts and social networks for sexual encounters. And I would bet you can comment that there's been rises in chlamydia and gonorrhea as well, because usually these STIs travel in packs. So interesting phenomenon going on in the background.
Yeah. Okay, well, I really appreciate everyone's contribution. These have been great discussions. Thanks very much for everything. But just in respect for our next speakers, I'd like to move right on. So our next speaker is going to be our head of department for infectious disease, Dr. Yoav Keenan. He's going to speak. Is going to speak on the silent syndemic and drug use and serious infection. So this has been touched on by some of our previous speakers. So I think this is a great kind of or progression of this discussion. Here we go. So just quickly, background. Dr. Keenan, he's mostly involved with HIV. He runs the HIV clinic with Dr. Ken Casper at HSC, but he's been very involved with medical complications of injection drug use as well, and so this is a great topic for him. So welcome, Yoav. Good to see you again. So I think you just have to go up to that top left and switch the slide presentation thing there. It's not completely on the left, on the side. Yeah, there we go. And you just switch it to, click that. Yeah, there we go. And bottom. There we go. Great. Okay.
Perfect. So you can see my slides, Richard?
That's excellent. And we can hear you fine. Away you go.
Perfect. Thanks for the invitation. Thanks, Dr. Amble, for running this successful event for the past 25 years. I'm happy to speak a bit about the silent endemics, and it's a good follow to Dr. Isaac's talk that outlined some of the endemics. In terms of conflicts of interest, I've received honoraria from Gilead, no disclosures that are relevant to this presentation. I live and work and on the regional lands of the Anishinaabe, Cree, Oji Cree, Dakota, and Dene people, and the homeland of the Métis Nation. And we respect the treaties that were made on these territories, acknowledge the harms and mistakes of the past, and dedicate ourselves to moving forward in partnership with Indigenous communities in the spirit of reconciliation and collaboration. What I wanted to do today is review a bit the trends in methamphetamine use. It's really going to be clear, and it's already clear from the previous talks that you've heard, and I'm sure that Dr. Devinder Singh that follows will have a lot to talk about that as well, because it is the same syndemic. Review a bit of the impact on the HIV cascade of care and how care of HIV has changed in the face of the crystal methamphetamine mass epidemic, and the impact of other STBBIs. And then talk a bit in brief about some of the changes that happened during COVID-19 and what is the impact of COVID-19 on the syndemics, and some of the recommendations and things that underlie what we're seeing. So in terms of the most common drug used in Canada until 2018, use of crystal methamphetamine among general population was low, and it is, however, increasing. It is surpassing heroin and other opioids overall, and we can see the trend in stabilization in cocaine use and taken over by stimulants such as methamphetamine. And that has resulted in increase in the number of methamphetamine-related deaths, and this is depicted here in this slide from the Canadian Centre for Substance Use and Addictions, showing an increase in Alberta of over 2.5 times, Ontario nearly 2.5 times of meth-related deaths. The demand for harm reduction and treatment, which are struggling to deal with the stimulant for which no antagonist clearly exists, and that those numbers have 2,000% increase in Manitoba, for example. The number of hospitalizations due to stimulants have increased dramatically in many provinces, Alberta by 800% and Manitoba 600%. And then low enforcement indicators that I'm sure will be related to Devinder's talk. Seizures have increased dramatically, possession charges, as well as incarceration related to offenses associated with use of stimulants. And in terms of what has happened in inpatient hospitalization with, so here you see the decrease in related admissions to cocaine and replacement with other stimulants, other CNS stimulants. And when we look at the complementary figure here, what you can see is that is largely driven by the increase in methamphetamine. And this slide goes just to 2017, but what we've seen here in Manitoba is a dramatic increase since 2017. And we shall see what would be the unveiling after COVID, but methamphetamine is definitely an issue that is increasing. And again, a summary of the numbers, and in the fiscal year of 2014 to 2015, 9% of adults reported using methamphetamine compared to an increase to 24%. The increase in use is more prevalent use among women, and it is become one of the most common causes of presenting, other than alcohol, in terms of presenting for support for addiction. Emergency room visits related to methamphetamine have increased dramatically in Winnipeg up to 1,600%. And this is a study from Regina, with senior author Stu Skinner, trained here in Manitoba, looking at hospital admissions and mortality due to complications of injection drug use in 2 hospitals in Regina. And the leading causes of admissions are opioids and methamphetamine, with methamphetamine accounting for 35%. And if you look on the table 3 from that paper, sexually transmitted infections are important, nearly half of those presentations, and followed by bacteremia. And a quarter of the patients present with infective endocarditis. This is something we're also seeing in Manitoba, and that has dramatic implication on healthcare utilization and costs and long-term consequences of the infections. Some of the challenges that we see in terms of HIV management during with this increase in crystal methamphetamine use are related to the fact that crystal methamphetamine has become the most common mode of HIV transmission, and we see an increase in the number of HIV co-infections with other STBBIs. In terms of the cascade of care, we've looked at the data, and we've made improvements in the linkage to care and ability to manage and to bring viral load to undetectable levels. But with the current trends in methamphetamine use and comorbidities associated with it, we have been seeing a decrease in number of individuals who are linked to care and who achieve adherence and undetectable viral load, in large part attributed to the emergence of this methamphetamine use syndemic. And adherence and missed appointments have increased dramatically in our program. What complicates further the management of individuals who are newly diagnosed with HIV in the setting of injection drug use driven by crystal methamphetamine are the occurrence of complicated bacterial infections that require prolonged, complicated antimicrobial therapy, for which also adherence is impacted by the addiction. And for example, we see complicated skin and soft tissue infections, endocarditis, osteomyelitis, and septic arthritis. Endocarditis and osteomyelitis require weeks of intravenous antibiotic therapy, and in individuals who frequently do not complete their hospital admission and leave against medical advice due to structural disadvantages, this is really tough to achieve. If we look at what has happened in terms of the comorbidities as part of the syndemic that Dr. Isaac described earlier, this is a credit to Dr. Rueda, who's been collecting the information from the Manitoba HIV program. The number of STBBIs, including syphilis, chlamydia, and gonorrhea by year in individuals who use compared to those who do not use methamphetamine are depicted here. And here are the new diagnoses with HIV in the years of 2018, 19, and 20. And those that do not use methamphetamine are marked as no on the x-axis. And as you can see, there's a higher number of comorbidity of co-infections in those who use crystal methamphetamine. And the trend is definite increase with 2020, over 3/4 of patients who have been diagnosed with HIV have at least one additional STBBI. In this case, the slide doesn't include HCV. And in this depiction, it includes HCV, so added the numbers of HCV into the equation. And of the newly diagnosed infections with HIV, we used to be at around 11 to 13% of individuals diagnosed with HIV that have hepatitis C as co-infection, and the rates now are higher than 30% among newly diagnosed. We don't know the full impact of COVID-19 on access to STBBI care, but Public Health Agency has conducted a survey on and questions over 1,000 participants, and 60% reported that mental health status was worse since the start of the pandemic, and 66% had difficulties accessing to mental health care. In addition, financial and food security have worsened, and 32% reported reduced hours of pay and or having had to stop working, and 36% reported major or moderate impact on ability to pay the bills. Food insecurity increased by 42% since the start of the COVID pandemic. In terms of use of drugs and alcohol, increase in alcohol use has been dramatic, and as well as increase in use of other substances. And I won't go into all of the list here, but 15% reported using speed, methamphetamine, crystal meth, and 52% increased use of those drugs. The top reasons why...
3 minutes.
Thank you. The top reasons why people were not able to access STBBI-related services are reduced hours of operation or services that were closed due to public health restrictions, difficulty getting an appointment, accessing services, and fear or concerns of experiencing stigma, discrimination, and violence. The main important thing to take home from this is that we have syndemic of multiple STBBIs, so testing needs to test for all of them. And while there have been an improvement in the testing for concurrent STBBIs, it's still far from perfect. And there are recommendations by many organizations on what the things that you can do to intervene to improve the situation, and prevention modalities, harm reduction interventions such as safe injection sites and opioid substitution are important, but those are limited for individuals who use crystal methamphetamine. Behavioral interventions are important. HIV testing services and HIV treatment and care outside of the conventional structured programs is deemed to be important. And prevention of other comorbidities, especially important in this setting and during the last 18 months, is mental health. What is also needed is a supportive legislation and policy, as well as funding that includes the criminalization of behaviors and addressing stigma. Health services need to be acceptable and accessible, and discrimination does exist in our healthcare settings, and work with community that contributes to empowerment and addressing the syndemics of intimate partner violence and other forms of violence are really critical. Canada has put an action plan to try to reflect some of those, and it's similar, but the main things that are really missing is our ability to collect data on knowledge, behaviors, and attitudes, and to break down the data based on subgroups, especially data on individuals who suffer structural disadvantages and who use crystal methamphetamine, to support initiatives to eliminate homophobia, racism, and sexism, and other forms of discrimination that are associated with STBBI, and to revise policies that increase risk of STBBI transmission and increase and limit the implementation and operation of STBBI-related programs and services that limit transmission. We want to support programs that facilitate access to basic needs, and this is a dire need of safe housing, which I echo what Dr. Isaac said before, and education and health promotion, and support initiatives that improve access to mental health services. In summary, crystal methamphetamine use is increasing. It's affecting young, increasing women. Syndemic conditions include bloodborne and sexually transmitted infections, as well as bacteremia and metastatic infection, making the management complex. Together with mental health coexisting issues, adherence to HIV therapy is become more difficult. In the context of newly diagnosed HIV, this has undermined the progress we've made toward 1990, and structural disadvantages underlie this endemics, and social determinants must be addressed if we are to make progress in trying to reach the unreached. I want to thank many Dr. Rueda, who is the PI on projects that were aiming to address some of the attitudes and understanding of individuals who are disadvantaged. The Manitoba HIV program, my colleagues Dr. McKenzie and Dr. Casper, as well as Nine Circles, Dr. Ireland, Mike Payne, and most importantly, community peers that support the projects that we're doing, the provincial lab that supports the diagnostic component, and Margaret Howard Brockman from the NCCID that's been a fantastic colleague and a collaborator on many of the projects. And special thanks to the HIV team at HSC, a fantastic and dedicated team that continues to work super hard despite facing dramatic challenges over the last year and a half. And a special thanks for Kathy that has helped to pull some of the data together. Thank you very much.
Well, thanks very much, Yoav. This has definitely gone to a very heavy subject. And so it looks like we're not going to move on to any easier subject. I want to introduce our next speaker, Dr. Devinder Singh. He's another medical officer of health here in Manitoba, but he also actually went on and completed his law degree here at the U of M, and he has looked very closely at the impact, the health impact when people are incarcerated. And so, yeah, I really look forward to this, although it is a very heavy topic. So over to you, Devinder. Good to see you again.
Great, thanks, Richard. Just a correction, I'm still completing the law degree, so I'm about 2/3 of the way through, so not quite done yet. So thank you, Richard. So the title of my presentation is Locked Up, Incarceration and Health. And I'd first just like to thank the other collaborators, investigators that I had working on this research with myself. That's Sarah Prowse and Marcia Anderson, who I'm sure that many of you know. For my disclosures, I just like to report that I received 2 unrestricted grants from Pfizer Canada that were used to provide immunizations that aren't funded by Manitoba Health to patients who could not otherwise afford them. However, that doesn't relate to the topic of this presentation. For my objectives today, I'd like to compare Indigenous and non-Indigenous rates of incarceration in Manitoba, describe the immediate and long-term health effects of incarceration, and identify next steps to address the over-incarceration of Indigenous people. So in terms of the rate of incarceration per 100,000 population for adults 18 years of age and older, looking at Manitoba and Canada, we can see that Indigenous people in Manitoba are 18 times more likely to be incarcerated than non-Indigenous adults at a rate of 1,378 per 100,000 population compared to 75 per 100,000 population. And in Canada, in the federal prison system, the Indigenous adults are 7 times more likely to be incarcerated at a rate of 330 per 100,000 compared to 45 per 100,000. Looking at the rate in a different way, looking at the proportion of incarcerated individuals who are Indigenous compared to non-Indigenous in Manitoba, looking at adult Indigenous incarceration and youth Indigenous incarceration compared to the proportion of people in Manitoba overall who are Indigenous, we can see that the general population in Manitoba identifies between 15% and 18% between the years of 2006 and 2016 as Indigenous. However, in terms of adult incarceration, the rates of individuals who identify as Indigenous have varied between 70% to 76%. And for youth Indigenous incarceration, that percentage is even higher, or the percentage of individuals who are incarcerated in the youth system who identify as Indigenous are between 85% and 82% non-Indigenous, and these rates are calculated using one-day counts. In terms of years of life lost to incarceration, we can see that Indigenous females lose 6 to 9 times more years of life than non-Indigenous females to incarceration. So looking at the federal prison system, that's 1,800 per 100,000 population compared to 200 years of life lost per 100,000 population. And looking at a provincial system in British Columbia, the difference is 3,200 per 100,000 population compared to 500 per 100,000 population. And for Indigenous males, while the relative rate is lower than for Indigenous females, the absolute numbers are much higher. So looking at the federal prison system, we have 30,300 years of life lost per 100,000 population compared to 4,900 for non-Indigenous individuals in the federal prison system. And in the British Columbia jail system, we have 27,000, my apologies, per 100,000 population compared to 7,200 years of life lost per 100,000 population in that provincial system. And since Indigenous individuals in Manitoba are 18 times more likely to be incarcerated than non-Indigenous individuals compared to in British Columbia, where they are 4.5 times more likely to be incarcerated, we can estimate that the difference in Manitoba would actually be much higher than this difference that we see in British Columbia. Adding those two groups together, because the federal prison system and the provincial jail system would be dealing with the same population. So prison here actually includes incarceration for both the federal and provincial system for British Columbia. We can see that the years of life lost per 100,000 population for Indigenous females compared to several common causes that we often look at for years of life lost. In terms of prison, women, Indigenous females lose 8.5 times more years of life to incarceration than to cancer, heart disease, than to heart disease and stroke, 5 times more years of life lost than to cancer, and 1.6 times more years of life lost than to injuries. And for Indigenous males, the difference is much larger, where Indigenous males lose 76 times more years of life lost to incarceration than to cancer, 53 times more years of life lost than to heart disease and stroke, and 9 times more years of life lost than to injuries. Another caveat for this is that for these health conditions, these are years of life lost before the ages of 75. However, for incarceration, the data sources actually for the federal system only included years of life up to age 65. And for the BC provincial system, they only included years of life up to the age of 55. So the higher end for years of life lost is actually much higher for these health conditions before age 75 than for incarceration. So we could expect that this number for incarceration could actually be higher if it was before the age of 75 for all of these states. In terms of the health outcomes for incarceration, there are compounded health harms of incarceration and overrepresentation, which include an increased risk of death, increased risk of acute and chronic disease, negative effects on family health, and consequences for social determinants of health. Going into the individual categories, in terms of increased risk of death, the risk is particularly high in the first 2 weeks after release, with a reported increase of 6 to 13 times the expected number of deaths after accounting for age and sex. For the first 2 weeks, the significant amount of this added risk is due to overdose, with an increased risk of 56 times the average risk of overdose death in those first 2 weeks, and for suicide with an estimated increase of 29 times the average increase over those who haven't been incarcerated between 2 and 4 weeks after release. as well, for every year that a person spends incarcerated, that decreases their life expectancy by approximately 2 years. In terms of the increased risk of acute and chronic diseases, those specifically include major depression, acute and chronic infections like HIV, hepatitis, and tuberculosis, stress-related chronic diseases like hypertension and heart disease, and the development of obesity. In terms of negative health effects on the family, parental incarceration increases the risk for negative effects on children throughout their life course, starting from birth. So for parental incarceration, that increases the risk of infant mortality in the first 4 months, after accounting for prenatal care, postnatal care, personal behaviors, and poverty-related indicators. Maternal incarceration also increases the risk of problem behaviors by age 9. Parental incarceration is associated with specific health consequences later in life, like risk for depression, obesity, diabetes, heart attack, and stroke, even after accounting for other risk factors. And these health consequences are likely caused by the effects incarceration has on the other social determinants of health, which I'll mention shortly. In terms of those consequences to the social determinants of health, incarceration significantly affects the type of employment that a person can receive after release from incarceration, the chances of getting a job interview and of getting hired, and the chance for promotion after being hired. And the social determinants of health influence the likelihood of an individual's involvement in the criminal justice system. So having incarceration affects those social determinants of health, and then those social determinants of health affect the future involvement of an individual into the criminal justice system. You can see that a vicious cycle could develop between these consequences that incarceration can have on an individual's life course.
Devinda, 3 minutes.
Great, thanks, Richard. So what do we do in terms of next steps for recognizing and addressing systemic racism, which is a significant contributor to this cause of over-incarceration of Indigenous people? First, I'll just start with a quote from the Aboriginal Justice Inquiry of Manitoba, which, while it was conducted back in 1991, the findings and the recommendations still have significant relevance to the situation today. So the report wrote that many opportunities for subjective decision-making exist within the justice system, and there are few checks on the subjective criteria being used to make those decisions. We believe that part of the problem is that while Aboriginal people are the objects of such discretion within the justice system, they do not benefit from discretionary decision-making, and that even well-intentioned exercise of discretion can lead to inappropriate results because of cultural or value differences. So this is trying to address the fact that while systemic racism exists in the system, that doesn't mean that all of the actors are overtly trying to have results that lead to these vastly different outcomes between Indigenous and non-Indigenous individuals. We should be treating over-incarceration of Indigenous people just as other public health issues, like those mentioned previously, that we spend so much time and energy trying to address. We can prioritize investment in the social determinants of health for Indigenous people, since that is a significant driver of the future contact into the criminal justice system. Implement recommendations in previous reports. There have been several reports, like the Aboriginal Justice Inquiry of Manitoba back in 1991, the Ikabuchi report from Ontario related to individuals and jury involvement in 2013, the Truth and Reconciliation Commission of Canada's final report in 2015, and many other reports. So there have been several recommendations in the past, and while we in public health aren't the experts in the justice system, several experts in the justice system have created recommendations to try to address these problems. And lastly, to monitor and report for evaluation of progress. If we're not continuously monitoring and reporting on these outcomes, then we won't know how much progress we are making in terms of changing the system and changing these outcomes. So just like to end with some key points. In Manitoba, Indigenous people are greatly overrepresented in the prison and jail population, with Indigenous adults being 18 times more likely to be incarcerated than non-Indigenous adults. The overrepresentation of Indigenous people in prison and jail has both immediate and compounded long-term health effects for individuals, families, communities, and all of society. Indigenous people lose far more years of life to time spent in prison and jail than to premature death from cancer, injuries, heart disease, and stroke. And addressing over-incarceration is required to close the gaps in health between Indigenous and non-Indigenous people. So hopefully you feel that I've covered my objectives for comparing Indigenous and non-Indigenous rates for incarceration, describing the immediate and long-term health consequences of incarceration, and identifying some next steps to address the over-incarceration of Indigenous people in Manitoba. And just for your information, I will go through the references for this presentation.
Thanks very much, Devinda. Like I said, pretty heavy subject. I'm sure there's going to be some tough questions later on. So, okay, well, let's move straight on to our next speaker. Dr. Zoma Ruda, I shouldn't really say this, Yoav, but I hope she's not the brains behind your talk, but she is a physician and a PhD in epidemiology from Columbia and has been working here for her research and focused on latent and active TB in people in prisons. But she is also an associate professor here at the U of M and a Canada research chair in STBBIs. She's going to be speaking on how science can inform health policies. So pretty big subjects, but I think that ties in very well with previous two subjects. So over to you, Zoma.
Thank you. Can you see my slides, Doctor?
Yes, yeah, we can see them. Great.
Okay, perfect. So I want to thank Dr. John Amble for his invitation. So I'm going to talk about before I start my presentation, I acknowledge that the University of Manitoba campuses are located on original lands of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. And we acknowledge all the treaties and the harm that we cause. As a disclosure, I have to say that I don't have any conflict of interest, but because this topic is very sensitive, I have to disclose that I've been working in science. I was trained in medicine and I did my PhD in epidemiology. I believe in science, which means that I acknowledge that the knowledge evolves. So it changes over time. Sometimes we believe that we know the truth, but then it changes. And I also acknowledge that I don't know everything. So this presentation is updated until yesterday, which means that maybe tomorrow, in months, or in a year, it might change. I also have to disclose that I never expected the evolution of this pandemic. So it means that my thoughts have been changing with the pandemic. And finally, the pictures and images that I'm going to show you are shown for educational purposes. The objectives for my talk is to, the attendee will be able to state key aspects of science informing policymaking, list barriers to implementing effective public health policy, and identify domains of evidence-based public health policy. So all of us as epidemiologists or infectious diseases, doctors or nurses or everyone that works in outbreak investigation knows these steps, which basically is to try to identify, it's based on research. So how to identify the causes of an outbreak, you perform the studies, develop hypotheses, and compare and adjust the prevention measures. But the 13th point is communicate findings. And through this pandemic, we have learned so many things. So here are the statements from the former president, Donald Trump in the United States. But I want to highlight three. The first one, at the beginning of the pandemic, he says we have it totally under control, 0 cases. The other one, it's going to disappear one day, like a miracle. It will disappear. And the other one, it was in March 2020. So he said, I feel it was a pandemic long before it was called a pandemic. And then all of us witnessed what happened in the US. So the question is how we take decisions, how policies, politicians and healthcare authorities take decisions. So we expect that is mostly based on evidence, but during this pandemic, we've learned that sometimes it's more emotional reasons. So the first thing is to understand what is misinformation. The definition is incorrect, false, or misleading information. The key point is that it's not created with intention of hurting others. However, most of us remember the statement of Mr. Trump when he mentioned that why we don't try oral or subdermal injection with bleach. Appeared this fake New England Journal of Medicine paper, which the conclusion is, please don't do it, it will kill you. So all of us, when he said it, maybe laugh, but then we realized that that in the US, there were different stores that were saying, we are going to allow only to buy 2 bleach per person, and the CDC calls to US poison because it increased the number of poisons by 20%. So something that we initially thought it was funny, then became harmful for people. This information, most of the conspiracy theories is deliberate misinformation, but the key point is that it is designed to deceive or mislead. What is the problem? The problem is that misinformation can be an innocent mistake, but it's still dangerous. Disinformation is dangerous, plus it serves someone else's agenda. We have been witnessing how different political groups worldwide has using disinformation, and unfortunately spread with among people that ended up with infodemic. So infodemic is basically that the information is spread like a virus. So if you see this figure, it reminds you about COVID-19 dissemination. So does misinformation and disinformation. It is exciting how faster it can be spread and how deadly it can be. So the important thing is we need to critically assess information before we share it. So here we are fighting, or we are trying to control epidemic plus infodemic. And there is a website, Canadian website, that I strongly recommend you, is Can COVID. And this is up to date. They review factors associated with susceptibility to misinformation. So the factors are younger age, self-identifying as a minority, lower trust in scientific institutions or researchers, being exposed to information about the virus through social media, lower performance on numeracy tasks, but one thing that surprised me, it was political conservatism. So when we are talking about the policy, one of the important things is there are several steps. So as with any decision-making process in public health practice, formulation of health policies is complex and depend on a variety of scientific, economic, social, and political forces. During this pandemic, we understand the importance of the integration of society and health, democracy, international affairs, and most important, public leadership and management. There is a considerable gap between what research shows is effective and the policies that are enacted and enforced. The definition of policy is often broad and includes what we call peak big P, big policies, which include laws, regulation, judicial decrees, and small P's, which are internal guidelines. And when we talk about leadership in this pandemic, we acknowledge that we are handling or facing not only coronavirus crisis, we are also facing economical crisis, racial crisis, leadership crisis, and there are several examples around the world beyond Mr. Trump. So one of the things when we are thinking about effective public health policy, and that surprised me, is that only 6% of public health laws demonstrate consideration of scientific information. As a researcher, I would expect that this would be close to 90% or higher. However, there is one thing that we need to consider, and its research is most likely to influence policy development through an extended process of communication and interaction. As researchers, we fail to communicate findings in a clear, plain language. Research, as the previous speaker, Dr. Isaac, mentioned, research is, we are in the middle of the pandemic. We don't know many things. There are a lot of uncertainties, but we fail to communicate to the general public and politicians about uncertainty. And the other thing is how we communicate the risk and how we engage the community. And this is extremely important because vaccine hesitancy, it didn't appear with COVID. It appears long time before. This is a paper from New England Journal of Medicine, recently a review of measles. And we see that we have a lot of cases of measles. Then we had the vaccine. Then we were in the phase of elimination, but since 2000, all the beginning of 2010, you can see how started to increase the vaccine hesitancy worldwide. And this is not only the US, this is high-income countries. And for example, look, Canada, more than 200,000 kids have not received this vaccine. And 2 days ago, the director of NIH, Dr. Collins, says we underestimated the vaccine hesitancy issue. So the point is, this vaccine hesitancy didn't start with COVID. We maybe didn't pay attention around 20 years ago, and this is what is happening. For that reason, it's important to trace and understand the community. The other thing is that policymaking and decision-making consider research evidence in less than 50%. If you remember, the number that I gave you is only 6%. But what matters for more policymaking and decision-making is policy maker values and competing sources of information. For example, anecdotes or personal experience. Remember when Mr. Trump recommended hydroxychloroquine because his personal doctor thought that it could be effective. So some of the barriers to achieve an effective public health policy might be absence of personal contact between scientists and policymakers, like is two complete different separate worlds. Mutual mistrust between researchers and politicians, political instability or high turnover of policymaking staff. For example, mismatched time horizon. This is related to elections. We saw what happened with U.S. election. But I wanted to mention not trained to distinguish between good and bad data. So that part is critical. So basically,
sorry, there's 3 minutes.
Yeah, thank you. So there are 5 points that I want to mention. The first one to achieve this effective policy is the transdisciplinary approach, which means the integration between epidemiology and public health and other healthcare sectors, but it goes beyond that. We need to involve, for example, ethics and law and governance. We need to involve marketing. Social and behavioral science became so critical to understand what is happening with the pandemic. User experience and design, media studies and journalism. So the first key point, we need to create this consortia. The second thing is to combine quantitative and qualitative data. I'm a quantitative researcher, but I acknowledge that what we call the best evidence in quantitative research is not always complete. We need also a complementation from qualitative research. So here, 292 US state policymakers mentioned that they preferred, instead of reading this complex or this amount of information, they prefer short, easy to digest data. Younger respondents preferred electronic information compared to older respondents. And they mentioned that most trusted info were those providing state-by-state comparison instead of global picture. Also, they mentioned that quantitative and qualitative should include surveys of policymakers that allows to people to understand their priorities, their attitudes and voting intentions and perceptions of lobbyists and lobbying. The third thing is understand people's motivations, fear, and concerns and knowledge. So in this case, the factors associated with higher uptake of COVID-19 vaccine were, for example, trust in the national health authorities, in scientists, in governments, awareness of misinformation, older age, concerned about the person, self-perception or other family member. But what I want to highlight is, for example, the conspiracy theories. So basically when people were asked, they were thinking that the government is hiding information about COVID-19 and its cures. So one of the main call for actions for all governments was the lack of transparency worldwide. So in this case, I just want to mention that we need to stop, if they said muting our ankles, but what it means is we need, instead of saying you are wrong, we need to be empathic with the people. Language should be not you, should be us, we. Focus on tactics and tell people why others create myths, because they want money, profits, political power, social plus identity reasons. And finally, because we need a multi-level sociocultural approach, not just technical ones. So I think we all are overwhelmed with research and the amount of research produced during COVID-19 pandemic, but how people digest that information. The fourth thing is be resistant to misinformation. So WHO recommend assess the source, go beyond headlines, identify the author, check the date, examine the supporting evidence. This is critical. Check our own bias, what we believe. And finally, turn to fact checkers. And the last thing is document the effects of implemented policies. So we issue policies, but we don't evaluate the impact of them. So this is the new discipline that is proposed, and it's called Infodemic Manager. So this is the Infodemic Manager unicorn, where we need to be adaptable, we need training and management, we need monitoring and evaluation, we need to understand public health and outbreak response, but with the unicorn of communication, social science, plus behavior. And always remember that should be coordinated, evidence-based approach, and understanding there is no single base type of evidence. So in conclusion, it is important to have a clear consortia with defined roles and responsibilities and common goals for various actors. Involve the relevant actors, including scientists, policymakers, but here it is demonstrated the importance of including civil society. Produce advice that is sound and biased and legitimate, and to do that, we need to monitor infodemiology, infovalence, and social listening. It is extremely important to build e-health literacy. People don't understand health in general, and knowledge refinement, filtering, and fact-checking. Thank you very much.
Oh, thank you. Thank you very much, Dr. Ritter. It's great to see that you could manage to get such a big topic packed down into 15 minutes. But I'm sure that's going to have of influence going forward. We've sure seen that with misinformation during this pandemic. So, okay, well, let's move on. We don't have a pile of time. I'm going to break into the lunch break a little bit, but we do have some fascinating questions. So obviously political here a little bit, but I would be interested to hear some answers. You can all kind of shout out at once. So what can Manitoba government do to bridge the gap to promote the healthcare and justice sectors to come together to address Indigenous health outcomes? Great question. I'm not sure that is a simple answer, that's for sure. Anyone? Devinda, this is kind of your study.
I could throw out a suggestion. Well, just whenever a new session of the government starts, and especially now we've got a leadership race with the provincial government, and we'll have a new leader of the PC party. And so with that new leadership comes a chance for a new setting of priorities, and having letters sent to ministers for health and justice to have on their priority list to start this collaboration, and to look at these sources which are already in existence for reports of how to try to improve outcomes and close these gaps. That I think that having those intentions written down and come from the top is the best way to start or continue a process of collaboration.
Sorry, busy chatting away there. So, yeah, obviously that would be great. Is that not a unicorn? So, but okay, next question. So how do we combat the dispersal of sham science in social media that impacts vaccine uptake? Yeah, that would be great if we could. Dr. Ritter, you've touched on some of them.
That is an excellent question. And the honest answer is I don't have the answer because, as I mentioned, the unicorn is just a call. This is an invitation to work together, to listening to several disciplines. What I personally, from my work in tuberculosis and tuberculosis in prisons, what I would say is the most important is to understand the public. And by public, I mean not only the general community, also politicians, also policymaking, also healthcare workers. So one of the things that I, reading and preparing all of this and my personal experience is go to several actors and ask them what they think, knowledge, attitudes, practice, what are their main fears, what are their main concerns, understand what they believe. And then you can try to individualize different strategies, because I think one of the mistakes is that it was created with COVID, it was created a unique message and it was the same format. And there are people, for example, that do not have internet access. So how they are going to be aware of the messages if we only distribute by internet? Right? So the point is you need to individualize, you need to reach the communities, what it works for some people, it doesn't work for other groups. So the point is try to understand the needs of this population. And for that reason, I emphasize on the importance of integrate and work with disciplines like communication, social science, and behavior. And the last thing is to acknowledge that we are not expert in everything. I think that is one of the main problems. Many scientists that knows a lot about their topic were talking about other fields, and that create confusion. So it's a collaborative work, I think, is the key point here.
Mm-hmm. Yeah. Okay, so this would actually probably be for everyone out there. So do you have sorry, I'm just going to the second question. Do you have stats on any positive health effects of diversion programs in Winnipeg, elsewhere, compared to incarceration?
I can just mention first that I don't, unfortunately, have statistics on positive health effects for diversion programs compared to incarceration. However, we know that for incarceration, for example, just looking at one behavior and health outcomes for those who inject drugs, that well, the percentage of people who inject drugs before going into jail or prison decreases after they go into jail or prison. For those that do continue to use injection drugs, that the occurrence of sharing needles increases dramatically. So, by not having people in those environments and having environments that do support harm reduction measures in a more rigorous way, that then we would be able to reduce outcomes that come from those types of incidences, like sharing of injection drug use equipment and the potential acquisition of HIV, hepatitis, and so on.
Okay, good. Just wondering, you're in the trenches a lot. Do you have some insight on that top question there? How can the average clinician best advocate for First Nations health and help lessen the impact of social injustice and inequities? I mean, it's a broad question, but I mean, you also face that every day.
Yeah, so it's a question that I don't have a good answer. And again, it needs a multi-pronged approach with realizing that a lot of the health consequences are a result of social injustice and disparities that need to be addressed. The healthcare system can do better in eliminating and decreasing racism within ourselves, having more training and education in real meaningful truth and reconciliation. But in addition to that, there needs to be an investment in addressing some of those disparities, including equalizing or ensuring equity in education and in housing. And those are really important. They're tough to, as a clinician, to make a difference, but it is important for us to advocate for that, because it is clear that whether it is incarceration or STBBI syndemic, where those are results of underlying structural disadvantages and are not achievable just within the health system. But the health system has a role to play in advocating for those resources.
Yeah, I fully agree there. So I appreciate that we're actually into lunch period already. I would like to, if I can indulge you guys, just this one last question, because I've seen this question has come up repeatedly, and I do actually really like it because it focuses on some potentially, are there some positive models? I'm going to throw in the word / programs that are here in Manitoba or in Winnipeg, and that for individuals where their behaviors are so dysregulated after multiple interventions, this could be other than jail, but I mean, it could also be, are there programs and things that we can be thinking of using that would even address some of the IV drug use and things like that?
I don't know the data. Sorry, this is not the field. This is not my talk, but I can mention. I've been working in tuberculosis in prisons for the last 11 years. And one of the things reading literature is that when you understand the epidemiology of this population, I've been reading in Canada, but I will talk about Colombia. Most of them are young people, and most of them are from low economic strata or low income, and they have things that are beyond health, like low access to education. Most of them are victims of violence, like within their families and within the surrounding, like neighborhood and so on. So definitely one of the things is that these kind of interventions go beyond a specific point and should go to the roots and should go to when during the childhood and how we can prevent these structural disadvantages.
So it's interesting the overlap between how you would address that in Colombia and here. There's so many similarities. I think you have actually summed it up in that we still, as clinicians, we really have to still advocate for our patients as much as we can. So, okay, well, thank you very much. I kind of dragged a little bit of extra time out of you, but I much appreciated. Very heavy topics, but very important topics. So now, just to let everybody know, we now have a lunch break until 12:45. So we'll start back at 12:45. And if you have tuned in late, you have to make sure you have registered online with the CPD department, the University of Manitoba, and there will be slides that will kind of circulate while we go for lunch, so you can get information off those slides. And then part of it is you have to go to slido.com and you have to register your attendance for today, and that way you can end up getting your credits, your CPD credits. So make sure you've registered with CPD, go to Slido, and then really important, please go back and do your evaluation on all the speakers. And that way we really build a strong bug day for next year. So, okay, have a great lunch. See you shortly in 25 minutes. Good afternoon, everybody, and welcome back. Hopefully everyone managed to get a quick bite and a stretch. I know if this was in Theatre A at campus, people will still be streaming in now, so hopefully we can get going. Just a few quick things. So before we start, I'm going to ask Amanda to put her camera on. I want to publicly thank Amanda for all the hard work that she has done. It is people look at this and it runs seamlessly. We have no idea how much work is going on behind the scenes, and Amanda is the puppet mistress, just like this, handling everything. So that's fantastic. Excellent job, and we really do appreciate all the work you've put into this. This is definitely your baby, so anyone that want, now we've got a face to who's behind the scenes here. So okay, and so let's move on to our first speaker for the afternoon. So we have got, oh, there he is, Dr. Robin Lindsay himself, the tick man. So well-renowned, and so he worked for Public Health Agency of Canada at National Microbiology Lab over in Arlington. Phenomenal work for years, all on ticks, mosquitoes, tick-borne diseases, mosquito-borne diseases. He's an entomologist of repute, and if you go to PubMed, Dr. Robin Lindsay, how many are you at now? 30, Robin?
Seven or eight now, Richard. Thanks.
Yeah. You don't even count anymore. So he's going to talk to us about the bite that keeps giving. So arthropod-borne illnesses. So over to you, Robin.
All right. Thank you very much for the introduction. I'm pleased to participate in my third bug day, and I guess this will be my final one since I'm retiring, but I hope to give you an overview of arthropod-borne illnesses in Canada, and hope that sets the table for Rob and Carl to provide more details on Lyme disease and trench fever. Now, the problems with arthropods from a public health standpoint begin with this sort of behavior. And why would they subject you to this blood feeding activity? Really, they do it because the blood is used for egg production and for their development. And this is really a evolutionary process that's been 150 million years in progress. Unfortunately, it's a behavior that's really specialized, and it has been adapted by relatively few arthropods. You can see within the group Insecta, they're really only the biting flies, the fleas, some of the true bugs, the lice, and believe it or not, a few Lepidoptera that are involved in transmission or biting behavior. So there's only about 14,000 species of arthropods that engage in this blood feeding, and there's probably only 300 or 400 that are important in terms of the overall, that do it on a regular basis, but still very important. The main strategies of blood feeding are either vessel feeding, like we see with mosquitoes, where the mouth parts are elongated and they probe within the skin to find either capillary beds or vanuoles to take a blood meal from. Or we have a slightly different approach, a more aggressive approach, where the mouth parts is designed as such to hack a hole in the flesh, and the blood that wells up is then absorbed by a sponging mechanism on the mouth parts of the insect in this case. And the duration of feeding is typically short. There are some exceptions with ticks, but most of these arthropods only interact with the host for a short period of time. In terms of pathogen transmission, there is some potential for mechanical transmission of pathogens from contaminated mouth parts when the feeding is interrupted. But most of them are, these pathogens are transmitted biologically. So there has to be a development within the vector. And then when the vector goes to feed a second time, a potential for transmission to occur. So it's a complex system. And as you can imagine, this is a real challenge. And why it took so long for this to evolve is because it's got all these mechanisms they have to be involved. They have to be able to find a host and locate it. They have to avoid the host grooming or defense mechanisms. You have to overcome the host's immune response. And saliva and its pharmacological properties are really the key to this activity. You have the arthropods injecting an anesthetic to prevent the host from feeling it, anticoagulants, anti-inflammatories, all kinds of saliva goes into the host to allow them to participate in this behavior. And of course, digestion of the blood meal is a complex activity. This is not a simple diet. And arthropods have associated microbiomes, often bacteria, to assist with this. And really, if there's a villain in this whole vector-borne disease component, it is the pathogens themselves and not the arthropods. They are simply trying to lay eggs or develop, and the pathogens have co-opted that system and are using it to transfer from host to host. Now, of course, blood meal or blood feeding has a number of impacts on public health. The consequence of nuisance and psychological impacts cannot be underestimated. The bites themselves can be secondarily infected. People can develop anemia. If weird conditions like autoacariasis, where ticks can get in your inner ear and feed into the tympanum and cause balance problems. There's a really cool infection condition where the injection of toxin from tick saliva results in an ascending acid paralysis. Get all kinds of allergic reactions associated with the bites of arthropods. But of course, the most important dimension of this blood feeding is the transmission of pathogens. And from a Canadian perspective, there are some unique challenges for vector-borne diseases in our very large country. And again, it's limited diversity of vector species. Most of the vectors are at the northern limit of the distribution. We have relatively few ticks, for example. There are almost 900 species in the world. We only have about 40. There are about 80 species of mosquitoes in Canada of the close to 3,000 that exist. So we've got a limited diversity of vectors. Of course, we have a relatively short growing season for the arthropods themselves, as well as for that transmission to occur. And almost all of them have to have some mechanism to overwinter the pathogens, that is, because there is going to be a cessation of activity at some point during the season because of winter. And all of this is happening in the context of extensive changes in the climate occurring in Canada, whether it's increases in temperature, reductions in rainfall. So it's a complex system. And I've listed here the key vector-borne diseases that are mosquito-borne or tick-borne. And you can see we've had a history of exotic pathogens like malaria in the 1700s. Western equine encephalitis was very common in certainly the prairies in the 30s and 40s, causing large numbers of equine cases. And geez, when I was a grad student, we were still talking about Western equine encephalitis as the prominent mosquito-borne disease. We had an incursion of St. Louis encephalitis into Quebec and Ontario in the mid-70s that resulted in cases. But all of these have been displaced to a certain extent to the new kid on the block, West Nile virus, which was introduced in 2001. The same sort of historical perspective can be seen for Rocky Mountain spotty fevers, where we saw cases of that starting in the 20s. Relapsing fever, a couple of cases a year starting in the 30s, Powassan from the 50s, Colorado tick fever and anaplasma emerging thereafter. But really, it's Lyme disease that is the main tick-borne disease now in Canada. So let's look at each of these in a little more detail and what's driving their incursion and activity in Canada. West Nile virus was an opportunistic colonizer of North America. And again, it came into a very permissive environment where we had the appropriate vectors, appropriate reservoirs, and a permissive climate for transmission. So here in Canada, we certainly have Culex orsalis, Culex pipiens, and Culex restaurans, species that are enzootic amplifiers of the virus. So we certainly have a raft of avian species to facilitate this amplification. Under the right environmental conditions, we can have spillover into dead-end hosts and causing outbreaks of this particular infection. Again, what drives these infection and outbreaks are a combination of biological and climatic events. You have to have a large population of vector mosquitoes. So typically that's dependent on having enough standing water environments or large amounts of larval developmental sites, which would be rainfall dependent. Also having hosts available at the right time when adult mosquitoes have emerged and are potentially transmitting infection. You need to result in an outbreak, you need large numbers of these birds, specifically nestling birds are preferred because they are really good amplifiers. And then again, you need hot temperatures. So these impact the speed of the mosquito development, potential number of generations, as well as the extreme incubation period, the time from when they're first infected to when they're infectious. So the hotter it is, the shorter that time frame becomes. And again, you see on this examination of hotspots in Canada, really there are certain areas in the country that meet that have the vectors and have the heat units to amplify virus to the point of spillover, and other areas that do not. So Manitoba and prairie provinces here really have large Culex orsalis populations and opportunities and realized transmission to humans here. And same conditions exist in Ontario and Quebec. Outside of those areas, we do see occasional human cases in places like BC, but really the amplification is not sufficient to result in spillover on a regular basis, especially in places like Atlantic Canada. And that overall pattern where you need a set of biological circumstances to occur in a very short period of time results in this sort of boom or bust type of epidemiology, where in certain years like 2003 and 2007, we had big outbreaks of lots of human cases. And then in the intervening years, very little in the way of activity. So this is the kind of epidemiological pattern we typically see with mosquito-borne diseases, where it's either a lot of activity or very little. And that really describes the fragility of the transmission cycles that we see. This is very much contrasted with what we see with Lyme disease. And again, the origin of Lyme disease in Canada, in central and eastern Canada, Pacificus was present in BC, and we had activity probably in the 70s and 80s. But really, it's been a transition where there's been an incursion in eastern Canada and central Canada of the tick itself, and then an establishment of transmission cycles. So unlike West Nile, where it's just the bug that had to get into the system, and there were already good vectors there, this is a 2-for-1 sale here on Lyme disease, where the pathogen, the vector has incurred into the location and it's brought with it a number of pathogens, including, and most prominently, Borrelia burgdorferi, the agent of Lyme disease. You still have this zoonotic disease cycle where transmission is results in eventual spillover, but the drivers behind it are different. In Eastern Canada and Central Canada, we've had a tremendous change in the range of this particular species. It was present only in one location at Long Point Peninsula as early as the 1970s. And over time, starting in about the early 90s, we had a range expansion of this tick starting along the north shore of Lake Erie, but then expanding into other parts of Ontario and eastern Ontario, into southern Quebec, into the Atlantic provinces, up and even into northwestern Ontario and into Manitoba. So this range expansion and expansion of this tick into this whole slew of new locations is driving the epidemiology of this infection. The disease became nationally notifiable in 2009, but you see this sort of general pattern of an increase in activity over time and fairly stable numbers. And this stability is different than with West Nile because these ticks are long-lived. They don't have this boom and bust population dynamic like you see with West Nile virus. So this being able to, and this pattern of increasing epidemiology once population established has been seen here, obviously been seen in the US and been seen in Europe as well.
Robin?
Yes?
3 minutes.
Thank you. Now, the drivers of these tick-borne infections are similar to what we see with the mosquito-borne infections. Temperature and precipitation and seasonal weather seem to have had an impact on the abundance and activity and geographic distribution of the ticks, and this has been well illustrated with the changing range of this species. The same sort of variables, changes in abundance, activity, and geographic range are occurring with their reservoir hosts as well. And again, this is also impacting the human activity patterns and some of our behavioral patterns. But the accumulation of that is the increased likelihood of exposure to ticks and a higher likelihood of transmission. And you can see that the foundation of that change has been climatic variables. With respect to areas that we need to remain vigilant on, I think we need to continue to do surveillance and to do predictive modeling to understand the risk of emergence of novel, emerging, or re-emerging infections, or even invasive vector species. We have the Asian longhorn tick and Lone Star tick sort of banging at the door, so to speak, in the northern tier states of the US. We have Aedes aegypti and Aedes albopictus making an appearance and becoming established in at least albopictus in southern Ontario. So we need to remain vigilant. We've been trying to do surveillance in novel and in economical ways and modernize our surveillance. For example, we're using this eTick program, which is the submission of digital images instead of specimens, to provide information about where ticks are occurring and where they're being cited and where risk may be emerging. But I really think our colleagues at the Public Health Risk Sciences Division who've been modeling and trying to predict where populations of ticks may be established and where risk maybe occurs is really very informative here. We have Earth observation-based risk maps that have been produced that look at habitat suitability and climatic conditions to predict where risk is. And I think these sorts of modeling exercises will be very helpful to public health in the future. I think improved diagnostic testing for Lyme disease is and has been a challenge since this disease first became recognized, and understanding the role of bacterial strain on test performance is something we really don't have a good handle on. But there's a study through the Canadian Lyme Disease Research Network where they have a cohort of people who they're going to enroll. They're going to try to isolate bacteria to understand which strains or determine which strains they're affected with. Then they're going to follow those people over time so we can understand the impact of strain on disease presentation, its response to treatment, and of course, most importantly, how do our tests perform to measure or to determine who's infected and who's not. And we're also establishing a biobank as a result of that, so we can have gold standard samples to be able to determine which species which new tests might be improvements. And the last thing, Richard, I'm here going to just say that we really do need some improvements in disease prevention. We've had some new interventions like Accredited come to the Canadian market and permethrin-treated clothing, but we need to improve our compliance to public health messages. People, what we tell them to do works, but they don't necessarily follow it. There's my alarm to tell you to stop. And we definitely need an effective vaccine to prevent Lyme disease. And there's one in clinical trials phase 2 here in Canada. So maybe we'll get there. So over to Rob.
Thanks, Robin. That's excellent. Yeah, I'm sure there's going to be questions around that vaccine. That's good to hear. There's some. But okay, I'll move straight on to our next speaker. I'm very proud to introduce Dr. Robert Strang. So he is the Chief Medical Officer of Health in Nova Scotia. So he is, I'm sure he's worked very closely with Dr. Ruthin, who was on a little earlier on. And he's been very involved with Lyme, because Lyme disease seems to be much more prominent over in Nova Scotia. So I think your insight as to how you've managed this over the last decade now would be fantastic for us. I really appreciate that. And because as I'm sure you'll mention, it's a very highly politicized disease. So your presentation is Lyme disease, sorting out the details. So over to you, Rob.
Thanks, Richard, and good afternoon, everybody. And I got 15 minutes, so let's get going. So the point of this slide is really that Lyme disease, since its first appearance in Nova Scotia in 2002, has really become an endemic disease in Nova Scotia. And as I'll explain, that's important in terms of how we communicate to the public and the healthcare providers around risks of Lyme disease and actions to take. But we have established populations of Lyme disease in all parts of mainland Nova Scotia. We believe it's in the Geisberg County. We just haven't been able to do good testing there. Certainly established in the Cape Breton area. The only part that we have lots of conversations with Robin Lindsay is maybe in the Cape Breton Highlands doesn't have the ecological requirements to sustain tick populations. But we assume we describe Nova Scotia as an endemic, certainly mainland Nova Scotia as endemic for ticks at this point in time. We have had a tick-borne disease response plan since 2002. The key elements of that, there's a clear outlining of what are the roles for public health versus our clinical colleagues. Outlines our approach around the epidemiology and surveillance, and that has transitioned over time. As now we're endemic. That was very different than a decade ago, where we talked about endemic parts of the province where we had established populations versus the rest of the province. But that black and white endemic or areas or not endemic really didn't capture the nuances of changes of likelihood of risk of exposure. And so now we talk about, as you see in the previous slide, we have 3 levels of risk for the province. And there's no area that doesn't have some level of risk. That's important in our communications. Public health focuses on both the surveillance and communicating that and the prevention, and then we work with our clinical colleagues on the diagnosis and management and a significant amount of communication on an annual basis that I'll talk more about. Our prevention, no surprise to everybody, there's a focus on making sure both Nova Scotians and people visiting Nova Scotia are made aware of the possibility that if they are undergoing certain activities in the outdoors, that there's potential for exposure to ticks. We provide a lot of advice for people living in Nova Scotia and how they may reduce their risk of ticks in the environment around their homes or businesses. And then the usual information about preventive measures that individuals can take when they're undergoing certain activities and actions like tick checks after those activities to reduce their risk of, first of all, being exposed to a tick, and second of all, if they are, identifying a tick very early on and removing that, and as well as being aware of signs of potential early Lyme disease. We have an infectious disease expert group in Nova Scotia. Their role is it's the adult pediatric infectious disease clinicians. Their role is to advise my office and the Department of Health and Wellness on a range of infectious disease issues. We spend a lot of time talking about Lyme disease, and for a number of years now, they produce this statement, which is updated every year, and it's our guide for informing clinicians around the diagnosis, evidence-based approach to the diagnosis and management of Lyme disease. It's an excellent example, I believe, of a partnership between public health and the infectious disease community. Simply a reminder to folks around the various stages of Lyme disease. And the key point in here, as highlighted in the next slide, is that in the acute phases, that our current testing is not highly accurate. Whereas if you get into situations where you're more disseminated Lyme disease, we know that the test is highly accurate. Two key points there that we continue to communicate to physicians, because Nova Scotia is endemic, that if somebody presents with appropriate exposure history and compatible symptoms for acute Lyme disease, that they should go ahead and treat them for Lyme disease. And the key point about, we used to then have to have a component about, well, where's the geographic exposure within the province, and that's where they kind of black and white. Were you in the Lunenburg, or were you 10 kilometers outside of Lunenburg, or were you somewhere else? Didn't really capture the nuance of risk. So now it's, I think, because we're endemic, makes it much easier that if appropriate exposure and compatible clinical symptoms equals acute Lyme disease and requires treatment in Nova Scotia. The other point about the accuracy of tests when people are in long-term symptoms is that we are continuing to communicate that if somebody tests negative for Lyme disease with chronic symptoms, that there's a very high likelihood that they do not have Lyme disease, and that's an important point to get across for clinicians because of the chronic Lyme lobby. The next point on the slide, so that's one of the key areas of controversy that we're criticized. We're not looking enough for Lyme disease, and there's this huge burden of Lyme disease that we're missing. We don't capture all of the acute Lyme in our surveillance, but we certainly make every effort to make sure that frontline clinicians are aware of to look for and treat early Lyme as appropriate. The second controversy is really about our approach to testing, that we don't accept lab results from other than ones that are done from an appropriate laboratory process. And that's simply because of the evidence, and this is one example, that those evidence-based approaches to diagnosing Lyme disease are highly inaccurate. And so that's the second area that we continue to do a lot of work educating both the public and clinicians around what is appropriate for diagnosing Lyme disease and the risks of inaccurate results if they travel outside of Nova Scotia, especially to the US, or have specimens sent to a private lab. We also, the other piece is around the long-term treatment of antibiotics for people with chronic Lyme symptoms. The point of this slide is really that even though most people with Lyme disease will improve over time, about 10 to 15% can develop post-treatment Lyme disease syndrome, but there is no evidence of persistent infection, and there's no role for long-term antibiotics as identified in this slide. Again, I'm sure you're all aware of the controversy around that. We spend a lot of time focusing on an evidence-based approach, trying to engage with our public and with communities, and even the chronic Lyme advocates around discussions around this slide highlights more of the financial, but there's also significant health issues associated with the non-evidence-based approaches which are put forward by chronic Lyme advocates. And we try to engage them and have a meaningful dialogue. We've had some modestly successful attempts. About 3 years ago, we've been sidelined for the last 2 years around COVID, but we continue to try to have meaningful dialogue around an appropriate approach to diagnosis and treatment of Lyme disease. Sorry, went one slide too many there. This is a complex area, the communications around this. So there's a very strong advocacy around chronic Lyme disease. Certainly we know that lots of people have chronic unexplained symptoms, but those symptoms are very non-specific, are not unique at all with possible Borrelia infection, and we know the evidence around, as I just summarized, around post-treatment Lyme disease, but not having a relationship with chronic, no evidence of chronic infection. But there's a lot, don't have time to go into it, but lots of individual and I would say collective psychological reasons around people's adherence to an external explanation for chronic unexplained, previously unexplained symptoms. And once why they have a diagnosis, it's extremely hard to convince them that there's maybe an alternative explanation for that diagnosis. The communications around this can be very tricky, again, because of it's the challenges of having an evidence-based approach and trying to keep up with evolving evidence and trying to counter misinformation. And when there's the other people bring forward a view and there's a lot of emotion and anecdote, which can tug at the heartstrings very much on that. So a key part of our strategy for me to end up is we pay a lot of time and attention around our communications to healthcare providers to do the best we can to make sure, especially frontline emergency room primary care providers have good information, evidence-based around diagnosis and treatment. A lot of time talking to the public in different formats. And I spend a fair bit of my time on the Lyme disease file is making sure that elected officials, especially in the provincial government, are briefed every time we have a new minister. The Minister of Health is briefed extensively. I bring in my lab and clinical colleagues because they get bombarded with all sorts of communication from their chronic Lyme advocacy. And so far, I think we've been able to do a reasonable job of being able to adhere to an evidence-based approach by paying particular attention to a communication and education of elected officials. And lastly, there's a number of bodies that you can search out. The Public Health Agency of Canada is not on there. Sorry, Robin, if you were looking for more evidence-based information on Lyme disease.
Oh, wow. Thanks very much, Rob. I didn't think you had managed to get that all down that quick, because that's, I must agree, that's a huge subject. And just out of quick interest, how much of your time is on the Lyme file with such indemnity?
In a normal life. I would say, it ebbs and flows, but when there's a surge of communication around, every spring, as I said, I periodically devote a large period of time to briefing elected officials. We write letters to the 3 provincial caucuses on an annual basis, and then reach out. We've done presentations to caucuses. Again, I think it's been effective of making sure elected officials have good information. The risk is that if you don't, then you're going to get told to do non-evidence-based things, which I try to avoid at all costs.
Yeah, very, very progressive. So great. Okay, well, thanks very much. Just hang around for some questions. I know there's some already. Okay, so let's go on to our next presenter. So Dr. Carl Boodman is a senior fellow here at U of M, and he is doing both combined infectious diseases and med micro. And one of his many passions, it's definitely not his only one, is infectious diseases that are linked to poverty and also those neglected infectious diseases. And so you found some fascinating things here in Manitoba and in Winnipeg, and we're really fortunate to have you here. So I'm going to talk about infections and homelessness and the re-emerging diseases. Okay, over to you, Paul.
Thanks so much, Dr. Rusk, and thanks, Dr. Embel, for the invitation. So I'm going to get started and talk about infections and homelessness. And a little caveat, this is a brief overview with, one little dive into one specific pathogen.
Mm-hmm. And I think you have to do slideshow.
Okay. Are people
there we
seeing
go.
it?
Perfect.
Now we're seeing a land acknowledgement. Is that correct?
Yeah. Thanks.
Great. Thanks, Dr. Rusk. So I want to begin with a land acknowledgement. I acknowledge that we're on Treaty 1 territory, the traditional territory of the Anishinaabe, Cree, Ojibwe, Dakota, and Dene peoples, and the homeland of the Métis Nation. And this land acknowledgement is particularly important for this presentation, as Indigenous people are disproportionately affected by homelessness and the lack of suitable housing, both urban and rural, in Canada. And I just wanted to showcase a very important article by Dr. Jessie Thistle and Dr. Janet Smiley. And Dr. Thistle experienced homelessness in Winnipeg previously. And this article describes how to advance good relations with Indigenous people experiencing homelessness. And they maintain that the roots of Indigenous homelessness involve colonial disruptions of various types with relationships or disruptions of relationships, to community, land, water, place, animals, culture, and language. So I encourage you to check out this reference if you're interested in this topic. Conflicts of interest. I received a research grant from the Hector Ma granting agency and the University of Manitoba to study trench fever in Manitoba in collaboration with some intercity organizations and the National Microbiology Lab and Dr. Robin Lindsay's lab. So outline, we'll briefly talk about terminology, some epidemiology, brief review of infections associated with homelessness, and examine Bartonella quintana, the agent that causes trench fever, as an indicator pathogen and an example of a neglected disease. So terminology, and it sort of seems that the semantics are kind of shifting, or the terminology is shifting underneath our feet. And this is something I'm not an expert in, and I mess up quite a bit. But you'll see in a lot of academic literature and a lot of community-based approaches, people prefer the term people who are experiencing homelessness rather than a homeless person. And I'll just spend a couple of seconds explaining a little bit why. No one's perfect, and sometimes we all make mistakes. But the rationale behind this is that homelessness is something that people are going through, it's something they're experiencing. And when we label someone as a homeless person, it may imply that there's no hope for change. Whereas experiencing homelessness hopefully implies that the experience won't last forever. And then when we describe an entire group as homeless people, sometimes it implies a static, homogeneous population that really betrays or doesn't really reflect the remarkable diversity of people who lose housing for various reasons, including people who've had PhDs and high status jobs to those who've really experienced poverty for most of their lives. So a brief touch on epidemiology of Canadian homelessness. And this is something that there's a lot of contentiousness regarding the methodology of estimates of homelessness, and I will not dive into that. In a 2016 report, it estimated that at least 230,000 Canadians experience homelessness in a given year. On a given night, at minimum, 35,000 individuals. There's a significant amount of hidden homelessness, so people who are couch surfing or temporarily staying with others. And certain studies have suggested that the pandemic has shifted from hidden homelessness to more visible homelessness because there's less couch surfing in this context. And in the 2016 census, over 22,000 people in Canada declared homeless shelter as their primary residence. And of course, this is an underestimate because it doesn't reflect any of the hidden homelessness or people who are sleeping or living rough or living on the street. So there's an interesting recent study from Ontario looking at unique patients experiencing homelessness who presented to emergency rooms. And you can see that the numbers doubled from 2010 to 2017 here. So the rates of homelessness seem to be going up. So a brief word on mortality. So people who experience homelessness in Canada may have a life expectancy that is extremely low. So as low as 42 and 52 years, respectively, for men and women. And this is based on old data and even data prior to the epidemic of the poisoned drug supply that we're currently experiencing. And this mortality rate is substantially higher than the lowest income bracket in Canada. So it's not just due to poverty, this is due to homelessness in and of itself as an additional factor. And it's, there's often complex risk factors at play. And I don't want to deceive you and maintain that it's mostly due to infection. I mean, infections do kill people, but most of this mortality is due to drug overdose and complications of psychiatric illness and some traumatic brain injury. And this was even prior to the poison drug supply that we're experiencing. So forces that predispose to infection, so crowded shelters expose individuals to communicable diseases, whether that's tuberculosis, COVID-19, MRSA. Prolonged exposure of feet to moisture and cold can lead to foot infections, cellulitis, osteomyelitis. There's sometimes barriers to obtaining medication and adhering to medical recommendations. So poorly controlled diabetes or chronic diseases and hypertension, peripheral vascular disease can lead to diabetic foot ulcers and osteomyelitis. Ectoparasitosis, which I will talk about in a second. So body lice, scabies, bed bugs can cause breaks in the skin, which can act as a portal of entry for bacteria and then cause infection. And then often chronic health concerns and even some acute health concerns are neglected, and that really reflects competing needs for the basics of survival for food and shelter. So if you don't have food and don't have shelter, maybe having your perfectly controlled blood pressure or type 2 diabetes might not be your primary concern. And then obviously the overlap with substance use disorder and infectious complications of IV drugs, which we're seeing quite a bit of on the infectious disease consultation service, whether that's endocarditis or discitis, osteomyelitis. So ectoparasitosis or arthropod infestations, so scabies, bed bugs, body lice, there's very little actual clinical data in Canada. One study in France suggested that 22% of people experiencing homelessness had body lice infestations. A study in California suggested this was 30%, and that the agent that causes trench fever was detected in 16% of the body lice pools. Regarding bed bugs, there's a little bit more Canadian data, and a study in Toronto that's actually quite old now suggests that at least 30% of the shelters had either current or recent bed bug infestations. So this is actually a picture taken by Robin Lindsay in collaboration with Access Downtown and Dr. Kathy Kissel. And so you can see body lice here in some clothing. So the body lice you can see to the right, and to the left you can see some long johns with all these kind of patches of blood. And that's because body lice live in clothing and they feed on the human host 2 or 3 times per day. They can cause these microabrasions, but then are very itchy. People scratch, they create breaks in the skin and some bleeding. For Bartonella quintana, it's actually transmitted through the feces of these body lice that then can survive on clothing for weeks or months and then enter the bloodstream, usually through these microabrasions and scratching. So respiratory disease, this is going to be very brief. TB, bacterial pneumonia, strep pneumo, viral pneumonia, COVID-19. I'll just highlight one study that happened at the beginning of the pandemic in a Boston shelter where there was a couple of cases of COVID-19 that were diagnosed, and then subsequent testing revealed almost 1/3 of the shelter was infected with SARS-CoV-2. Luckily in that study, most people were asymptomatic, but we've subsequently known that that's not always the case. So regarding sexually transmitted and bloodborne infections, we've already heard from Dr. Keenan and others about this today. There's complex overlapping risk factors. Sex work or survival sex is sometimes done to maintain shelter or avoid intimate partner violence. There's often an overlap between homelessness and substance use disorder. And homelessness is a barrier to clinical improvement for infections. So in one study in Vancouver of people living with HIV who used drugs, for every 6 months that someone was homeless, the odds of having viral suppression decreased by 30%. So we know that homelessness actually is a barrier to treating infections or maintaining control of infections. I'm now going to shift gears and just talk about Bartonella quintana and trench fever. This is something that we published last year, and there's some ongoing publications that are under review. Some key points. So Bartonella quintana causes trench fever, is transmitted by body lice in the way that I described before, with this kind of chronic presentation or chronic viability in body lice feces that then can enter the bloodstream through these microabrasions. It was first coined in World War I, and it can cause culture-negative endocarditis. I guess I'm at 3 minutes, Dr. Rusk? Or? Yep, great. And it can cause very mild symptomatology during chronic bacteremia. And B. quintana evades identification in routine blood cultures, and so you need to talk with your ID or MedMicro colleagues to diagnose it. So this is the first example and the first description in 1915 of Bartonella quintana in the Lancet in the trenches of World War I, mostly diagnosed as a relapsing illness. And in all of North America until 2019, there was only 12 cases of Bartonella quintana endocarditis, only 2 in Canada. And then last year, in only a couple of months, we diagnosed 4 cases. And I just want to highlight that 2 of those cases actually presented with intracranial hemorrhages and from ruptured mycotic aneurysms. All 4 individuals had experienced homelessness in certain shelters. Luckily, all 4 of them survived with antimicrobial therapy, often with gentamicin and doxycycline, but some had residual neurologic deficits. So subsequently, and this data should soon be published, we did a review of Bartonella serologies over the last 10 years and found 11 cases of Bartonella quintana, and then 8 of those were actually associated with endocarditis. And 4 patients had intracranial complications with embolization or ruptured mycotic aneurysms, often as their primary presentation, often mitral and aortic involvement, large vegetations, almost 2 centimeters. And often these stories have mild or no clinical signs until they present with embolization. So there could be someone with endocarditis who presents after their endocarditis embolizes or there's significant valvular damage. So this is really the proverbial tip of the iceberg. This is a retrospective study. We have no idea how much Bartonella quintana is in certain communities that have a lack of access to housing. And this is just the overlap with the lack of access to suitable housing and the Bartonella quintana cases. And you can see that they overlap perfectly in certain areas that do not have access to housing. This is my last slide. And I just wanted to talk about why talking about trench fever or Bartonella quintana is important. So it's rare in quotation marks because we don't really know how much of it is out there. And why is it important? Well, first of all, without wanting to be sensationalistic, it really conveys the degree of disadvantage that certain communities are facing. So this is a disease of World War I, found in East African refugee camps. This is a disease that's associated with some of the most vulnerable populations historically and currently, and it's a disease that we find 2 blocks away from where I'm speaking. 2, it's a neglected disease. We really don't know enough about it. It exclusively affects those who are affected by poverty. The epi data is limited. The diagnostics are somewhat limited as well. It's culture negative. There's some improvements that can be made there, and also some improvements based on for treatments, because it's based on quite limited evidence, and I think there's less toxic treatments available. And I just wanted to end on the concept of an indicator species. And so an indicator species is a concept in ecology or conservation biology that reflects the health of an ecosystem. So, whether that's algal blooms in Lake Winnipeg that reflect the poor quality of water in Lake Winnipeg at times with significant runoff and nitrogen and phosphorus, I really think that Bartonella quintana can be viewed as an indicator species or an indicator pathogen of the lack of suitable housing in a community. And so if there's even one case of Bartonella quintana endocarditis, it reflects a lack of adequate housing and running water in the community at large. Here are some references, and feel free to get in touch if you'd like any more information from those. And I just want to acknowledge some partners in crime here, the patients, obviously, inner city organizations, Salome Mission, Access Downtown, Housing Outreach, the Hector Ma Grant, and the doctors mentioned here. And I welcome any questions. Back to you, Dr. Rusk.
Wow, Carl, that's fantastic presentation. And yeah, you really, you're putting it out there, having indicator species. Yeah, might as well. It doesn't just have to be ecological things. So, okay, so, well, welcome back to the other two as well. We definitely have some questions here. So, interesting, a good start, and I think all three of you could jump in to all of these questions from what I can see. So is there a difference between the Lyme testing here in Manitoba and in other areas? Because the example given was a patient with symptoms who tested negative here, but then went to the Mayo and was tested positive. So, I mean, obviously that doesn't give the full question, but I mean, it does beg the question, and there's always controversy about, oh, our testing in Canada is no good. I've heard that from patients all too many times. Anyone want to jump in?
I could take a shot there.
For sure. Yeah.
I guess there's a certain element of time associated with this. I mean, in the US in the last year, they've switched from standard two-tier testing to modified two-tier testing, whereas instead of doing an EIA followed by a Western blot, they're doing an EIA, and if that's positive or equivocal, then they do a second EIA. But that's coming in the last year. So there's if you were talking about it in the last year, then there is a difference in the way that the testing is approached in Manitoba versus, I guess it's the Mayo Clinic in Rochester or perhaps in Minnesota. But so there has been that subtle change, but if it's an old or a historical question, then there really isn't any difference. We've been following the same two-tiered testing that would have been done historically at the Mayo Clinic. Now, maybe they used a different kit or they used a different product to do that, but it has been standardized. So that's a bit of a head scratcher why typically the results should be in agreement between those two institutions.
And also what Dr. Strang brought up, in that you may end up having a higher sensitivity specificity later on in disease as well. So, yeah, okay. I didn't know that there had just been some new changes. Good to know that. So what's the best diagnostic test for Lyme disease? Anyone? Robin, Carl, I'm sure you can also jump in. I see Dr. Strang has dropped off. He must have been called away to something. So, anyone want to actually hazard the best?
Oh, go ahead. Okay, well, I mean, ideally, I mean, for Lyme disease, what we want is no diagnostic test. We want to identify cases in the acute phase, right? So that they're looking at a clinical presentation, you get treatment into those individuals as soon as possible. So our ideal diagnostic test is a clinical diagnosis. So someone who's been acutely infected, the outcomes for them in terms of disease are best. But if that person doesn't identify it and goes on to develop more disseminated forms of disease, the tests that give the greatest sensitivity and specificity are still the serological assays. They're the only standardized testing platform that we currently have. And so in the simplest sense, that two-tiered serology is currently the best we have for Lyme disease diagnosis. So, Carl, you want to add anything?
Not much. I think, there is ongoing debate about, as you mentioned, the standard two-tiered and the modified with the two EIAs with somewhat different targets versus confirming with a Western blot. I know that currently we're still confirming with a Western blot here, and I know in other jurisdictions they're starting to do something different. And from what I understand, the differences in sensitivity and specificity are relatively minor. But there is some kind of ease or technological ease in avoiding the Western blot. I don't know if you had wanted to kind of comment on that, or I think they're both fair game currently. So
I'm happy with that answer, Carl.
Okay.
Okay, so in the ideal world, I would prefer that Dr. Strang actually handles this question, because he is definitely the person who's been one of the Canadian forefronts manage this. I mean, obviously, I could also touch on this. There's probably much the same with COVID. There's a advocacy group that has gained a lot of political sway, and so with Lyme disease, there definitely has been a very strong advocacy group that has essentially been claiming that we are as clinicians, we are missing this, and that also, as we've just talked about, the testing is not necessarily right. And in many cases, we don't, it's very difficult to manage patients that clearly have something wrong when we can't come up with a clear diagnosis. And so, unfortunately, there is lots of information out there on Dr. Google, and people that are, there was a mention in one of Dr. Strang's slides about some of the drivers that can drive people down this road. But I don't know if either of you want to jump in with a statement or some additional ideas, maybe some lab ideas. No.
Well, I mean, I certainly feel for people who feel they have Lyme disease but don't meet either the clinical criteria, or they don't. The laboratory tests that we perform do not confirm a clinical suspicion of Lyme disease. So I think these people are looking for answers, and will go to great lengths to confirm what they believe is the situation. So this has created a market for private laboratories who, quite frankly, as Dr. Strang showed, have issues in some of their assays with specificity. They can probably, using their algorithms, can probably have similar sensitivity to the tests that we run, but the specificity is often quite poor. So they end up picking up, they can get as many true positives as we get, but they get many additional false positives. So that is also part of the problem, and it feeds into the controversy. Why can't I get a positive test in Canada, but I can go to laboratories in the US or Europe and get a positive result? And then in their perspective, which result is wrong? If you have two conflicting results, well, they tend to lean towards the situation that suits their mindset best, and that ends up fueling the controversy. The tests in Canada are terrible. I'd have to go to the country to get diagnosed, and unfortunately, that is a bit of a cycle that they end up getting involved in that doesn't often resolve for them in a positive way. They don't often end up getting better.
Mm-hmm. Okay, I mean, there is no real answer to that, unfortunately. It's so hard. But the interesting question here in vaccines, I'm not sure, Robin, do you know anything about the vaccine that's being developed on the human side? I mean, I can touch on the veterinary side for the dogs.
I mean, there was a vaccine, as most people on the call would know. There was a Lymerix vaccine in the late 90s. It was even licensed for use in Canada, but for a number of reasons, it was, removed from the market. The company claimed that the sales were were insufficient and removed it from the market. And since that time, there's been a number of efforts to reinstitute a vaccine for people. Valneva is one of the groups that now has a multivalent vaccine that they're in clinical phase 2 trials, even recruiting some locations in Canada for those that phase 2 trials. I think in Kingston, one of the areas that they're trotting this vaccine out to see if it actually works in those preliminary phases. Again, I think it's well overdue. Like, I was never a big proponent of Lyme disease vaccines because these ticks, the black-legged ticks, are not a one-trick pony. They transmit more than one pathogen. So, I mean, Borrelia burgdorferi is the most important one, but it's not going to protect you from anaplasmosis or babesiosis or powassan. So you're still going to have to do the tick checks and all those other things to prevent those other tick-borne infections. But we've had such a steep curve here and not been able to really tamp that epidemiological curve down using the standard preventative message that we give. So I think we really do. The only way we're going to get that kind of flattening of the curve, to steal a term from COVID, is to bring in a vaccine. So it's not going to be a panacea, but I think the only way we're really going to get a handle on these numbers and get them going in a downward direction is to have a vaccine.
Yeah, no, I agree. And you've actually touched on one of the other questions in that your ixoides carries a number of other potential diseases. The one question, do you know what those rates are for those other tick-borne diseases, anaplasmosis, babesiosis? And I mean, I know Carl for sure has some clinical info on the signs and symptoms.
Well, I could address the rates. I mean, we know that Anaplasma phagocytophilum and Babesia microti are present in these black-legged tick populations, but they're an order of magnitude less prevalent than Borrelia burgdorferi. So they're out there. They seem to be emerging in certain areas, and right now we're looking at anaplasma cases are up. In Quebec, there was a cluster of cases this year. There are cases occurring in Eastern Ontario. We do see cases in Manitoba and elsewhere. So there does appear to be an emergence of those, at least anaplasma. Babesia seems to be a very rare bug. Again, being here in Manitoba, it really seems to be the only location where we can see Babesia at least occasionally in people, and a reasonable prevalence of infection in black-legged tick populations on the ground. Nowhere else in Canada do we really see that. And I'm at a loss to understand quite why that is, but Manitoba seems to be a hotspot. We are trying federally with our partners to make both of those diseases, including Powassan virus infection or Powassan disease, nationally notifiable, to get a better handle on what is the burden of disease from those other tick-borne pathogens that are out there that are emerging. So COVID has thrown a wrench into getting those onto the nationally notifiable list. But once we do that, I think we'll be in a much better position to be able to track these and count them as the burden of disease associated with these darn black-legged ticks.
Yeah, that's right. Okay, well, I'm going to actually steal some of our next time quickly. So this actually, I would put this to Carl, because this is more of a clinical question. So any thoughts of potentially delaying treatment for Lyme disease for an inaccurate, due to the inaccurate diagnostic test during the initial phases? And that's, I know there's definitely some people that, yeah, that's maybe what we should do. What are the risks of doing that, though?
Yeah, so as Dr. Lindsay mentioned, and yourself as well, often the importance is treating early when there's a clinical, an epidemiologic history that is consistent and a clinical picture that is consistent. So that bullseye rash, the erythema migrans, even if someone has a picture of it on their phone, and especially if they've been out in Manitoba, that is enough to treat. And I wouldn't delay, because as Dr. Strang mentioned, there's these phases of Lyme disease, sometimes just early cutaneous, early localized, but then it can disseminate. So it's important if you see the bullseye rash and there's some clinical symptoms associated with it, you can actually nip it in the bud and prevent more chronic sequelae and more dangerous manifestations, such as something called neuroborreliosis. We've seen a couple of cases of Banworth's here in Manitoba, or even 1 or 2 cases of pericarditis or carditis, neurocarditis. So it's important to really, if the clinical picture is there, just treat it. You can test for it and the testing will come back, but just treat it. Yeah.
No, I agree. That's very, very, very good message. So, well, thanks very much to the two of you. Much appreciated. Very hot topic, but and sorry we didn't touch more on on the trench fever. But,
oh, no problem.
Yeah, you still put a really good point out there. We need to think about some of those emerging diseases as indicators. So we can. I'm excited to move on to this next subject. It's TB. We've touched on TB earlier on today, and looking at some of the data that's coming out of the US just earlier this week, I'm kind of worried how what's happening here in Manitoba. So who else but Dr. Marcia Ainsley to actually talk about this? I mean, definitely our TB guru for Manitoba. So and so she's a specialist in internal medicine and respirology. But you're going to give us the TB in Manitoba and look back over time, and looking forward to it.
Thank you. You can hear me okay?
Yes, all good. And
okay.
We can see your slides fine, thanks.
Thank you. So I've been given the task to try to give you an update of all the new advances that have occurred in the last 25 years with respect to our understanding, diagnosis, and treatment of TB. And I would certainly consider her to be the queen of pandemics. Makes COVID look like a young little whippersnapper. I have, my disclosures would not impact in any way the content of this talk. So just a brief summary of what I'm going to talk about. I want to just highlight the role that we now understand at a much better level of colonization in the residential schools on the incidence and prevalence of tuberculosis in our First Nations communities, especially in Manitoba. I am going to talk about latent TB, and I'm going to talk about targeting testing for those who are above average risk for progression to active disease. I'm going to talk about IGRA versus the TST and some newer treatment regimes. And then with respect to active TB, I'm going to talk about the role of nucleic acid amplification tests for early diagnosis, as well as early diagnosis of drug resistance. I'm just going to briefly touch on some newer emerging shorter regimes, and I have one slide on some new drugs that we are using now for drug-resistant tuberculosis. One of the important calls to action of the Truth and Reconciliation was that we call on the governments to acknowledge that the current state of Aboriginal health in Canada is a direct result of the previous Canadian government policies, including residential schools. And in nowhere, with no other disease is it more obvious than with tuberculosis. So this is from the actual document that they published, and this is a graph that's showing mortality in residential schools for the year. And it's crazy that you actually have a chart with school mortality. But you can see that in early 1900s, we're sitting at 2 to 3% mortality per year in the schools. And what are they dying from? By far and away, the students are all dying from tuberculosis. So not only tuberculosis, but tuberculosis might be hidden under the diagnosis of pneumonia, other unknown illnesses, and meningitis. So TB was by far the most lethal of the infections that they had. And why was TB epidemic? It was epidemic in the residential schools secondary to very poor ventilation, poor access to medical care, overcrowding, malnutrition, and in many cases, actually starvation was occurring. The death rates in the schools in the early 1900s from TB was 20 times higher than the national death rate for children between 4 and 15, 5 and 14. And when survivors of the schools returned home, it's important to remember they brought with them both latent and active TB that they acquired in the residential school. And this created a reservoir of latent infections that later spread or reactivated in the community. And we're still seeing this effect right now. So I want to talk about latent tuberculosis, and then I will talk about active TB. So just as an example, this would be something I would be asked to see, but I'm referred a healthcare worker who has a positive TST done before a placement. She feels well. She has no systemic or respiratory symptoms. She was born in Eritrea and came to Canada. No overt TB contacts that she's aware of. She had a BCG at birth as well as before primary school, and her chest X-ray is normal. I want to just briefly touch on this slide because this tells us where we need to focus our treatments with respect to latent TB. So when a person is exposed to TB and acquires a primary tuberculosis. Now, some people actually are able to kill the TB and never become infected, but for those that become infected, most of them will heal within 6 months. But there's a couple of people groups of people that are very high risk of progressing to reactivation, or what we would consider active TB. The first and the highest group will be those with AIDS or HIV. And if you have AIDS, your risk of progression is going to be 10% per year. The second group is going to be those who have had a recent skin test conversion or have been in close contact with an infectious case and now are TST positive. And they're going to have a risk of developing latent tuberculosis, progressing from latent TB to active TB at about, it's quoted at 5% for the first 2 years. If they don't within those 2 years, then their lifelong risk after 2 years is 5%. This is the group that we're referred the most often. And in this group, we're going to look for factors that make them at increased risk above that average 5% when we decide whether we should treat them or not. So there's 2 tests we use to diagnose latent tuberculosis, and it's important to remember that these are immune tests. So we're measuring their immune response to an antigen of some sort. And we use both the TST, which uses the purified protein derivative, or an IGRA, which I'm going to talk about, where we look at how much gamma interferon is released. Both required an intact immune system. And I'll just remind everyone that they have no role to play in investigation for active TB. Why is that? Because a quarter of the world's population has latent TB. And in up to 20% of people with active TB, their skin tests are negative. So it turns out TST and IGRA are neither specific nor sensitive for active TB. So what is interferon gamma release assay? So when TB infects the cells, eventually dendritic cells will present antigens, TB antigens, to the T cells. The T cells will become primed and then release gamma interferon. The gamma interferon acts at the macrophages and allows the macrophages to actually kill the TB. So what an IGRA is, we take blood, the patient's white T cells will be exposed to an antigen. This antigen is not found in BCG, and we will measure the amount of interferon gamma that is released to the antigen. So one of the questions we have is which is better? Is it a TST or an IGRA we should use? I will say the TST is still preferred in Manitoba because of the cost of an IGRA. It is cheap and it's well established and accepted. And we have very good data on it dating back decades, if not centuries. The IGRA is the preferred blood test if they've had a prior BCG after age 2 or if they had a booster at any point. So I believe in the 1970s, nursing schools and actually doctors in Manitoba, medical schools in Manitoba received actually BCG when they came into nursing. So we have seen that cluster of people, and for sure a TST is unhelpful in them. It should be considered in patients who are unlikely to return for the second reading. And it is routinely used now in the HIV clinic. We do have access to it in the TB clinic and the right clinical indication. And patients can pay for an IGRA, and often patients do that if they're going on a biologic, but that would comes out of their pocket. I will remind everyone both the IGRA and the TST can react to some of the non-tuberculous species. And so IGRA does in fact have false positive related to infection with things like Mycobacterium kansasi. The second or important thing to remember in treatment of latent tuberculosis is that we really should be targeting treatment to people that are above average risk of reactivation. And so really, we probably shouldn't be skin testing people that are 60 or 70 unless there's some very strong indication that they will need treatment. And one of the tools that we find the most helpful here is the TST in 3D website. In it, you enter in all the variables related to the patient, and it comes out with results that tell us, one, the pre-test or the positive predictive value of the test. It then goes on to tell you what the predicted cumulative risk of active TB should the patient live up to age 80. And then it also tells us as a third dimension what the risk is that they'll have a reaction. And in this case, it's from INH. So it tells us, again, what the risk of treatment is. And now, how are we treating? That has changed over the last 25 years. So in 2018, Dick Menzies' groups published in the New England showing that 4 months of rifampin was non-inferior to 9 months of INH, and rifampin certainly has less hepatotoxicity. Rifampin is therefore our treatment of choice for latent tuberculosis, except when there's drug-drug interactions, and rifampin has fabulous drug-drug interactions. It interacts with the birth control pill, it interacts with many of the DOACs, it interacts with immunosuppression. So in those cases, we would consider INH. The second treatment regime that is now we use is a 12 doses once a week, daily. It has to be directly observed treatment with rifapentine and INH. So this treatment has to be directly observed. It is only 12 doses, though, and we are using it in Manitoba in northern communities where patients can get directly observed therapy. And also we have been using it with our healthcare workers because they can pop in to the TB clinic or the rest clinic, get their dose before or after their shift once a week. So what's new with active TB? I'm going to talk briefly about new diagnostic tools, drugs, and treatment regimes. Well, TB really is the queen of pandemics. TB is the leading killer, leading infectious disease killer globally. In any given year, we have roughly 10 million new cases and resulting in 1.4 million deaths annually. On average, 3,836 people die from TB daily, or that's one death every 22 seconds. An accurate diagnosis is important because we need, one, to start treatment early to prevent more infections and also to guide drug therapy because of drug resistance. So this would be a typical example of a 35-year-old who presents with 2-week history of cough, productive of yellow phlegm with fevers, smoker, some weight loss, but no dyspnea. And actually TB, one of the unique features of TB, unless it's quite advanced, actually patients often do not have dyspnea and often don't have hypoxemia because TB seems to have very good VQ matching. There's Louis Pasteur in HSC labs working away and diagnosing TB. And the treatment has, for the diagnosis, the standard in the past was microscopy using fluorochrome stains. And this picks up the most infectious patients. It will be smear positive when roughly there's 5,000 to 10,000 bacteria per ml. But culture obviously is the gold standard. It picks up 10 bacteria per ml. The sensitivity of the staining is variable. It depends on the specimen, actually the burden of illness, the stain used, and the experience of the technologist. And a technologist should be reading at least 15 smears per week. In Canada, where non-tuberculous mycobacterium is an emerging disease, and certainly the numbers are increasing, AFB smears will not distinguish between non-tuberculous mycobacterium and MTB infection. Obviously, the gold standard is culture, but remember that takes 2 to 6 weeks. And then during that time, the patient could be or may be infectious. We do culture because it allows for drug sensitivity testing.
Martha, there's 2 minutes.
Okay. The next treatment, and this is what I'll sort of end on, is the nucleic amplification diagnosis, and this is key. These are commercial machines that allow basically sputum to be processed and analyzed within 4 hours, and it will actually tell us whether they have nucleic acid related to tuberculosis. If you have smear positive, then the commercial assays are greater than 95% sensitive. If you're culture negative, it's actually 70%. So the WHO now recommends NAT instead of smears as the first diagnosis of tuberculosis. As my last slide, I'm going to say rapid testing for drug resistance is critical. I'll say drug resistance now causes an estimated, there's probably 500,000 cases of rifampin-resistant TB occurring annually. We think that drug-resistant TB will cost the world $16.3 trillion by 2050. And it is what threatens our ability to stop TB. And I will say now these commercial assays, as well as whole gene sequencing at the National Lab, will allow us to actually rapidly identify drug-resistant TB and start treatment front. Finally, there are some new drugs available for drug-resistant TB, and there are new trials emerging. This one was one recently published. It's an open-label, single group, so it's not randomized. But in fact, they had very good outcome looking at two new drugs and a repurposed older drug. So in summary, tests for latent TB, we should test only in patients at high risk from baseline for reactivation. The IGRA is preferred test for latent TB in people who are unlikely to return for a reading or who have had a BCG after age 2 or a booster. Rifampin or rifapentin INH are preferred treatments. Nucleic amplification tests now allow for rapid identification of MTB in smear-positive cases and allow for rapid identification of rifampin and soon-to-be INH resistance. And we do have newer drugs and some shorter regimes that are emerging for the treatment of TB.
Oh, thanks. Thanks very much. Yeah, very, very important subject here in Manitoba. So let's move straight on to Dr. Greg Hammond. So he's a infectious disease specialist, but a professor here at the University of Manitoba. He's been the former director of public health branch of communicable disease branch at Manitoba Health. He's been a co-chair for the national immunization strategy. He's still actively practicing, and yet he's this. Can I hazard to say decades of knowledge there, Greg? And one of your babies has been poliomyelitis, and so it's quite apt that you would be able to speak on this subject. So over to you. I don't actually see where.
I'm here now, I hope.
Yeah, there we go. Hi, Greg. Good to see you. So, okay, do you want to? I saw you sharing your screen earlier. Should we try that again?
Thank you very much, Richard. I very much appreciate being invited to be here today. I'd like to thank John and the organizers for this event, especially on the 25th anniversary. Thank you very much, John, and congratulations. So the topic today is the Polio Eradication Initiative, which is an ongoing challenge, but it has demonstrated improved health equity through this immunization program. We've learned a lot from the polio eradication program. So regarding potential conflicts of interest, I've been on vaccine advisory committees for Sanofi Pasteur for influenza vaccine, and I've given seminars to medical physicians on shingles vaccines, but neither of them are particularly relevant to today's topic. I am a member of the Rotary Club of Winnipeg West since 1991. And just to point out that polio eradication is a major signature event of Rotary International. So the objectives today are to understand why and how polio is targeted for eradication, to understand the benefits of the challenge of polio eradication, and to understand why ongoing assessment and support of this immunization program is important. So what is the context for this topic today? First of all, what is eradication? It's a very unique biological situation where we can actually eliminate an infectious agent by reducing it to zero on a worldwide basis from deliberate efforts where we no longer require any interventions for disease control. And the only example we have in human situation is smallpox. So the details biologically are that it must be confined to human populations with no animal reservoir. There must be long-lived immunity. We must have good diagnostic tests or tests. We must have effective vaccine or vaccines to interrupt virus transmission and to produce long-standing immunity. And it must not have the biological property of latency in the human body. So unlike chickenpox, which comes back as shingles, polio does not have that feature. So why target it for eradication? Well, we need to understand what polio is as a disease. Usually it's a very mild disease. It's a mild infection infecting the pharynx and the gut. Sometimes doesn't produce any symptoms at all. But when it multiplies at the local level, it can produce pharyngitis or sometimes gut upset and vomiting. But more often it just passes into the body, into the lymphatics. Sometimes it can pass into the bloodstream. And when it gets into the bloodstream, it then can spread to other parts of the body. So most notably when it affects the lining of the brain or spinal cord, it can cause a meningitis, which can result in a painful neck or spine, can headache, confusion, coma. It can cause encephalitis when it gets into brain tissue. So this can cause further confusion and coma. Can even lead to death when it affects the brain stem, which controls respiration. And if it doesn't, it can still lead to individuals being on iron lungs. It can cause death because of the brain involvement or the difficulty breathing. But most commonly, it causes paralysis because this virus affects specified cells called the anterior horn cells in the spinal cord. And when it knocks those cells out, there's no longer innervation along that nerve route to the muscles. Now, this infection can also occur in outbreaks. The outbreaks can cause fear and societal disruption, not too dissimilar from what we've experienced with COVID. It causes paralysis in childhood, which can affect lifelong independent living and requires care throughout the rest of a person's life. There is no treatment for either acute or chronic disease, and it can disproportionately affect disadvantaged populations, especially because this is a fecally orally transmitted virus, and therefore it can spread where there's poor hygiene, poor sewage control, and poor water. And lastly, it does meet the criteria for eradication of an infectious agent, so it's a good target. So what has been the impact of polio in Canada? So we have to look back away. The 35 years between 1927 and 62 show these black bars, which are outbreaks of polio across Canada. Vertical scale is the incidence rates per 100,000 population. And we can see there are a series of peaks at different times. The one I wanted to focus on is the 1953 peak. This was the largest one in Canada. And in 1953, Canada experienced 9,000 cases and 494 deaths, which was the most serious national epidemic since the 1918 influenza epidemic. Manitoba alone that year had 2,317 cases, 85 deaths. And at that year, it was the highest incidence in North America of polio. There were 92 individuals on iron lungs at one time, mainly in the King George Hospital at Riverview. Over the 25-year period from 28 to 53, we had 6 polio epidemics. So this was a recurring nightmare for families and young children. So the breakthrough were the development of polio vaccines. It started from some basic science work that was done and good technology work done in Canada at Connaught Laboratory, but it resulted in bulk preparation of material that was then purified into a product for a killed polio vaccine called the Salk vaccine after Jonas Salk. It included all 3 types of polio. And this was rolled out very rapidly in a huge clinical trial, a randomized trial that showed for sure the benefit of this vaccine. And the uptake on that was very quick, and it helped to end outbreaks. Another vaccine was developed in the 1960s, licensed in Canada in 1962, the Sabin vaccine after Albert Sabin, also trivalent. But this was a live vaccine. It was made less strong, was attenuated, and it was able to be given orally. The advantage of this vaccine was that it produced gut immunity, so that could interrupt transmission from person to person because that was the route of transmission. But the occasional reversion to neurovirulence was noted, and so this became a disadvantage of this vaccine later on, with vaccine-associated paralysis rate of about 1 in 2.7 million. So that resulted in changes back to IPV vaccine. And between these two vaccines, in developed countries, polio became very much under control. 1979, Rotary International piloted a program in the Philippines, which was successful. In 1985, Rotary set a vision for polio eradication. And this was joined in 1988 by other partners, the Global Polio Eradication Initiative, or the GPEI. It was begun with the oral polio vaccine. So there were remarkable improvements. In 1994, Americas were certified polio-free. 2014, India was certified polio-free. In 2020, Africa, just last year, was certified wild polio-free. And we have a new vaccine I'll talk about later. So the GPEI partners, the Global Polio Eradication Initiative partners, in addition to Rotary, were the Center for Disease Control, Gavi, Bill and Melinda Gates Foundation, UNICEF, the World Health Organization, all combined to work to end polio now. So the activities as part of the GPEI start with the purchase of the vaccine, which is actually the smallest component of the overall GPEI budget. It's around 3%. The largest component is for operational support for primarily the community-based vaccinators who administer the vaccine, largely on a door-to-door basis. Surveillance was another component, 11%. This is for laboratory-based surveillance of cases and for sewage specimens that look at environmental sampling and other kinds of strain analysis. Research, 16 million, 2%. Technical assistance for field officers and the cold chain managers and the social mobilizers was another 19%. So a great deal of effort needs to be coordinated across all these different activities as part of the GPEI. And what were the results? So the then and now, 1988, when it started, there were 125 countries that had endemic polio. By 2020, last year, there were only 2, Afghanistan and Pakistan. So a marked improvement. There was elimination of wild types 2 and 3, and there was a greater than 99.9% drop in the incidence of cases from 350,000 per year down to less than 350 per year. And overall, 18 million children who otherwise would have been paralyzed have avoided paralysis as a result of the GPEI initiative. So there has been tremendous progress through global cooperation. In addition, the GPEI has built capacity because upon the GPEI have built other programs called Polio Plus, which have resulted in various activities depending on local needs, including bed nets for malaria, malaria medications, vitamin A drops, yellow fever vaccine, sometimes other childhood vaccines, soap and water sometimes for hygiene. But the front lines of the polio eradication initiative is happening largely with women. This is a slide taken from the GPEI website showing the impact of women and other caregivers in the local community going door to door with polio immunization programs. This points out sometimes the terrain is very hilly. The environmental conditions can be very extreme. There's a need to protect the virus. It's a live virus vaccine, so they use this temperature controlled box to transport the virus all around the countries. There are several 100,000 of these frontline immunization providers in Pakistan alone where they need to immunize 40 children under the age of 5 per year. So it's a very large activity and project. They also outreach to bus depots and train depots catching children in transition.
Great.
So there are several unanswered questions. Yep.
There's 3 minutes.
Thank you. Okay. There are many unanswered questions. Some of them political, COVID pandemic, economic, lower overall childhood immunization rates, complacency, burnout. The one I want to talk about briefly is the mutating oral polio vaccine. What is it? It's a virus that can emerge when a weakened virus from the OPV mutates through children who've not been immunized adequately and it continued to mutate, much like COVID virus mutates around the world. So there's been a couple of thousand cases of this over the 3 billion doses that have been administered. This up-to-date map as of August 17th shows where these overall cases of polio are occurring in the world. The red dots show paralytic polio type 1. These are confined to Afghanistan and Pakistan, a total of 25 cases over the previous year up to August 17th. Interestingly enough, since January of this year, there's only been 2 cases in the world, one in Pakistan and one in Afghanistan. And the number of environmental samples positive for polio have decreased. So whether this is also a function of COVID with decreased social interactions is not known, but this is quite a dramatic reduction, but it's still not gone. And we still have environmental samples positive for polio 1, so we know it's around. The vaccine type 2 is a problem, however. And this has been affected, however, in the future, we believe, by a new tool, which is novel oral polio vaccine type 2, designed to stop these outbreaks. It's been taking 10 years to develop this new vaccine through the support of the Gates Foundation. It's genetically stable and been designed that way. It's being rolled out already. 100 million doses have been administered. And just 9 days ago, the SAGE group just said it's safe to use for widespread rollout for this purpose. So where are we going? We're trying to develop a polio-free world. This little girl with a mark on her finger is what we want. We want all children to be immunized. This is the new strategy, trying to get rid of type 1 and to mop up the type 2 outbreaks. Summary next steps, we've made great gains, but we have to continue. We need a science-based approach. We think it's achievable to eradicate polio because we've already eliminated types 2 and 3. Progress is being made. On June 10th this year, the World Health Organization reaffirmed the GPEI plan, and they've also wanted to bolster their surveillance on a world basis using polio as a model. So where we are right now, this is an important time with a narrow window to maintain the gains achieved to date. The World Health Organization states the international spread of polio is a public health emergency of international concern. So we want to achieve polio eradication. We want to protect the children of the world. We'd ask you to please consider helping with this effort. And you can do this if you believe in polio eradication. If you'd like to help eradicate polio in the world, if you go to endpolio.org, it's an easy process to contribute to this program. The Gates Foundation is matching all grants to Rotary through this site 2 to 1, so it triples your donation. You can also get a tax receipt. So I hope you be generous and help support this initiative at this critical stage. Lastly, you can help us also by celebrating and advocating for World Polio Elimination. There's an event this Sunday, October 24th at endpolio.org, as shown here. Thank you very much.
Oh, thanks very much, Greg. That's definitely a good news story in a way, considering there's we've made such amazing gains. So, okay, well, let's move straight on to our last speaker for this hour. Dr. Michael Goitan is a spinal surgeon here at HSC, and he's going to talk to us about spondylodiscitis and what to do and what to expect, and then what to do again. So he's this is his primary practice is spinal surgery, and very involved at the spinal unit at HSC. Sorry. So over to you, and I see you already have your screen up.
Thank you, Richard. Can you hear me?
Hi, Michael. Yes, we can.
Hey, good afternoon, all. I'm the former head of the spine program here at HSC, and that spine program allows you to get access to a spine surgeon 24/7. So I'd like to extend a big thank you to John Emble for allowing me this opportunity to participate in this Bug Day, and a topic I hold close to my heart because, you know, once you involve a spine surgeon in this process, the cat's out of the bag and it's a bigger problem down the road. And also, John, congratulations on your 25th anniversary. These are my disclosures. The relevance of this is the implants used in the surgical treatment of spondylodiscitis or infections are both J&J and Stryker. So the objective of this talk is to allow the participant to appreciate the clinical presentation of de novo spine infections. And these are not post-op surgery or surgical spine infections, but hematogenous-based discitis, spondylodiscitis, epidural abscess, and psoas abscesses, and then subsequently understand how this occurs and what's the pathophysiology of a spine infection, and then appreciate the medical and surgical management of a de novo spine infection. So when we look at the incidence of spondylodiscitis, when you look at the world literature, it's anywhere between 2.5 to 6 cases per 100,000 persons per year. And the difficulty with this, it can either be those individuals who may present to an emergency department with back pain and have workup of this, or it's a retrospective diagnosis seen on incidental imaging, i.e. with MRI being performed so regularly for pain or a clinical scenario of a radiculopathy in pain, it's seen after the fact, and hence why it's added in. So to get an absolute exact number of this is difficult. The only thing that I could find that would perhaps maybe parallel this is when we look at the cardiology data from 2018, where infective endocarditis, there were 5.16 cases per 100,000. And of these, greater than 50% related to IV drug abuse. And certainly we're seeing this on the spine side, you know, where there pre-COVID, it was rampant in terms of intravenous drug use, not only in a younger age population, but even older patients. So somebody who's struggling with chronic back pain, neck pain, etc., they take into the habit of injecting oral medications and hence would introduce Staph aureus into their bloodstream and then to the spine. Other indolent infections that we typically see, but certainly creating an osteomyelitis versus an epidural abscess or spondylodiscitis related to TB, blastomycosis, and some protozoal infections. So the disc has a fairly unique nutrition, and hence that's why it tends to be an excellent petri dish for the propagation of bacteria. So the intervertebral disc does not have a direct blood supply, hence it receives its nutrition via diffusion. There are end loop capillaries that are juxtaposed to the end plates, and these end loop capillaries are kind of like renal tubules. They're very slow flow, decreased oxygen content, and decreased pH, and hence a perfect petri dish for the propagation of bacteria. And I think when you look at the hematogenous spread to the spine, whether it's venous or arterial, it then tends to result in two distinct possibilities. When we look at the valvulus plexus that drains the pelvis and the lower extremities, Batson's plexus, this already drains up into the chest. And these bacteria can seed the epidural space and create an epidural infection with cord or quina compromise, and that can extend to the facet joints. Whereas if you truly have an arterial spread to the end plate and then the disc, this typically creates erosions, collapse, and epidural abscess and or psoas abscess. But the bottom line, it's always venous, or pardon me, hematogenous spread. The clinical presentation and what we're trying to identify or establish here is a pattern recognition. Usually patients present with unrelenting pain in the cervical, thoracic, or lumbar spine. And the lumbar spine is the most common area of affliction because of its, rich blood supply. They may have concomitant complaints of radicular pain or loss of motor or sensory function related to either direct compression or fracturing of those vertebrae, and typically a history of recent fever and chills. Obviously, if they're using a non-tunneled catheter for whether it's chemotherapy or dialysis would be a risk factor, but perhaps even more a bit clandestine is IV drug use. And you have to actually ask patients this. It's obviously sometimes an uncomfortable topic, but don't get kind of duped that it's a young person's disease. As I said previously, there are patients in their 50s who are chronic IV drug abusers because of chronic pain. The obvious ones are those who are immunocompromised, whether it's iatrogenic in treatment of autoimmune diseases using the anti-TNF alpha agents, chemotherapy, or steroid therapy, acquired with HIV, or metabolic related to diabetes, alcohol abuse, and malnutrition. So part of the physical examination always should be vital signs. Might seem pretty basic, but oftentimes it's overlooked. And what we're looking for is a objective fever or temperature. Can that patient sit, stand, or walk? And typically in a scenario where that patient is so debilitated, they cannot. It hurts too much. They're bedridden. And unlike with degenerative disease of the cervical, thoracic, or lumbar spine, palpation is paramount, meaning if you press on the spinous process of T12 and L1, that's likely the affected segment. Whereas in the degenerative scenario, you see degenerative disc disease, facet arthropathy, and hard to pinpoint what's actually the pain generator. Here it's a bit more distinct. We have to do a fairly detailed or neurologic examination looking for myotomal weakness, long track signs, and sensory loss. And in those scenarios where they're non-ambulatory, looking for upper motor neuron signs. This is compression of the cord in the cervical or thoracic level. The psoas sign was typically described for that of appendicitis. However, it's like a femoral nerve stretch. And when you have involvement of the psoas musculature, extending that leg in the lateral cubitus position will create pain. The difficulty with this examination is patients are often too painful or in too much pain, pardon me, in order to allow this exam to take place. So I'm presenting now radiology versus blood work. And typically a spine infection is a radiographic diagnosis, and then we put the pieces together after that. So one of the things that we should start with is a plain radiograph, looking for disc space narrowing and end plate erosions. So as that end plate becomes irregular, the disc loses its nutrition and quickly loses height. We can confirm this with 3D imaging such as CT and MRI. CT looking at the bony architecture, MRI the neural elements, marrow, and soft tissue. So here we see the CT of that same patient who had a plain radiograph that just showed disc space narrowing, and we see fragmentation of the disc, osteolysis, and a kyphotic deformity. And on the axial view, so think of the patient with their head into the screen, their feet coming out. On the right-hand side, we see enlargement of the psoas on the right-hand side with respect to the left to clinch a diagnosis of a psoas abscess. So likely that infection embedded itself in the disc space, created osteolysis of the end plates of L2 and L3, and then spread to the disc space, auto-decompressed itself in the front. Pus needs somewhere to go. The MRI not only will show those aforementioned findings, but the usefulness of that is to reveal the amount of edema, which we can't tell is that an osteomyelitis or is it purely reactive edema, but also what's happening to the levels above and below. Has this created an abscess above? So what we don't want to do is miss a skip lesion at the area of affected, but also higher up in the spine. So typically we're going to get an MRI of the cervical, thoracic, and lumbar spine. This is a case of an epidural abscess where we see effacement of the CSF from T3 to T10, an actual discrete cord compression related to purulent material being caught in the epidural space. And in most individuals, there's a layer of epidural fat, and that abscess or pus gets trapped between the spinal cord here at T8 and that epidural fat and creates a thoracic myelopathy or an acute spinal cord injury, rendering that patient paraplegic and necessitating a surgical emergency. if we have the luxury of time, what we hope to do is get a CT-guided biopsy, meaning unless the patient is septic and needs antibiotic therapy started immediately, or does not necessarily need to get to the OR immediately, we're going to ask our interventional radiologist to get a tissue sample for us. And we obviously want to do that for bacterial etiologies, aerobe, anaerobe, TB stain and culture, fungal stain and culture. And in some cases where it's a very low virulence organism, we're going to insist upon pathology, because oftentimes we'll be able to tell, based upon the cell types that are there, what actually was the bacterial infection. So, parallel with imaging, we need to do some blood work, obviously a white blood cell count, and ESR CRP, which is going to be elevated as an index measure. But we're also going to use this as time goes on to be able to tell us what to do with our antibiotic therapy. We're hoping that these numbers will fall, and if they're not, well, then we may have had inadequate treatment or a walled-off abscess or inadequate surgical treatment. Antibiotic therapy should be withheld until an organism is identified. Oftentimes it clouds the scenario. If we have positive blood cultures, there's likely a 50 to 60% chance that those organisms are correlative to what we're seeing within the spine. The role of surgery is going to be for source control, neurologic deficit, correction of deformity, instability, and reduction in pain. And what we can do with surgery is a decompression, i.e. formally removing those compressive lesions, whether it's related to fibrotic tissue or active pus, or by stabilizing the spine, putting one vertebra back into place, reduce that neurologic deficit. And obviously with that is deformity correction. So what we're trying to do is reduce the amount of pain, reduce the amount of energy expenditure that patient has to undergo in order to sit, stand, and walk properly. So the case we're going to present is a hallmark case of typically something that we see. And although I'm presenting as a surgeon, the care of these patients is not just around one individual. It's the primary care doc, primary care nurse, associated medical staff, obviously the infectious disease people, and surgery, I think, is a small part of this whole process. But the primary thing is pattern recognition. So this is a 44-year-old female, known history.
Sorry, Michael. 2 minutes, is that possible?
Oh, yeah. Always. Past history of type 2 diabetes, 6-week history of progressive low back pain, has had repetitive emergency visits. And we see here that she's got a scoliotic deformity apex to the left, kyphotic deformity. We see that there's fragmentation on the CT scan, confirmed that we see that there's significant bone loss here at the L2-3 level to account for her back and leg pain. The MRI shows that there is compression upon the neural elements, the exiting nerve root, and hence this is what we've got to then apply to that patient. You know, fairly invasive surgery where we've got to come around to the front, take out that disc, that necrotic tissue, put implants to stabilize the back, bone graft the front, and this is treatment in addition to antibiotic therapy. The difficulty with this scenario, if we have somebody who's a recurring IV drug abuser, we are at point A, but the likelihood of them reinfecting with continued IV drug use is pretty high, and either these implants are going to get colonized or another infection, either cephalad or caudad. So finding or identifying this entity at an early stage and avoiding surgery, I think, is a crucial point in the outcome for a lot of these patients. Certainly we can make things better, but by no means it's lures that we've created here. So fortunately, we were able to get adequate bony purchase, reconstruct the spine, reducing the amount of kyphosis, relordosing the spine, correcting the scoliotic deformity. She's going to remain on IV by antibiotics for approximately 6 weeks and then to oral. And the difficulty that we have is, other than pain, which is obviously very subjective, and ESR-CRP, how do we radiographically prove that we've eradicated that? And I think the best thing thus far is a PET scan after completion of antibiotic therapy. And what we're looking for with that is a lack of metabolic response from those previously infected tissues. So when to call a spine surgeon? Obviously, if there's a severe motor or sensory deficit, loss of function, unrelenting pain and immobility, we failed a CT-guided biopsy of the affected area, and we need source control, persistence, recurrence of infection. Thank you very much for your time and attention.
There we go. Thanks, Michael. It's always very worrisome clinically when we see those sort of things. So, and I have to admit, I've always been very, very happy when I call up and it's yourself or Dr. Beringer. It's like, oh, fantastic. But anyway, okay, so let's move on to some questions. So I see there's definitely a few TB questions for sure. So, Martha, oh, there you go. Okay. So, is there a provincial or national strategy to focus on the diagnosis, treatment, and prevention of TB for First Nation and Métis and Inuit communities in Manitoba?
So there is the federal government does have a national strategy for the elimination of TB in First Nations and Inuit communities on a national level. Obviously, at a provincial level, FINIB is quite involved with TB strategies for elimination. I think the most successful strategy, actually, that I am aware of nationally is actually the Inuit strategy, and it's really taken it to a new level. It's community-driven. They've had massive sort of community events. And with linkage to the federal government, they brought in x-rays to communities and they've done on-the-spot assessments. So there are national strategies. I don't know how effective they are because TB is intimately linked with poverty. And my slide that said TB is a comment on society, I think holds true. So for us to eliminate TB, we are going to have to answer all the calls of the Truth and Reconciliation Commission.
Yeah, it sure sounds like has become a common theme in a lot of our talks today, that's for sure. So, okay, so, there's another question for you. 20% of people with active TB have a negative TST. So will a similar percent of people with latent TB also have a negative TST?
It's almost a diagnostic. So we know that if you are immunosuppressed and you have had prior TB infection, you can have a negative TST or IGRA, and that would imply that your immune system is suppressed for whatever reason. The most common would be HIV. So, for example, if someone is living in a house with a close contact of a highly infectious case of TB and, for example, had AIDS with a CD4 count of less than 20, we would offer treatment for latent TB after ruling out active TB, regardless of what the TST is, if their CD4 count was that low. So, in fact, we do have to take into account, because both IGRA and TST require an intact immune system, we actually do have to take into account what their immune system is when we're reading it. And I think if people recall, there's different cutoff points for the TST, and in part that takes in account what the immune system is going to be and what the positive, sort of the pretest probability is.
Right. I don't know if you can actually see in the chat side there's Dr. John Connolly has actually asked you a question. Interesting, talking about group A strep. But could the heart disease, pneumonia, and renal deaths in children in the residential schools have been due to group A strep and all those complications, and thus potentially exceeding deaths due to TB, or was there clear respiratory findings?
Yeah, that's really interesting, John. I think the reality is the healthcare was so poor there that we won't know. So we do know what we do know, I guess. And so what is reported is that TB by far and away was the most common killer.
Okay. All right. It looks like we've got a great question for Dr. Hammond. So, nice and brief, do you think measles can be eradicated? I mean, does that fit some of the criteria where we can actually follow the footsteps of polio?
Thank you, Richard. I think technically it does. I think it does fit into the category where it would be parallel to polio for many of the parameters that would be needed to eradicate it scientifically. One of the other things that measles helps it to be recognized. It's quite often very symptomatic. So it has a rash that polio does not have. So similar to smallpox, where it was recognized what smallpox was because of the rash, measles does have a rash, and that might enable it to be recognized. One of the challenges, though, if you look even at North America, one of the problems we're having now is vaccine hesitancy, and our immunization rates are not high, and they're falling down into the 70% range in many cases. So that's a major concern because measles is highly infectious. It can also spread by aerosol, and so that makes it difficult to control. You can't even control it easily with hygiene sometimes. And when you have immunization rates that are in the 70% range, you're not really getting enough herd immunity. So the major problem with measles is a low immunization rate. It's also a live virus vaccine, so it requires great handling skills. But I think it could be overcome, but it takes a great effort and consistency of immunization and acceptance of vaccine programs, which we have to get better at, even though we've got all these great vaccines.
Yeah, that's right. I have to admit the pandemic has definitely brought out some of the worst. So anyway, okay, Michael, there is a question here for you. So the provincial strategy to limit lumbar MRI to leg dominant pain of 3 months duration. So do you think that we might limit early diagnosis of the spondylodiscitis?
Yeah. So really good question. And, the difference between that group of a spondylodiscitis and the degenerative is the persistence of pain and pain that's nocturnal. Typically degenerative disc disease will give you pain that's related to that brought on by weight bearing or being upright or sitting, whereas the pain related to an infection typically is recalcitrant to reasonable analgesia and there at night. So, I think our radiologists are certainly attuned to this as well. And, if you had any question about that being a worrisome entity, despite what I just said, calling a radiologist, by far, majority are very happy to accommodate you on an early basis. So. And even then picking up the phone when to call a spine surgeon, running that by them as well.
Yeah, totally. Something we often forget to do, but you pick up the phone, it's amazing what you do.
Yeah.
Okay. All right. So, we've still got a minute or two because we do have a stretch break now. So let's try and get through one or two extra questions quickly. Current recommendations of doing TST with individuals who receive BCG vaccine as a child, and then you can see does a BCG is at birth or later. So those two questions are actually the same.
Yep. So BCG at birth, we feel does not affect the TST result. It's really the BCG after age 2, or if they had 2 BCG vaccines for whatever reason. Some countries actually would give a booster vaccine when people go into primary school. Mm-hmm. So they've had 2 or more vaccines, or if they've had them over age 2, then you should actually, IGRA would be your preferred test.
Yeah. Okay, good. All right. And what's this top question? Okay. And Greg, maybe you can help with this potentially clinic in Winnipeg where we can send post-polio syndrome for long-term follow-up. Are there neurologists that are helping with this?
Yeah, so post-polio syndrome is a weakening of the limbs of many patients who've recovered from polio. It seems with time there's a somewhat of a degeneration. I'm not an expert in this, but it is a neurological condition that is real. I just don't know if there's any specific neurologist. I think a good neurologist should be able to give some guidance on this. Again, there are mechanical assists that can help people who have weakness of limbs, but that's one of the unfortunate features of polio, is that this is a long-term, it's like long COVID. There are long-term sequelae, and most of them are not reversible. Again, just to reemphasize the point again, until polio is eliminated in this world, we have to be aware of the potential spread. It can spread fairly easily, and we have fairly widespread these circulating vaccine strains right now. So I just would say that, again, to reemphasize the value of immunization for prevention, because there is no treatment.
Okay, and last question just before the break, because we do have still time for a break. Rasmussen's aneurysm, anyone?
It is uncommon. I'll tell you though, 2 years ago, we had a Rasmussen's aneurysm in the form. It's an artery that courses through a TB cavity, and it ruptured. So the person was lucky to survive, but had to have an emergent pneumonectomy. It's a very uncommon but lethal complication of cavitary TB.
Okay. Well, thank you very much to the three of you. Yet again, some excellent discussion, excellent presentations, and continues to emphasize the importance of health is not just on its own, it's part of the bigger picture, and health equity, and looking after those people that are sometimes they don't get access to vaccines and all sorts of things. So, all right, now stretch break is until 3 o'clock, so we've got over 10 minutes, and then we're going to be coming back for it looks like our last session of speakers. So that's going to be, we're getting close. So 3 o'clock. Remember, please go and do your evaluation of the speakers, and we'll see everyone shortly. Thank you. Okay, well, welcome back, everybody. We have one more hour of the 25th Bug Day. We've had an incredible day so far, lots of really, really good speakers, and we're actually circling back to our keynote speaker from the day. Karen, I'm really appreciative that you've hung in this long. That's great. So for those that ended up missing this morning, you'll only get 15 minutes of Dr. Karen Doucette, but she is renowned professor from University of Alberta, and she spoke to us about transplant medicine this morning, but now she's going to switch a little bit and move over and talk about infections in the immunocompromised host. I think that's obviously very important at the moment with COVID. And I'd be interested to hear your ideas on how what we do with vaccines for these compromised hosts. But anyway, that's an aside. Over to you, Karen. And it looks like you.
All good?
Yep, there we go. It's all good. Thanks.
Thank you very much, Richard. So I'm happy to be back again. And so I'm going to talk about, so this is a very broad overview of infections in immune-compromised hosts. I'm going to touch very briefly on COVID, but the rest of the panel will be talking about COVID, so I can answer hopefully any questions specific to immune-compromised hosts towards the end as well. So doing the good, preventing the bad, and avoiding the ugly. So first of all, these are my disclosures. Relevant to this talk is largely related to clinical trials that I have done or currently am participating in related to vaccines, as well as antivirals, particularly for CMV and immune-compromised hosts. So prevention, I'm going to talk about the good things in prevention, talking about some of the gaps and challenges, particularly in CMV prevention, but also treatment. And then towards the end, we'll talk a little bit about invasive fungal infections that can unfortunately still get very ugly. So very broad topic, immunocompromised hosts. Actually, if John Connolly is still around, we were talking earlier today about this. In the setting of COVID, who's immune compromised, what degree, how does that impact your risk to various infections? So this is a broad and increasingly prevalent population. Primary immunodeficiencies, or what's now been called inborn errors of immunity. There are over 100, but these are relatively rare and generally present in childhood. Far more commonly, secondary immune-compromised hosts typically present later in life and are as a result of an underlying condition. So for example, diabetes or HIV infection, or are a result of therapy for an underlying condition such as cancer chemotherapy, or in the case of transplant, the immunosuppression required. There are a number of specific immune deficits, so whether it's in humoral immunity and B cells and antibody production, or cell-mediated immunity, different deficits in phagocytosis or complement specific, but very often, particularly in adults with secondary immunodeficiency, they're really mixed patterns, and some component often dominates, but there are risks that span across different components and different arms of the immune system. So I put up here, so predominantly the work that I do is in solid organ transplant, but I could have put up here similarly a timeline post hematopoietic stem cell transplant, or different periods of risk depending on your underlying immune compromising condition. So when we talk about immune compromised hosts, it's really important to think a little bit more specifically. So we think about what is the net state of immune suppression. So not just what is the underlying primary disease, but what are the other factors that may be playing a part. So in the case of solid organ transplant, there's a surgical intervention that puts people specifically at higher risk early post-transplant for actually all of the typical infections that any surgical patient might get. So these are the nosocomial infections, pneumonia, C. difficile, surgical site infections. So we see lots and lots and lots of routine surgical site infections, unfortunately very often with more drug-resistant organisms, but otherwise fairly typical. For following solid organ transplant, there's then a peak period of immune suppression. So when the immune suppression levels are the highest during the first 6 to 12 months. But there also, this is a time when we typically now have preventative strategies, so giving prophylaxis for viruses, for pneumocystis, that actually has pushed the timeline out a little bit. So whereas we used to see CMV or pneumocystis very early post-organ transplant, it's now very, very uncommon to see those infections in the first 6 months or 12 months following transplant. And those complications are pushed out following the period of prophylaxis. Very late post-transplant, so of course the goal of undertaking solid organ transplant is to return people to high quality of life where they engage in community activities. And that can be associated then with a higher risk of community-acquired infection. So for example, on here, West Nile virus. So patients who are immune suppressed are at higher risk of getting severe disease related to West Nile virus infection. And so we need to think about strategies that both allow people to return and engage in their activities of daily living and enjoy their life, but also try to minimize some of these potential risks. So minimizing risk pre-transplant, so donor and recipient screening, which I talked a little bit about this morning specifically, but really a lot of this is basics, taking a history, understanding what potential transplant candidate may have been exposed to in their past based on where they've lived or infectious complications they've experienced, undertaking serology testing and nucleic acid testing based on the standards that exist. So for things like we talked about this morning in bloodborne pathogens, toxoplasma, syphilis, et cetera, are all routine screening. Immunizations are also a key part of prevention. So there are protocols in place to ensure that transplant candidates have undergone all of their routine immunizations so that they, have it reviewed through public health, that they've had their polio vaccine and their MMR, et cetera, et cetera. Some of the things that are particularly important are hepatitis B vaccine, which can allow for that expansion of a donor pool to receive organs from donors who had higher risk or may have had hepatitis B infection in the past. And then a number of vaccines, it's very important to ensure that people are vaccinated prior to transplant, although they are to a degree immune compromised by their underlying primary disease that makes them a transplant candidate. They will generally still respond far better to vaccination prior to transplant than after. So particularly important in children who may still be in the process of completing their primary vaccine series, in which there are schedules to accelerate this to ensure that they are vaccinated prior to transplant. But in adults, particular to COVID-19, this has become a fairly hot topic recently in the transplant community about vaccination prior to transplant and whether these should actually be mandated and required, and that if people are not vaccinated, that they may not be eligible for a transplant. And the reason for this is that the outcomes of vaccination following transplant are still quite poor, so that only about, even with the 3 doses, still about a third of solid organ transplant patients remain at risk for COVID-19, have poor or no vaccine response. And this is a small study that was published in Clinical Transplantation that demonstrates that if this is in kidney transplant patients compared to dialysis, and you can see that those who are post-transplant, less than 50% had a serologic response to COVID vaccine. However, when they were vaccinated prior to transplant, when they were on dialysis, the overwhelming majority actually seroconvert, and their antibody levels, their neutralizing antibody levels are also higher. Still not as high as control subjects who are otherwise healthy, but significantly higher than those who are vaccinated post-transplant, which again, long-term follow-up will demonstrate, but it's likely that they will ultimately have better protection from COVID-19 disease long-term. So another part of prevention is prophylaxis, so pneumocystis, which is routine prophylaxis with TMPSMX. Again, very, very rarely seen now in organ transplantation with routine prophylaxis. And then herpes viruses, again, I'll talk a little bit more about CMV, but also HSV prevented with antiviral therapy very effectively in that period of the highest risk of immunosuppression. Antifungals are challenging, so we can certainly identify groups. So for example, in solid organ transplant lung recipients, or those who undergo hematopoietic stem cell transplant or acute leukemia induction therapy, are at much higher risk of invasive fungal infections and may benefit from prophylaxis as well. So we can lower the risks through prophylaxis of fungal infections as well. And strategies for safe living, as I referred to, just some advice around consumption of food. So not eating raw deli meat, for example, safe water supplies, mosquito avoidance to limit risks of other community-acquired infections, which these patients who are immune suppressed are at higher risk for and higher complications. Cytomegalovirus, I'm going to talk a little bit about, it's a bit of a good news, bad news story. So as we have very effective prophylaxis and preemptive therapy. So prophylaxis means we give a whole bunch of high-risk people an antiviral and we can prevent CMV fairly effectively, or we do preemptive therapy where we do a lab test to monitor for CMV, and we're able to pick up low-level CMV reactivation and intervene with antiviral before people develop disease. And these strategies are pretty effective and have substantially lowered the risk of CMV infection in particularly solid organ transplant and hematopoietic stem cell transplant recipients. But there are a lot of challenges that remain in terms of late onset CMV, and we lack reliable predictors of individual risk. The therapies, so the backbone of therapy remains ganciclovir or valganciclovir, which has significant side effects related to marrow suppression. And recurrence, because this is a virus that persists forever and we have no curative treatment, recurrence and resistance remain a challenge. So is prophylaxis or preemptive therapy better? We still don't actually know the answer to this, and it depends on the risk group, and it just depends on your perspective to a degree. So this just shows you, this is a recently published trial in 2020 in JAMA that looked at liver transplant recipients, which as a group are at relatively low risk, although these were a higher risk based on serology, and that the donor was positive and the recipient was negative, and they compared preemptive therapy to prophylaxis. And you can see that the conclusion here was that preemptive therapy was actually more effective with fewer patients developing CMV long-term, with the theory being allowing the virus, allowing the immune system to be exposed to the virus for short periods of time and intervening with antiviral therapy thereafter may actually then train the immune system to develop better T-cell mediated immunity in the long term and avoid these higher rates of CMV that we're seeing with antiviral prophylaxis. But this does carry risk, and it carries complexity because you have to actually monitor, do the test, and intervene. And so most, well, in fact, all guidelines and most institutions continue to use CMV prophylaxis as their backbone of prevention in this high-risk group of organ transplants who are donor positive, recipient negative. There have been some advances. So this is very old, showing you from 2010, valganciclovir effectively prevents CMV in solid organ transplant for as long as you take it. And this was 100 days compared to 200 days. And while you're taking it, people don't get CMV. But when you stop it, a significant portion still do get CMV. More recently, in stem cell transplant, letermovir, which is a newer antiviral that does not have the marrow suppressive effects of valganciclovir, was looked at prophylaxis in stem cell transplant. And this actually significantly reduced the risk of CMV in high-risk stem cell transplant patients and, in fact, decreased mortality. But again, you can see that over time, these patients still develop CMV. So we have made progress, but we still see late onset CMV, and we don't have good predictors. So cell-mediated immune assays have been looked at and do provide some evidence of the development of CMV-specific immunity, but overall do not have very good predictive value on an individual patient basis. Some of the new therapies, so
2 minutes?
2 minutes, that's yep. Good. So maribavir is another new antiviral for CMV, which is currently undergoing review by the FDA and by Health Canada. And this is a drug that, again, it has a niche, but isn't a game changer in CMV, I would say. So this trial looked at those who were refractory or resistant to standard therapy with ganciclovir or valganciclovir, and compared it to what was called investigator therapy. So what would you use if you didn't have access to maribavir, which was largely foscarnet, which is very toxic, largely with renal side effects. And you can see that maribavir was superior, but still, again, fails to clear CMV in a significant portion. And once you stop, there are high rates of recurrence. So just finally, I'm going to very quickly just talk about fungal infection, aspergillus being the most common one we worry about. And this is ubiquitous in the environment and is inhaled and can cause severe disease in immune compromised. In particular, we worry about solid organ transplant, hematopoietic stem cell transplant, who get invasive infections in the lung, sinuses, and brain predominantly. And although there are now many new and emerging therapies, prevention is very challenging because this is, as I say, an organism that is present everywhere in the environment. And I just have a few pictures to end on with a number of mold infections. So a kidney transplant patient, and this is fusarium. So this was a patient who actually worked as a farmer. So again, has returned to their life, productive, working as a farmer in Alberta, and unfortunately got this infection, although it was cured. less good outcomes. So this is a leukemic patient who developed an invasive fungal infection of the lung and dissemination to the brain. And as you can see here, the diagnosis was made by a burr hole brain biopsy. And unfortunately, months later, despite being on antifungal therapy, this actually started to emerge through the burr hole. She survived for about 9 months on suppressive therapy, but had relapsed leukemia and eventually died from that. And just finally, to compete with the surgeons, I have this picture from a surgeon. So this was a young woman with cystic fibrosis who actually developed discitis due to scedosporium, which then extended and resulted in this mycotic aneurysm. She underwent surgery and had complete replacement of her thoraco-abdominal aorta, which, as you can see, was about to fall apart and had a hole in it and attached to the spinal area of infection. All grew scedosporium. She actually also lived for almost 4 years after this surgery, but eventually died of recurrent mycotic aneurysm. So this is really the ugly that we do our best to prevent, but unfortunately still occurs. I will stop there.
Thanks very much, Karen. Not sure that too many people can beat that. That was a good picture. Good. Okay. All right. Well, let's move on. We have got Dr. Jared Bullard. There he is. The infamous Dr. Jared Bullard. So he is a pediatrician, ID specialist. He's associate medical director of CADM Lab, and was instrumental in doing a whole lot of CME last year. And clearly you did fantastic because we've asked you back. So well, welcome, Jared, and you're going to be talking to us all about vaccines.
Absolutely. Yeah, well, thank you for having me again. It's always my pleasure to really come and help dismiss all the misinformation that's out there. So my talk will be specifically about children and vaccination for COVID-19. There we go. I have no conflicts of interest at this point. I'd love to figure out how to do that at some point, but we'll do that another date. So the objectives really are to go over what we've learned since wave 1 when it comes to SARS coronavirus 2 and children, because our initial interpretation and expectations of what would happen has changed quite a bit. As well, we're going to talk about what the goals of vaccinating children are comparatively to adults, because of course we're very familiar with what happens, particularly with older adults and how sick they can get. But that's not the same in children. And finally, we're also going to talk about some of the side effects of COVID vaccination, particularly as it relates to children and some of the early signals that we saw. So I'll start with this. It's an interesting diagram. I was presenting grand rounds in the Bahamas back in June and trying to relate how big Canada was. I'm originally from the Bahamas, and all the islands could actually fit in Lake Manitoba very easily. And so this was a map just to help them understand, like, this is how big Canada really is. And you can see that over the course of the pandemic since March of 2020, there have been just over 340,000 children infected with COVID. Of those, almost 1,800 are hospitalized. But it's really important to understand that just because you're in hospital with COVID does not mean that you're in hospital because of COVID. In fact, a lot of the time, children that are in hospital are just coincidentally are found to have it on screening tests on admission. In addition, a number of children are in ICU, and a good proportion of those are actually with multi-inflammatory syndrome in children. And ultimately, even though we say that children don't die from this, there have been 18 deaths across the country, it's substantially less overall than when compared to adults. What we see also when we're talking about Manitoba is that we've had about 15,000 children infected with SARS coronavirus 2. So proportionally, we're about the same. And what you've seen over wave 1, 2, and 3, and as you go into 4, is that the proportion of positive cases is increasing in children. So initially, it was around that 20 to 25% mark. It's now upwards of about 30%. We have very similar statistics when it comes down to those that are in hospital in the ICU. 2. It's a little bit higher, but at the same time, the COVID in this province really has disproportionately affected kids that would likely come into hospital for other reasons as well. The interesting thing is we did have 12 cases of this multi-inflammatory syndrome in children initially. That was primarily back in wave 2, but since then it's actually dropped off, and we'll talk a little bit about that. And of course, we've had 3 children in Manitoba die from COVID. So what do we see? Well, typically, and this is a big difference again compared to adults, children have asymptomatic disease or polysymptomatic disease, meaning that their symptoms are often very mild. When they do get these, it tends to resolve quickly compared to adults who tend to be sick for the better part of a week. Children tend to get better in the course of a couple of days. The most common symptoms that we see are primarily fever and cough. And so that also is important to understand, that a lot of kids come into hospital, particularly infants, when they have fever, because we have to rule out a lot of important causes of infection in them, including bacterial infection. Headache is also seen to some degree. Long COVID, which is clearly an issue in adults, is seen in children, but again, to a lesser degree. And so that's an interesting finding that, again, is an evolution. So how is COVID transmitted? And that's really the big question, because when we think about children, we know that they're the sentinel group for a variety of respiratory viruses like influenza and RSV. So typically you see them getting it first, and then a couple of weeks later, you see it transmitting in the adult population not long after. And in fact, you can still see this to some degree, even with all the COVID restrictions we have with rhinovirus and the colds that are just flowing through those kids right now. So typically, when we're thinking of COVID in children, they acquire it within a household. So they can get infected. And typically when they do, it's because an adult is in the house or an older sibling who's out in the community and brings it home to them. Now, that's not to say that children can't transmit this. They can. They're not quite as good at it overall. So we know that also when we're talking about children and their transmission to other household members, it tends to be about 2 other cases. So it's not quite as dramatic. Like with Delta, typically what we've seen is a case goes into the house with an adult and everybody gets it subsequently. With children, it's not quite behaving like that. And so that's, again, different. And that's even with Delta. We also know that preschool children, so the young kids require a lot of handling by their caregiver, are much more likely to be able to transmit that to those caregivers, whereas the adolescents who hide in their basement bedroom looking at TikTok and other assorted activities rarely transmit. But the key take-home message from this is that the single greatest risk to children, in fact, is their household members, in particular if they're unvaccinated. So what about schools? Because schools is the other place where you would think of children as having a lot of contact with other children and also teachers and other educators. In fact, a substantial portion of their day is in fact there. And what you can see with this particular diagram is that in waves 2 and wave 3, the epidemic curve is actually following what's going on in the general community. And even now that we're in wave 4, you can see the same sort of trend going on, in that the cases in schools, either in teachers, educators, or students, is again paralleling the curve that we're seeing in the general population. And so that's in fact what we've seen the entire time, is that COVID activity is a reflection of what's in the community. So if you have a community that has substantially more COVID activity, and at this point, it's in northern Manitoba, more in southern Manitoba, there's more cases in those schools in particular. But it's important to know that, again, most of that is actually occurring in households and not necessarily in schools. So direct cases attributed to outbreaks in schools is actually less than 5%. So that's what's happening with children. But what about teachers? Because again, teachers are very used to getting sick all the time from all sorts of different respiratory viruses. And we have a lot of data coming from various parts of the world and of course across Canada as well as here in Manitoba. And so we know that when we look at symptomatic cases diagnosed here in the province in teachers, or people who identified as teachers and educators, that they were actually a little bit less, lower rates than the rest of the general adult population. We also know that when we look at seroprevalence data, in particular in BC, which is very good and has a very comprehensive study ongoing, that the seroprevalence of adults either teachers or in the general community is about the same. And so that's actually very reassuring. In addition, Ontario is doing a very similar study. And what they're looking at is actually what exactly is the risk factors that increase the likelihood that you're going to get COVID. And so, like I was saying earlier, households seem to be where you're most likely to get COVID, and that applies to teachers as well. In fact, if you have an adult, there's a substantial chance that you're going to get COVID if it's in your house. Interestingly, students with COVID and children in your household have about the same increase in your risk. And finally, there's also travel. If you're to go outside the province, you're more likely to pick that up. So overall, what that suggests is that there's many interventions that have been undertaken in schools to make it a safe environment when it comes to COVID. So we have social distancing, masking, hand hygiene that's regular, and trying to make our kids' lives as normal as possible with COVID in place. But overall, this seems to be somewhat protective, and so that's actually good. Now, a lot of the cases I've heard about, or people have brought up a story that came out of LA through the Morbidity and Mortality Weekly Report. So this is published through the CDC in the US. And it's a really interesting story of a number of kids that got Delta from a teacher. So the story goes that this teacher had mild rhinorrhea, so runny nose and congestion for the better part of 2 days. And she was attributing that to her seasonal allergies. And so she was at work and she was wearing a mask, and they were doing all the things that you would expect in a classroom. So all the children were wearing masks quite religiously. They were all socially distanced. There was actually excellent ventilation in the classroom with the windows open, the door open, and they actually had a HEPA air filter unit at the front of the classroom. The other thing that was unfortunate was the teacher was not vaccinated. In addition, she was also taking off her mask for about a 10 to 15 minute period each of those 2 days to read to the class. And so when people saw that the secondary attack rate in that classroom was at 50% of the students got infected, they were saying that this was evidence to support that COVID is airborne. So that's not entirely accurate, right? If you think about this exact same scenario with a lot of susceptible students in the classroom with somebody with chickenpox, which is truly airborne, over the course of 4 days of transmission, everybody in that classroom would have been infected, in addition to some of the people down the hall. In fact, there are some case reports talking about assemblies at schools back before vaccination where you had a significant vis-a-vis transmission, even with as short as a 15-minute assembly in hallways. So I think the key message from this particular study is that, one, if you're sick, stay home, and two, just as important, make sure you get vaccinated, because I think that this was very much avoidable, or at least could have been reduced. So we're talking a lot about 2 minutes. Woo, or fly.
Three.
Okay. Three. Oh, thank you, Richard. All right. So what we were looking at was primarily environmental things we've done, but we also did a study here in Manitoba looking at, is there a biological reason? And because I said children are usually the sentinel population when it comes to respiratory viruses, and we didn't really get to study them in a big study that we did. So what we wanted to figure out was, well, how infectious are they? And so we took 300 samples from children, all of whom had COVID, and compared them to adults, all of whom had COVID. In no way does this represent that the testing is actually prone to false positives. And we wanted to see how often the culture was positive, what their viral load was, and how much virus grew. And what we saw overall was that the viral load did tend to be higher in those samples that ultimately grew in culture. And in addition, children tended to be asymptomatic. So when you look at these two, you can see that displayed. And in addition, you can see that the amount of virus represented by TCID was substantially less in children when compared to adults. And so the take-home message really was that the chances of a sample being positive by culture is less. For children, there is often less virus overall, and ultimately we couldn't really figure out the symptom to test time. But we kept getting asked about alpha, and we kept getting asked about delta, and so we actually did manage to look into that recently as well with another 400 samples. And what you can see here is that even though delta samples from children with COVID and adults with COVID is still more likely to grow, it's about 3 times more likely to grow compared to the original variants we had in adults and 2 times in children. And when we look at the amount of virus and viral load in delta, again, children have higher viral load. The big difference is that the amount of virus that they have is actually about the same. In fact, there is no statistical significance difference between it. So children now have about as much Delta in their nose, even if their cultures are less likely to be positive. Now, with all of that going on, of course, I think those of us who have children in school appreciate all the things going on related to lockdown and suspension of in-person school. The big one to me, honestly, is increased obesity, and there's lots of studies to show that down the road, I think this is going to be the thing that really bites us in the ass more. And it's also important to know the risks in youth. Now, again, this is individual risk for children, and so we'll talk about what that means more on a population level. Fortunately, we've actually managed to vaccinate a significant portion of the population, and you can actually see that holding across all the age groups, including the teenagers and adolescents, but it still leaves 240,000 unvaccinated children. And so these children, of course, are going to be prone to all of the sequelae of COVID. And even though it's not likely to cause severe disease, death, or hospitalization, when we're talking about 240,000 potential kids that could get this, it could add up very quickly. So what about the children? If you were watching the news yesterday, you saw that Pfizer has asked Health Canada for approval. And I think you're going to actually see this moving faster than we initially thought. When it comes to vaccinating children, we can't really do the same thing in terms of studying it. We can't say symptomatic disease. So what we're looking at instead is anti-spike antibodies. In addition, we want to be extra sure that if we know that the benefit to them is a little bit less in adults, that there's no significant side effects, either myocarditis or multi-inflammatory syndrome in children. The dosing will be different at 1/3 the dose, and there's a lot of developmental considerations as well. So children, of course, aren't little adults. You could, of course, get them to go on a field trip of horror to the RBC Center to get a bunch of vaccinations. But there are certain things will help. And so one of the things, of course, is consider all the vaccinations that they've missed as a result, making sure that we engage pediatrics and child health to deliver vaccinations. It's going to have to be a true community effort in pediatrics offices and offices across the province. We have to make sure, too, that parents are on board for vaccinating, because we know from a number of surveys that even adults that might get vaccinated for themselves may not do the same for children. So it could be as low as 50% of uptake. And we also have to make sure that certain high-risk pediatric populations are vaccinated. So that was a quick run through at the very end. Hopefully we achieved the objectives. I have the self-assessment questions as well, which we can go over, but I'm happy to go over any questions in the next little while. Thank you.
Oh, thanks very much, Jared. Great to hear things are moving ahead. Okay, all right. So I'd like to move straight on to our last speaker. So Dr. Pierre Plurd is a medical officer of health at the Winnipeg Regional Health Authority. He's a professor in the Department of Community Health Sciences, as well as in Department of Medical Microbiology and Infectious Diseases. He also this is his 24th presentation at Bug Day, which I think is outstanding. And so welcome, Pierre. It's going to be great to hear your final take on life after COVID. And what is that new normal? We can see your slides all fine.
Good, great. Thank you, Dr. Rusk and Dr. Amble, for the invitation to present. The new normal is an interesting aspect of my title. What is normal? Was it really normal before COVID? Certainly from the perspective of population health gaps and disparities, it was anything but normal for a significant proportion of our population. So again, I won't get into the nuance of that, but I still am asking the question, what is the new normal? Many people have made land acknowledgements, and so I will add to that, simply stating that I do live and work on Treaty 1 territory here in Winnipeg, and that unfortunately, many of the treaties and agreements, such as agreements made with Métis Nations, the Métis Nation made on this territory, have been broken and have resulted in past, and I want to stress present harms. And so albeit the organization I work for, the Winnipeg Regional Health Authority, dedicates itself to collaborate in partnership with First Nation, Métis, and Inuit peoples in the spirit of reconciliation. We're trying, but we have a long way to go, as you've heard in many presentations today. Again, I wish, as Dr. Bullard does, to that I had some certain conflicts of interest with commercial interests anyways, but all I've received in 24 presentations at Bug Day was over 15 years ago. I think I got a mug, well, not I think, I know I got a mug from Embel. And I just wanted him to know that it's my prized coffee mug. I still use it. And thank you for that gift. And that's all I have to declare. So what's happening? You've heard this again throughout the day in one way, shape, or form, but there's been over 240 million cases of COVID as of today, reported by the WHO worldwide. As of yesterday, today's numbers won't come out until just later in the afternoon. Canada had over 1.6 million cases, and pretty consistently throughout the world, severe illness requiring hospitalization has occurred in 5 to 10% of SARS-CoV-2 cases, with deaths anywhere from 2 to 3%. In Canada, it's more like between 1.5 and 2%. And as you just heard in the children's presentation, more so in adults, long-term chronic symptoms, initially termed long haulers, in 20 to 30% of adults with COVID-19 infection reported recently in MMWR. It's very reminiscent for me, reminiscent of post-infectious neuromyasthenia, which is a condition that I've been quite familiar with in the world of tropical post-travel medicine. This individual, Brenda Goodman, published in the Web MDTelehealth News back in January, an article that was quite telling. In fact, I borrowed part of my title from her article, which she titled Life After COVID, A Long Road to Recovery. And she described, I'll just read from her article, those deaths due to COVID have unleashed a tsunami of grief. A recent study by researchers at Penn State University found that every person who dies of COVID leaves 9 others grieving for their loss. So again, I don't have to tell this audience that there have been significant fallouts from this pandemic. And the fallouts you've heard is a variety of ways today, a significant mental health deterioration in society that has been measured by increasing suicide rates in some sectors, increasing unintentional deaths from overdoses. We've seen throughout the country, serious social deprivation due to lockdowns and some of the consequences, mental health consequences that have come out of that. We've just heard about children who have missed school and the consequences of that, and those same children who have missed routine immunizations and have fallen behind. Many people, frontline, especially those in the hospitality and entertainment industry, lost their jobs, and other people during the pandemic, frontline essential workers and healthcare workers, had too much work. It was feast or famine. You couldn't find work, or you were overwhelmed with the amount of work, which led to economic loss for many and economic gain for some. And throughout the pandemic, we became hopefully more aware of disparities and saw an increased measurement of those disparities. And thanks to the First Nations Health and Social Secretariat of Manitoba, Dr. Marcia Anderson, and the Manitoba First Nations Pandemic Response Coordination Team, these disparities were measured quite well during the COVID-19 pandemic. And as Dr. Anderson frequently points out, although only 10% of the population of Manitoba are First Nations people, First Nations have been well overrepresented, being 25 to 35% of all COVID-19 cases, factoring 25 to 30% of hospitalizations due to COVID-19, 15 to 20% of ICU admissions, and 20% of all deaths due to COVID. And measured again differently, where very good ethnicity data has been collected by Dr. Anderson and her team, severe illness and hospitalization was demonstrated to be 6 times higher in First Nations, people identifying as First Nations versus people self-identifying as white. And even in other BIPOC populations and those identifying as African or Black, risks 3 to 5 times higher of severe illness and hospitalization, with the mean ages of hospitalization in First Nations or African and Black people in their 40s versus 72 years for those who are white. Similarly for ICU admissions versus those of white ethnicity, 5 times higher rates in First Nations people than twice higher rates in African and Black. And then for deaths, the mean age of death in a First Nations person has been 65 versus 83 years overall, with twice as much likelihood of dying from COVID-19 if you're First Nations versus white. So the fallout, in addition to this, has also affected our healthcare system and healthcare worker burnout. I don't have to tell many of you attending this conference, has been a incredibly significant fallout of the pandemic. I have been the recipient, and more so some of my colleagues, including Dr. Rusin, who spoke this morning, have been the recipient of vehement accusations of incompetence in public health, related initially to a slow rollout of COVID vaccines, even though the slowness of the rollout had nothing to do with anything that was within the control of Manitoba public health authorities or even political entities in this province. But really took its toll on many of my public health colleagues, to the point that not only in our healthcare system have we had a significant loss of trust between esteemed colleagues, but in general society as well, not only south of the border, but within Canada, we've seen an increasing polarization between the two extremes, those claiming, civil liberty advocates claiming Canadian charter rights of their freedoms to do as they wish and not to be forced into mandates, versus the other extreme where physicians and scientists have demanded COVID zero or COVID suppression strategies, requiring essentially total lockdowns, closing schools, locking down the economy completely, which really put us in public health between a rock and a hard place. And this really came to a head for me in the spring, when within a span of 3 days, on April 30th, Maclean's published an article signed by many specialists actually from Manitoba, doctors and scientists from Manitoba, demanding a maximum infection suppression strategy, which is also called a COVID zero strategy at the time, trying to emulate what New Zealand was doing, which New Zealand has subsequently abandoned, by the way, as a strategy that would require a complete shutdown that would probably have to last for 8 to 10 months, really, to be completely effective in shutting down this virus 100%. And then 3 days later, on May the 3rd, the churches, we see in our local media that the churches are suing our government provincially and our public health officials for having too much suppression. So what are some lessons that I have learned? Maybe, I don't know if you share these lessons, but that I'd like to kind of share with you at this time. My sense is that over the last several months, really shaming one another, shaming our colleagues, telling our acute care colleagues, shaming our public health colleagues, and to suggesting suddenly acute care colleagues are becoming experts in public health and trying to direct our public health colleagues on how to do public health, or shaming the public, especially those who are not willing or able to get vaccinated, is not likely an effective behavioral modification strategy. We need to find better ways of encouraging people to change behaviors, because it only puts people on the defensive who end up digging in their heels. And we're seeing this in 10 to 20% of the population when it comes to COVID immunization. And I attended a talk by Dr. Brian Postal, our local Faculty of Health Sciences Dean, who reflected on 40 years of his experiences and challenges in the healthcare system. And I'd like to quote him at this time, because I thought his insightful comments were quite helpful for me. He's not telling us not to be passionate, but he's asking us to be careful how we express our anger. And he basically said, folks, pay attention to our passion, but they don't pay attention to our anger. And if we start getting angry or attacking our colleagues, people will lose respect, and you will have lost their trust in the future. And this was what he's learned over the past 40 years. So where are we now as we gradually enter into a fourth wave with trepidation when we're watching what fourth waves are doing in Saskatchewan, in Alberta, and probably now in New Brunswick as well? You know, we need to be cautious. We can't let our guard down, especially at a time where our healthcare workforce is exhausted and burnt out. On the public health side, on the acute care side, primary care side, chronic care side, everywhere. We're tired, we're sick and tired of COVID, but we also know it isn't going away anytime soon. We're not out of this pandemic anytime soon. We don't like mandatory immunization policies. Many people, when I say we, that's about 10 to 20% of our society do not like mandatory vaccination policies, but without them, too many people don't do the right thing to protect others. And it's not all about you, it's about others. We're tired of public health orders, I get that, but not enough of us are immunized, and some of us are still not eligible for immunization, as we've heard, the 5 to 11-year-old group. And so we still need the public health orders. So what do we know? We know that public health measures work. All the standard hand hygiene, masking, physical distancing. We know that COVID vaccines work to prevent infection and severe illness, hospitalization, and death. But we also know that if given opportunity and allowed to fester, our fears and our anger will take over, and that's just not healthy. We also know that, we've heard this several times today, racism, the impacts of racism have been exacerbated during this pandemic. And racism is actually the social determinant of health, not race. I facilitated a tutorial recently where the medical students' notes were listing race as a social determinant of health. And it's not race, it's not the color of your skin or your ethnicity that renders you at risk of adverse consequences. It's behavioral, it's racism. So I'd like to end with what I learned. The elders of the Taskiwak Cree Nation in northern Manitoba in Split Lake this summer invited me to join them on a canoe trip to help Indigenous youth, teenagers, who were struggling in a community that had seen about a dozen teenage suicides in the last year during the COVID-19 pandemic. And they wanted me to help work with youth. And in the process, I learned from the elders. I was gifted with 10 canoe teachings that I'd like to leave you with at this time. These canoe teachings actually originate from a West Coast First Nation in British Columbia. I'm not going to go over all 10. I'm just going to highlight 4 of them. Meaningfully addressing systemic racism will take all of our gifts and talents mixed with courage. And it will take a lot more than land acknowledgement or even acknowledging that systemic racism exists, but at least that's a start. Because some of us can't even admit, we have some leaders, some politicians and other leaders who can't even admit that systemic racism exists. So we have to start there. We will need to pull and support each other as we take on decolonization. And we're gonna have to figure out what that means, what decolonization means and what it will take. But something tells me it will take a lot of courage, and it will require that our colonial structures, like most of our healthcare system, to be honest, will have to give up some power and control. We will need to empower and fund Indigenous partners and organizations to work with us and to lead us in tackling some of our biggest challenges, including the congenital syphilis outbreak in Winnipeg, including dealing with HIV persons, with infected persons with addictions and serious mental health challenges who are currently not accessing care, dealing with a lack of potable water and a lack of adequate housing. Shaming and constant criticism of one another serves no useful purpose, in my opinion. We've been humbled by this pandemic. I'd like to ask us to consider humility when providing feedback to our colleagues who, honestly, we're all doing the best we can in acute care, in chronic care, in primary care, in public health, under the most dire circumstances we have ever faced in our careers. And then finally, we need to remember that our actions or inactions during this pandemic can have very negative or very positive impacts depending on how we react on others. And remember, it's not all about me, it's not all about you, it's about all of us collectively. And when given any choice at all, be a worker bee and make honey. And finally, to use a poster that was produced by Indigenous youth for youth in northern Manitoba that we're using also in Winnipeg during the COVID pandemic. It was initially a social marketing campaign addressing STBBI prevention messages, and they added a COVID poster in 2020. I'd like to simply conclude with this statement: COVID changed it all. But what's important is still the same. Be honest, reach out, take care of each other, especially, I would add, those in greatest need. Play nice, listen to your body, and have fun. Look after yourself. Thank you.
Wow. Such amazing words of wisdom. Thank you, Pierre. I really appreciate that. I think that those sorts of words of wisdom are needed. I think you're quite correct. There's a lot of people that are very burnt out, and this is a way for us to turn around, hey? Okay. All right. Well, kind of sad. Our last question period of the day. Had a great session, I have to admit. So, but let's do a few at least. I know there definitely are some good ones. I've been looking at them. So, all right. So our top one there, myocarditis. Actually, and I'd ask, can you kind of expand a little bit to it's not just kids, also young adults, because I've got a lot of young athletes in my practice, like up to 25. So I'm assuming that's Jared.
Yeah, so I kind of rushed through the last part of it, which I guess would have been more ideal to focus on. So myocarditis is actually a common feature of infection with COVID. And so that is including adults and pretty much anybody who gets it. The vast majority of people, of course, are not going to have a workup for myocarditis. And when we think of it, it's about 1 in 50. When we're talking about myocarditis secondary to vaccine, there was an initial signal that came out of Israel, and then they were doing some further studies on it. And so we do even have some data here in the province as well. And what we know is it's about 1 in 75,000. What's important about that particular frequency is that also falls into the proportion of naturally occurring acute myocarditis in the population in general. So it's to say that this might just be background signal, and it's not necessarily going to be teased out as we go forward, looking at COVID myocarditis post-vaccination.
Okay, all right. So next question, what metrics will we use to signal the end of the pandemic and thus end of restrictions and mandates? Yeah, Pierre, I'm sure you guys have talked about this.
Well, the focus right now is we have an opportunity in Manitoba, which was lost in Alberta and Saskatchewan. So we can learn from our Western neighbors. We have an opportunity to so-called flatten the fourth wave. We're not going to eliminate it, but we have an opportunity to flatten it. And the real goal right now is not to eliminate COVID. Elimination is just not in the cards, it's not feasible, but it's to render COVID to the point where it will not overwhelm our hospitals and our ICUs. That's the goal. And I don't know if we will achieve it. It's hard to say until we can immunize our 5 to 11-year-olds, which I think will make a huge dent. Right now, only 72% or so of all our population has been immunized. If the immunization rates in 5 to 11-year-olds reaches what it has in the older age groups, and we can reach an 85% or get close to an 85% overall population immunization rate, we may turn this pandemic into endemic SARS-CoV-2. When that will happen, your guess is as good as mine. I'm hoping that it will happen sometime over this winter, but nobody can predict.
Yeah. And I remember some of our discussions in March last year, and people were throwing out predictions. I'm not sure that anyone was right.
Yeah, about 20 years ago, I made a prediction about influenza outbreaks every winter. I basically said the most predictable thing about influenza outbreaks is they're unpredictable. And that's the same thing for COVID, right? We have no idea.
So, okay. All right. So is there any surveillance being done to see the prevalence of long COVID in children? I know there's lots of stuff for adults.
There is. So certainly pediatrics and child health and the various practitioners have been working with the long COVID adult people as well. And that's what we're doing. We're watching for it. And so far, I don't recall any specific long COVID cases being seen in children yet.
That's in Manitoba.
That's in Manitoba, correct? Yes. Right.
Yeah.
Yes.
Okay. All right. So, yeah, vaccine question. So why? Any idea? I mean, obviously, there's lots of potential speculation, but have you seen any actual reason why we aren't revamping it yet?
It's the current vaccine, at least the Pfizer vaccine, still has remarkable efficacy against the Delta variant in terms of, again, preventing what we're really trying to prevent at this point, hospitalization, ICU admissions, and death. We're still talking about Delta variant efficacy rates in the 85 to 95% with the 2 RNA vaccines, the Pfizer and the Moderna. So, we still have pretty decent vaccine.
Okay.
I think I would add to that too, that we kind of have to change our expectations of what's going to be accomplished by the vaccine. To say that you're not going to ever get infected by COVID because of the vaccine is unrealistic. We will all get infected. That is just the reality. Yeah. But like Dr. Plurd said, the vaccine is going to protect us from severe disease, hospitalization, and death, which is the goal.
Yeah, no, thank you for that. That's why I deliberately did not talk about the vaccine efficacy against infection, because that's not what we're aiming for right now. We're aiming for a vaccine that essentially protects and saves our healthcare system.
Mm-hmm. Okay. So I'm actually going to cheat. I just want to go down a little bit because, this is personal as well. For Karen, are there any reasons to defer COVID-19 vaccine transfer patients? So in Manitoba, exemption can be given if transplant is imminent, but does that actually make sense?
Yeah, so I think this is a question, everything is a quickly moving target. So, when vaccines first started to roll out, we were trying to get people vaccinated as quick as possible, particularly in that immune suppressed group. There were some people, and we actually had someone come from Manitoba who was receiving a lung transplant and got his Moderna vaccine like the day before he flew out. So ideally, we want to, allow people that time to have their vaccine series and mount an immune response. So at least 2 weeks prior to undergoing transplant. And as we're now moving further into the vaccine rollout, I think that's the reality. As I say, we are seeing mandates. So, most programs are now considering not transplanting individuals who have not at least initiated COVID-19 vaccine. But there still are exceptions, I think, to be made to somebody who presents, for example, with fulminant liver failure or, acute need for acute transplant and has not been vaccinated in certain circumstances.
Mm-hmm. Okay. All right. So there's question. It's actually the second one down there. So we've got our 1,500 children with COVID-19 diagnosed, and the old asymptomatic question, which therefore wouldn't necessarily end up in that diagnosed population.
Right.
What are the speculative numbers out there for kids?
Part of the surveillance in Manitoba includes seroprevalence studies. And so the idea there is that you're capturing the asymptomatic spread in the community. And so the most recent seroprevalence study we had was about 17%. So that's implying that that proportion of the population has had COVID infection one way or the other. And so that would translate to about even up to 45, 60,000 children that have been infected. And like I said in my presentation, asymptomatic presentations are quite common. And it might even be higher than that, right? Because seroprevalence studies are limited too, in that we only sample randomly certain parts of the population, in particular those that are most likely to get medical care and testing in the first place. So it's of course higher than the 15,000 confirmed cases.
Yeah. Okay. All right. I think this may end up being you, Pierre. What would you recommend or expect to see with respect to guidelines changing? So isolating after a close contact, COVID contact at school, once children are fully vaccinated, or even with adults at work like even as healthcare providers, we have to be so close to our patients.
Yeah, right. The reason we are so much stressing immunization with 2 doses, so becoming fully immunized, is that it will allow us to drop a lot or to relax a lot of these stringent regimes of, for example, having to isolate for prolonged periods of time. That it's not that we're going to eliminate the transmission of COVID-19, but we will be able to allow limited transmission of COVID-19 among fully vaccinated populations, knowing that it's not going to, lead to any significant amount of serious illness and serious sequelae. So the sooner that we can get this higher herd immunity to I'm guessing a good 85% or higher of the total population going down to 5 and above, age 5 and above, the sooner we'll be able to drop our guard on some of those aggressive post-contact public health measures. I don't know, Jared, if you have anything to add to that.
I think you're exactly right that when we're looking at vaccinated people, I don't think it's necessarily accurate to say that they can't infect other people. They probably can, and so if they're symptomatic, they certainly should still stay home. I think that ultimately what will change because of vaccination is a duration of infectivity. So now we're saying 8 to 10 days in an otherwise normal host, but with a vaccination in play, I think that you're going to reduce that time. The question, and it's a big question on a lot of people's mind, is how long? Like, how long are you infectious when vaccinated compared to when not? So.
Right. And we'll be able to relax a bit the recommendations for asymptomatic close contacts. It'll be more of them being told to watch for symptoms, to monitor rather than to isolate.
Okay. Well, I mean, we are a little bit over time, but I would like to give the last word to Karen here, because this is also something that we see, especially within our hospitals. And so our severe immune suppressed patients had COVID, and then they shed it, but how long do we keep them on enhanced contact precautions? I mean, so this is an infection control question as well, but I mean, it's your patient population very much so.
Yeah, so I mean, someone at infection control may want to add some comments, but I mean, I think it's important to remember that when we talk about shedding, that typically we're monitoring or we're retesting, it's using a PCR assay that is not necessarily representing infectious or viable virus. We certainly do know that there have been cases described, and we've seen them here, where we've been able to culture virus long-term in very profoundly immune suppressed patients, particularly those who've had B-cell depletion or other severely immune compromised individuals. So In the community, where people have had more mild disease and will typically shed for shorter periods of time, we do not extend their isolation period. So it's routine, 10 days, whether you're being compromised or not. In hospital, we have extended it out to 21 days routinely in hospital. And then we actually, in Alberta, are then doing follow-up testing, recognizing that we will pick up people who are shedding non-viable virus longer, but as a safety measure while they're in hospital, if they remain in hospital beyond that 21 days.
Right. Long time, hey? Okay. All right. Well, I would like to extend my thanks, especially to you, Karen. Our guest speaker stayed right to the end. That's fantastic. And to Pierre and Jared, always great to hear you speak. And I believe John is around. This is kind of impromptu, but I'd like to give John a few minutes. But I want to extend my thanks to the speakers, to John's organization committee, definitely, as I've said earlier on, to Amanda Martin and her team behind the scenes. This has gone off fantastically, and I'm not sure what the final numbers were, but there was more than 2,500 people online earlier on today. So I'd like to say thanks for everyone who joined. The small bit of information would be, if you never, I would hope you've listened to me earlier on today, if you did not sign into Slido and you did not sign into our CPD unit to be able to get credits, you still can. Yeah, you probably can for another 5 or 6 minutes. I think the cutoff was actually at 4. I just see we had 2,654 participants today, which is a record by at least 500 from last year. So once again, thank you very much for everyone who joined on and for all the participants. And we will see everyone again, well, kind of see everyone. Hopefully there's going to be a more face-to-face option next year. But for the 26th Bug Day next year. And I don't see John online anymore. So I'll sign off and say thanks very much for everyone for tuning in.